Good morning, everybody. And I formally welcome you all to this rectal cancer update. When we conceptualized this update, we ran into a lot of troubles at multiple points. First, we were not getting a good venue. We decided to do this in Ram Manohar Lohia Hospital, which is an academic institute, but unfortunately, due to NEET, they had to take over that venue where the conference was. So then we did it in Lalit. Then G20 was a great problem, and then NMC rules. Somehow we have managed to steer ourselves through to this point. I really thank you all for being here. We would like to start in time, and as we all know that in our practice as GI surgeons and surgical oncologists, rectal cancer is some of the things which we very commonly encounter, and there is a lot of myth and aura still attached to this organ and the treatment. Though I feel that this is one of the organs after breast where the protocols of treatment are now pretty much set. And it is that we all have to spread the awareness among our colleagues. Yesterday, we had a very good session on radiology where Dr. Seema Sood and two younger colleagues gave us a capsule of how MRI should be read and how we can keep the radiologist on their toes. So it was a very good session. And today now we have Dr. Gina Brown, who is very well known to all of us. Unfortunately, she could not be here herself. This is a recorded lecture. I will request all the moderators and the chairperson to please come on the dais and please moderate this session. She's going to talk about imaging in rectal cancer, good, bad, and ugly. So the concept is that, sometimes, even a T2 tumor, maybe an ugly T2 tumor, which may require neoadjuvant treatment, and sometimes a T3 tumor may be a good T3 tumor and can be taken up for upfront surgery. So from that point of view, I think this is what we're going to hear to Dr. Gina Brown. Thank you.
Good morning, everyone, and thank you for inviting me to give you a talk about assessment of rectal cancer. And I'm sorry I can't be with you in person. The areas that I want to talk about are really about looking at imaging as a biomarker for recurrence and looking at how we assess patients after they've received preoperative treatment, and also what the current and future practice might be if we are staging patients with rectal cancer to perhaps avoid major surgery, for example. We often think about preoperative staging in a very simple way. We think about tumours that have a good prognosis, ones that have bad features, and then the absolute worst of all, the ones that are spreading into adjacent organs or beyond the mesorectal fascia. And in a way, it's a good starting point because, of course, it's important to identify patients who don't require preoperative treatment because they will be able to have either a local excision or primary surgery and avoid the possibility of overtreatment and the side effects of chemotherapy and radiotherapy, which can be very harmful in the long run. But for patients with poor prognostic features, we are increasingly seeing a move to giving more and more treatment before the patient comes to surgery. That has two implications. Firstly, that we mustn't overstage these tumours because otherwise we'll inadvertently be giving too much treatment to patients with good prognosis features. But secondly, that we need to understand how these patients have responded to those treatments. Do they still have a persistence of those poor risk features? Because if that's the case, then the surgery and indeed further treatment may have to be modified, as well as the surveillance of these patients at the end of their treatment. So these are the important aspects of not only using imaging to select the patients in the first place, but also to evaluate the response. When we first started out imaging was mainly used to look at the status of the CRM, which we can now do so accurately that it no longer is a risk factor, because you can avoid almost all instances and most examples of CRM involvement. And that's because not only can you give preoperative treatment and reduce the tumour distance to the mesorectal fascia, but also the surgery can be modified to avoid cutting through the tumour at the circumferential resection margin. So in a way, we can identify CRM, but we no longer accurately predict it, because the whole goal of the preoperative treatment strategy is to avoid a positive CRM. And what we showed previously and published in JCO a while ago now is that if you have a persistently positive CRM, then that's the survival disadvantage, increased rate of local recurrence as well. But actually, the numbers of patients who now have involved CRM at the end of treatment are much diminished. And now we would expect less than 5% of patients to have a positive circumferential resection. So that leaves us with other prognostic features that we have to deal with, because they are also risk factors for recurrence. And one of them is extramural venous invasion. At the end of chemoradiotherapy, if there is persistence of the MVI, it's a bad risk factor. But also the imaging detection of the MVI appears to be more accurate than that of pathology, mainly because it is easier for us to see and identify patients with vascular invasion. So we can see on the survival curve analysis that patients who have a persistently positive evidence of vascular invasion on their post-treatment scan have a significantly worse survival. And that we are seeing patients who are EMVI negative much more accurately than that of pathology. So this is a very useful biomarker for an ongoing risk of metastatic failure and for local recurrence. So why is that the case? And the logical explanation is that, in fact, the venous channels that drain the tumour within the pelvis and go to the lateral compartments, as well as the venous channels that find their way to the portal vein and indeed to the systemic circulation, are responsible for the development of metastatic disease as well as pelvic recurrence, and that this pathway of spread is the major cause of patients who do not survive cancer. So we need to really identify these patients accurately, and we also need to develop better ways of treating and dealing with extramural venous invasion. Otherwise, what happens is patients come back with distant metastatic spread. So that's what we want to avoid by disrupting the pathway of spread within the pelvis. So how do we do that? Main things, firstly, to identify these patients. So I always urge radiologists to stop looking at the lymph nodes, but instead look at the vessels and see if they are abnormal, if there are nodules of tumour that can be traced along the vessel pathway. And if that is the case, highlight these to the oncologists, and in particular the radiotherapy teams who can target these areas and can follow and track these vessels to where they're eventually traveling, in order to eliminate the risk of disease rooting and seeding within these areas, within these compartments, within the margin. So this is unwanted disease that cannot necessarily be controlled by surgery, but we are now very reliant on pelvic radiotherapy to deal with this, because it inevitably involves pathways of spread that the surgeon cannot reach and cannot effectively control, because it's following these small veins and vessels within the pelvis. So in a way, the hypothesis that we run with is that venous invasion is important, and actually lymph nodes may be part of the defense against venous invasion, and of course they can be malignant, but the significance of lymph node malignancy is not as great as the significance of tumor deposits or vascular spread, so tumor growing into veins. And what we notice is that sure, tumor will grow into veins and into lymph nodes, but it is the venous pathway that seems to matter the most. And we know this from comparing the clones of the lymph nodes with the metastasis and the clones of the primary tumor with the metastasis, and find that in 65% of patients who develop a metastasis, there is more of a match to the tumor, the primary tumor, than there is to the lymph node. And this means that the tumor is bypassing the lymph nodes and evading the lymphatic system in order to develop metastases, because it is doing so via the vascular hematogenous routes of spread. And there is pretty good proof of that the lymph nodes are not responsible for the metastases, because when we look at the lymph nodes on MRI in patients who are negative for vascular invasion and don't have any tumor deposits, we find that lymph nodes, in the absence of other risk factors, are associated with an improved disease-free survival. And in a way, that's not surprising, because enlarged and numerous lymph nodes have been known to be a good prognostic factor. So the combination of venous invasion and tumor deposits is far more important than measuring the size of lymph nodes, which does not give you good prognostic accuracy. So that illustrates well why we use the venous invasion and tumor deposits as our main staging criteria for preoperative treatment, because you see this fantastic separation of the survival curves that you simply do not see in patients where you're looking at just lymph nodes. So patients who have both vascular invasion and tumor deposits have a much, much worse survival than patients who have neither of those things, irrespective of their lymph node status. So when we are reassessing tumors after chemoradiotherapy, we often look to the pathologist as our gold standard. And there is a slight problem with that, because at what point can you really say that the imaging and the pathology truly match? So here's an example. This is a patient who had very adverse features. They had vascular invasion, and the tumor was extending to the mesorectal margin. And they received preoperative treatment. And you could say, when you scan this patient, well, that's not such a great response. I can still see the tumor, I can still see the vascular invasion, and that's not a good response. Now, if the surgery takes place 6 weeks later, at 12 weeks, which can happen, the pathologist says something completely different, because the tumor has gone from the endoluminal side and there's only a fibrotic nodule of treated tumor. So in a way, comparing our 6-week scan with the 12-week pathology is going to show us different things. And then if you wait another 18 months, as we did in this patient, you find that there's no viable tumor at all, that this is just a scar nodule and scar within the treated tumor bed. This patient ended up avoiding surgery altogether. So what we've noticed, and what we tested in the 6 versus 12 trial, is that this kind of downstaging beyond 6 weeks is quite a frequent thing, to the extent that patients who had their surgery after 12 weeks had a doubling of the complete response rate compared with patients who had surgery earlier on. And during that wait period, no treatment had been given. It was just a bit longer from the end of chemoradiotherapy. So what that means is that patients who are delayed surgery, as long as they're already responding, they seem to have far fewer adverse prognostic features. They have fewer rates, fewer events of vascular invasion. They have a higher rate of a good tumor regression response, and they also have more T downstaging. All of these are significant. And if you look at what that impact has, so if a patient has become EMBI negative, then there is a survival advantage compared with those who remain positive. So you're halving the risk of developing either a metastasis or an overall survival event. And similarly, the response to preoperative chemoradiotherapy seems to show an increase in the number of patients who have a complete response. So what we see that's prognostically relevant after chemoradiotherapy are these three things: the CRM status, whether or not there is persistence of vascular invasion, whether or not there is persistence of tumor deposits, and an overall regression grade in terms of how much residual tumor there is versus fibrosis. So these are the things that we should look at the end of treatment to judge the efficacy, but also to determine what further treatment the patient might need and what kind of surveillance they might need. So, for example, a patient who has a positive CRM at the end of treatment would need beyond TME surgery. A patient with persistent EMVI, well, they may need either further treatment or they may need very close surveillance to check for distant metastatic disease. And a patient with a good TRG response, well, perhaps in the future, we will be able to offer more of those patients watching. So at the moment, when we talk about a good MRTRG response, it doesn't guarantee that there isn't residual tumor. What we're really saying about this is that it is possible that there'll be no residual tumor, but also that maybe these tumors are not viable if we keep monitoring them. It's a very different thing to be able to predict pathological complete response compared with saying that the tumor is or isn't viable. And we propose that the TRG1 and 2 category tells us that the tumor may not be viable in the long run. So here's some examples. So this is a patient who was treated for a low-lying tumor. After treatment, there's just a scar. This patient could be offered watch and wait. What we find is that those patients with this kind of good response have a good survival outcome, and that we see this kind of good response in up to 40% of patients, which is a big number to see that kind of response rate. But it means to say that potentially in the future, these are the sort of patients who could avoid surgery altogether. So that's the sort of thing that's being proposed, and the OPRA trial, as everyone knows, showed organ preservation rates were higher than the complete response rates by giving the TNT. But what they did show was that there was a higher rate of sustained complete response in patients who received adjuvant consolidation radiotherapy. So there were fewer regrowths in patients who received chemoradiotherapy followed by consolidation chemotherapy rather than the other way around. And that's something we're going to be testing in the phase 3 trial called Trigger, where patients will have a control treatment of the usual either preoperative TNT or chemoradiotherapy. They will then have their surgery as planned and have their clinical follow-up. But the patients who have drawn the interventional arm, if they have a good response to treatment, they will be offered watch and wait. And the idea here is to compare the metastatic rates and the sort of quality of life and what happens with the patients between the control arm and the interventional arm, because there are some uncertainties about how useful or how accurate TRG is in identifying patients suitable for watch and wait. These patients ultimately get a disadvantage because they have a higher rate of metastatic disease, because you're looking at a tumor that hasn't completely disappeared, versus those patients who go and have their surgery irrespective of whether or not there's been a complete response. So this will be something that we can keep an eye on. So far, we have 45 patients with a good TRG, of which 21% have regrown, and the rest remain on surveillance. But what we want to know is ultimately in the larger series, as we increase our numbers, is if there is regrowth, is there associated disadvantage in terms of a more aggressive tumor, a tumor that is more likely to metastasize, surgery that may not be successful after regrowth? These are questions that at the moment we don't have answers to, because nobody has designed a trial to look at what the control arm patients would, how they would do in comparison. So in a way, we will be looking at what the value is of using MRI to select patients for watch and wait, but mainly to see if there is a disadvantage from a watch and wait approach, to end up with patients who cannot be salvaged, or patients who develop metastatic disease. It does rely on radiology expertise, and we've been training radiologists to look at TRG. Not everybody does brilliantly straight away, but we can train people and they can get up and do rather well. So the things that sort of take-home message really is both the baseline and the post-treatment assessment of prognostic markers is important. And when the EMVI status changes from positive to negative, or when the tumor deposit status changes from positive to negative, that gives the patient a prognostic advantage, and the patients do better who have reversed their status. It seems very much like chemoradiotherapy is the most effective way of reversing EMVI status, and it's also the most effective way of reducing CRM positivity. Patients who have lots of enlarged nodes, who are negative for EMVI and tumor deposits, seem to have a very good prognostic outlook, and it may reflect a very effective immune system on the part of the patient that is keeping the cancer from becoming aggressive. And we are also aware that tumor deposits is something that pathologists aren't very comfortable with always calling, and sometimes they will identify them as replaced lymph nodes rather than calling them tumor deposits. And the same happens with EMVI. And so working more closely with pathology on the imaging side is going to be very helpful in improving staging accuracy. MRTRG, which is the assessment of tumor regression, is quite an important tool, but we need to investigate more about how we can use this information to perhaps offer a watch and wait approach for patients after they've received chemoradiotherapy or indeed.
I think yeah, so be there. So I think we've pretty much covered most of the aspects surrounding MRI and uncovering these the good, bad, and ugly tumors. And I think it's very important for all of us to understand and interpret these imaging modalities and how we actually look at them from the standpoint of multimodality treatment of rectal cancer as a whole. The other thing is that one problem that plagues all of us is how we actually look at the MRI from a technical standpoint. See, MRI interpretation has got a lot of fallacies, because MRI is critically dependent upon the phase in which it is evaluated, how the radiologist looks at it. So there would be categories of radiologists who would be specially trained in reading these MRI reports versus a general radiologist. So our radiologists who are interpreting these images have to interpret these images with caution. The second thing is that MRI as a whole, see, rectum is a structure which curves left, right, and then anteroposteriorly as well. So again, it is very important to crucially interpret these images in various planes, and ideally the plane should be perpendicular to the rectum at all points. So rather than looking at the conventional sagittal, coronal, and axial planes, we should look at them in additional planes as well. These are things which are in the domain of our technicians that are there, but somehow these things are sometimes missed. So therefore, our technicians need to actually interpret these things in the light of these updates that are there. so that we can accurately interpret these images. Because unless and until you are imaging them in the right plane, then you are bound to miss these things because of partial volume effect that is there in the MRI. So the technicians have to be accustomed with these modalities and how we are looking at them from that standpoint.
Hello, as a clinician, I can make one comment to what you added. It's very important to have right sequences. And very often we see that unnecessary fat suppressed images which are not required. All we want is good T2. Of course, T1 can be there, but T2 axial, sagittal, and coronal planes. No contrast to be given, no rectal contrast to be given. It's very important. So Dr. Suprita Saklani and me, we have published a paper purposely in IGRI in 2015, which discusses about this protocol, because very often we see all over the country, the good images are not available, and a patient, and in fact, you can reduce the cost of MRI by doing only these sequences and nothing else. So it's, please go through that paper in 2015 about the rectal protocol, and so we can have very good images, so we can have better interpretation. Thank you so much. And of course, synoptic reporting is important.
So I'm a radiologist here. So I think exactly what we showed yesterday, you people have highlighted that it's very, very important to have the right planes, and we showed you how we should do it. And we are having people who are now being specialized and trained in specific fields. So you all must make sure that whenever you're getting any imaging done, make sure they're going to people who actually do this, because it's important. We now have a selective field for every kind of imaging. So you will have breast radiologists, you'll have rectal radiologists. So I think what you're saying is absolutely very important here.
So the take home message is that instead of having just a study, it should be a dedicated MR study. So that's what we are looking at.
Absolutely. I think we discussed this in great detail yesterday during the workshop. The importance of the MRI cannot be, overemphasized. It is something which is the basic, and it is a starting point. If you get this wrong, the whole treatment protocol is going to go haywire. So it is very, very important, as discussed, that people who know how to read MRI, people who know how to do an MRI are the people who should be sent our patients to. And there's no reason why, as surgeons and radiologists, we all cannot be trained in this particular specialty. We have to at least know that much, that we can stimulate our radiologist to give a right report.
Or any question from my question is to the radiologist. Madam, how do we, identify tumor deposits on MRI and which phase? And second, the extramural venous deposit, which she, mentioned. I don't find them in our reports. How can we improve and get these information on our MRIs?
So first of all, like ma'am mentioned, you must have non-fat saturated images, because we use the signal of the fat to contrast with the tumor to show you these things. So if the protocol is right, you will not go wrong. EMBI we see at the same signal as the primary tumor in an expanded vein. So you can see EMBI very well. It's a tubular kind of structure because it's a venous structure. So that is how we see it. To evaluate extranodal, deposits and not a node, sometimes it becomes difficult. But if you see a lesion which is irregular, not confining to the shape of a node, that is what we call as a deposit. And normally, if it's along a venous channel or a nerve channel, whatever you're looking at, we can say this is perineural spread or this is along the venous spread. So that is how we do it, because that is important to differentiate. It upstages the end stage if there is a tumor deposit. Yeah.
Thank you.
More questions are coming. One query to any of you. So since we are having interval after treatment 6 weeks or 8 weeks and 12 weeks, what's your experience and what you consider before deciding when to restage the patient? Any of you? Okay.
Yeah. So if First of all, I think it is most relevant in low rectal tumors. And if at 8 weeks, that's the timeline I use, the patient is having a near complete response, then we are tempted to follow this patient up again at 12 weeks to see if the patient goes into CR. But if there is a palpable lesion and if there is still MR evidence of disease at 8 weeks, gross disease, then I think it's better to go in for surgery. 12 weeks, yeah.
Experience every patient kept observation.
Yeah, yeah, madam will be. Thank you. Thank you.
Thank you.
For next session, I would like to invite Speaker Dr. Sanket Mehta sir, and next sets of chairperson on stage.
Yeah, after the wonderful first talk, we are moving to the second session that's on the real challenges beyond surgery. The first talk will be by Dr. Sanket Mehta, who's oncosurgeon from Mumbai. And he will be speaking on the elderly colorectal surgical patient, balancing functional and oncological outcomes. I think that's one of the real challenge which we face in clinical scenario, and Dr. Sanket Mehta will be discussing on that. Thank you.
Thank you. Thank you so much. Thank you, Dr. Deep Goel, for the invite. And it's wonderful to be here on this Saturday morning. This was a new topic for me as well. So as usual, the toughest part is getting the presentation going. And we're going to start with this topic and enumerating the challenges that we face in the elderly patients. Usually it involves a multidisciplinary management team. The comorbidities are a big challenge for most patients. The critical aspect is that this population is underrepresented in all the trials, which is why whenever we have intensification of treatment giving us better results, is it really true for the elderly population? We really don't have great answers except for retrospective studies. And the comprehensive geriatric assessment tools and the MPIs are labor intensive. We don't have many geriatric specialists. In Mumbai city, we have 2 of them in private practice. So you can imagine what it means, and which is why it is left to the clinicians to take decisions for the patients in their favor. If you look at the registry data, the SEER database shows that for every 5-year increase in the age above, for every 5-year increase in the age above 70, you have a 35% decrease in the mortality. Can we go back one slide? Okay. And the Swedish registry shows that above the age of 75, which is 42% of the population diagnosed with rectal cancer, they are less likely to undergo radiotherapy. They are less likely to undergo chemotherapy and less likely to undergo sphincter preservation. So you can imagine these are real world problems even in the developed countries and more so in our country as well. With the aging population, we are also going to face these situations. Now, this is a 80-year-old gentleman who had diabetes, hypertension, has 2 angioplasties done, early onset Alzheimer's, so is high risk for fall and has restricted mobility. His creatinine clearance is borderline. And with this MRI, where the tumor is starting at 5 centimeters from the anal verge with multiple nodes, what's the best strategy for him? Is it neoadjuvant long course radiotherapy, TNT? And if so, if we actually undergo all this treatment, does he go for a low anterior resection or a Hartmann's? And I think there are no right answers. It will be a discussion, but through this presentation, we'll try and get some idea of what would be the best strategy. Even in the non-comorbid elderly, there is a national Dutch registry which has shown that nearly 20% of the patients of the 60,000 patient registry data, there were 19% who were non-comorbid, fit, more than 75-year-olds, and their oncological resection rates were lesser than the less than 75-year-old population. Much lesser number underwent chemotherapy and even lesser number underwent radiotherapy. The mortality, in spite of this lesser treatment, was almost 4 times that of below 75 patients. And the relative survival hazard ratio was 0.8. So you can imagine that these are real problems, and which is why it is important that we take this seriously. The implications of all this means that whenever you have elderly patients, you can divide them into 4 groups in terms of treatment: surgery only, radiation only, neoadjuvant radiotherapy, and adjuvant radiotherapy. And you find that if we look at the 5-year cancer-specific survival results, patients who have received neoadjuvant chemoradiotherapy seem to have the best results at 70% 5-year survival, followed by adjuvant radiotherapy. And then comes surgery, and then comes only palliative radiotherapy. So it is essential that we put this in perspective when we are doing the decision making for our patients. This is, and if you see the PRODIGE 2 and ACCORD 12 data, patients who have received neoadjuvant chemoradiotherapy, patients with elderly population seem to have much higher rates of permanent stomas, lesser rates of radical surgery. But if we undergo the radical surgery, the R0 resection rates and the path CR rates are similar in the elderly population, and therefore they have similar outcomes. So it becomes imperative to give proper stage-specific treatment for elderly patients if it is possible. And that's why an individualized therapy plan for these patients is essential. Now, what is the role of short course radiotherapy? Short course radiotherapy would seem attractive because it decreases the duration of treatment and would appear simpler. But short course radiotherapy in this Dutch trial for patients above 75 years did not pan out well. There was no improvement in survival. There was much higher in complication rates, especially deep pelvic cavity infections and anastomotic leak rates. And the 6-monthly mortality was almost 4 times, which means that short course radiotherapy is a strict no for patients who are above 75 years of age. And again, if we look at the role of mesorectal excision, the role of elderly patients, sorry, let me just. So if we consider the role of local excision, can we do local excision for early tumors? And we have some data over this. We have a meta-analysis which shows that patients who undergo a local excision seem to have similar results for early T1 tumors. And there is, in fact, a meta-analysis of multiple studies which have shown that these patients do well, which is why low-risk tumors, moderately differentiated T1, less than 4 centimeters, no LVE, and node negative can undergo a transanal excision with good outcomes. With the ECOSOG and the CARTS trial, it might also be worthwhile considering this for patients who have undergone NACT-RT and keep the patient on close follow-up as well, although there is no specific data for patients above 75 years of age. What about the mode of surgery, whether we should go for laparoscopic surgery or open surgery? Patients who have who are above 75 have much higher ASA grades and Carlson comorbidity scores. But if they undergo a laparoscopic surgery, they seem to have similar results to younger patients, and therefore that should be the preferred mode of treatment, although the retrospective data shows that these patients are more likely to undergo a stoma. Stoma rates are higher, and there is one study which is a Dutch multicentric study which has shown that the patients who undergo sphincter preservation for lower rectal tumors seem to have poor continence rates and Wexner scores. But there are some other studies which have shown contrary results, so the debate is still on. I think more than the chronological age, the functional age of the patient is important in the assessment. It's also important that we discuss the issues of continence, especially with decreasing mobility of the patient as they age, and have some realistic expectations regarding what the patient will have after a low anterior section. Regarding adjuvant chemotherapy, there is data which shows that 5-FU and capecitabine-based chemotherapy seems to offer survival benefit for patients who deserve chemotherapy, but oxaliplatin does not. And there are multiple studies which have shown that oxaliplatin does not add to survival for patients above 75 years of age. So if at all there is chemotherapy, 5-FU leucovorin or capecitabine-based chemotherapy is what we are going to give these patients in the adjuvant setting. Regarding assessment of the patients, you can see these very complex scores. And I think it is about time with our aging population that we should have geriatric specialists to assess the patients and to, again, counsel the patients why their treatment is going to be slightly more complicated, and they need to have patients. The caregivers need to know what they are going in for when they are going for these patients' treatment, and that can probably simplify the expectations of the family in taking their treatment decisions. So to conclude, treatment of the elderly is a multimodality management. It involves discussion between the geriatric specialist, surgeon, medical oncologist, and radiotherapist to plan the treatment. It is important to assess their comorbidities and functional status, and also their overall life expectancy. Tolerance to standard of care treatment is often a problem, but if it is possible, that is the treatment that gives the best survival results, specifically related to cancer. And whenever possible, we should consider neoadjuvant radiotherapy followed by surgery as the treatment of choice. Thank you.
Thank you, Dr. Sanket, for nicely covering the important aspects which one should remember while dealing with these patients. Before I ask my question, do you have any questions from the audience? Yes.
Yes, sir.
That you said radiotherapy followed by surgery.
Yes, sir.
Is this the long-term radiotherapy? Because
Yes. Yeah. Yes. Yes. Long course radiotherapy. Yes.
Yeah, so you have nicely mentioned that it's not the chronological age which is important, but the functional or the biological, how the patient. So that's the most important factor. So in your practice, so when you see a patient coming probably around 77 or years, so what's your protocol you follow? I mean, you have given the evidence.
Yeah.
With respect to in the evaluation, for example, you want to do sphincter preservation. Do you do something different in an elderly patient compared to a patient maybe in 40s or 50s?
So I think for me, and I'm being very honest and candid about it, my counseling is more towards having a permanent stoma. because as the mobility decreases, the amount of difficulties that they face, especially with the caregivers and dependence on diapers and caretakers, it becomes increasingly difficult for the family as well as the patient to accept the Lar syndrome at that age. However, if the patient is desirous of sphincter preservation, I mean, who are we to deny? But my counseling would be more towards a permanent stoma.
Any objective way of counseling by, for example, do a manometry or so do
So I
you
think
incorporate those things or
no,
it's based on
so
the
I think there is a study from TMH which has shown that manometry does not correlate with sphincter function. And we have only one guy in who does manometry in our entire area. I have not seen very great correlation with the manometry results and outcomes. Yeah.
Age and the sex also needs to be taken into account. Women, multiparous, poor function, sphincter function, I think these are the people where we should actively counsel, as Sanket said, for permanent stoma. Obviously, they have to have a final say in the management and what option they want. But if surgeon is going to shy away from offering a permanent stoma, then obviously they've been denied an option which can be really probably a better quality of life than a stoma, than the preserving the function at that point of time. So I think as surgeons, we need to counsel more often in patients who are poor risk patients for having a poor quality of life.
I have one question to Dr. Sanket Mehta.
Yes, sir.
Thank you for your very good presentation. And because most of the patients are suffering from some comorbid disease and locally advanced, even with obstructive disease. Do you think that defunctioning ileostomy before doing any further proceedings is important?
So, sir, I think the decision for a defunctioning stoma remains the same irrespective of the age. The question really is that can we push these patients to go for neoadjuvant chemoradiotherapy, because that is the one that gives the best survival outcomes for these patients, or at least neoadjuvant radiotherapy. And for that, if a defunctioning stoma needs to be done, we have to do it. Yes, sir.
Sanket, good talk.
Thank you, sir.
Always enjoy your talks. Regarding manometry, it's something that I've always thought. Manometry does not actually tell you the sphincter status. You send them for manometry. If you don't do it, we send it to the AAG. They say all the values are perfect, so the patient develops a hope that you will preserve.
Yeah.
But if you inject water on a Foley's, they'll not be able to hold. So it becomes a problem like that. So we have stopped doing manometry.
Yeah. Thank you, sir. Thank you.
Yeah. Thank you.
Sanket, I think one of the most important thing is for elderly people is ileostomy. I think we tend to underestimate and we'll give them an ileostomy. The incidence of renal impairment in elderly patients is so high. It's not uncommon. You've done an LAR in ileostomy and 3 months down the line, you actually get the renal failure. So in fact, early stomach closures is okay. So I think colostomy is okay, but ileostomy for elderly patients, I tell you, you can have mortality for an operation.
I think thank you. We
Thank
are
you.
running short of time. So we had a very good discussion. Thank you, Dr. Sanket. So the next talk will be by Dr. Rajesh Gupta, who is the head of Department of Surgical Gastroenterology at PGI Chandigarh. He'll be speaking on survivorship after proctectomy for rectal cancer. What does it really look like?
Thank you, Kale. At the outset, I would like to thank Deep for this opportunity of this podium. And my brief is to talk on survivorship after proctectomy for rectal cancer. Why is this important? Because the patients after proctectomy are living longer and the diagnosis is also become more frequent. So we have a larger proportion of patients who have had proctectomy and are available for improving the quality of life. And also for these patients who survive this surgery, there is also important to understand how we need to follow up and what we need to follow in these patients. So survivorship, as we know, is not just about living longer, it is about living well. And that is what we need to address in this segment of patients now. So when we talk of improving the quality of life and improving survivorship, it means that we not only need to address the physical and emotional, but also the social challenges these patients face after surgery. And if we do all this in totality, then only we can assure a good quality of life for these survivors of surgery for rectal cancer. As we know, I mean, in this to this audience, just for the residents here, APR has been in use for rectal cancer since early 20th of century. However, in late 20th century and early part of this has laid more emphasis on function preserving surgery. So if we look at what are the function preserving surgeries, that includes high and low anterior resection as well as intersphincter resections. There is a problem and with these anal preserving surgeries, as I think Dr. Sanket has also elucidated, that we have to balance between oncological and functional outcomes. This because these surgeries are associated with both evacuative dysfunctions as well as degree of incontinence, and this incontinence can be to the liquid, to the gas, and evacuative symptoms can be because of urgency, frequency, and clustering of these symptoms. The internal sphincter resection though gives good oncological outcome, but we need to understand that many of these patients have the similar evacuative and incontinent functions following intersphincter dissections. So that is a challenge. So this is an image which shows what are the different planes of resection. For low anterior resection, anything up to 6 centimeter, and then mid rectum is from 6 to 12, and then 12 to 16 becomes high. And for APR, as you know, we have to go beyond this sphincter, while intersphincter is when you preserve the external sphincter, but you go between the planes. So this is important because this is how the functions of the patients post-operatively would vary based on these surgeries. So in survivors, what are the concerns? So I will be only looking at these concerns in these survivors. So obviously hospital stay is one thing which we all know would be dependent on the kind of surgery which is undertaken. But other than hospital stay are the short-term complications in these patients which are unique because of the patients who have received new adjuvant chemoradiotherapy. There could be infections and wound healing issues, not only because of the chemotherapy and the generalized immune suppression they may have, in addition to the comorbidities which contribute, but the radiotherapy itself can lead to delayed wound healing and wound dehiscence. There could be bowel complications initially in the post-operative period, which can present as ileus or anastomotic leakage, urinary complications in the form of retention and UTIs, and there is a risk of DVT and pulmonary embolism, more so in elderly patients than younger patients. So if we look at the recovery timeline in these patients, I would divide it in first 48 hours where we look at the hemodynamics of these patients, take care of the pain, and then gradually introduce these patients to liquid diet. So by the end of 1 week, we should have established a resumption to a regular diet. These patients should be walking and should be able to carry out light activities. When these patients reach a milestone of 2 to 4 weeks after surgery, they should come back for follow-up. We should look at surgical site, and that's the time when you look at the histopathology report and plan further treatment. 4 to 8 weeks later is the time when we plan gradual return of the patient to their normal routine, as well as that is also the time to introduce physical pelvic floor exercises so that these symptoms of bowel dysfunction are minimized. So these patients have various post-operative challenges. Is the time up? They have post-operative challenges which include physical, emotional, and social challenges. Physical challenges are largely because of the stoma which these patients get. There could be bowel functions, which are diarrhea, constipation, urgency, as I said. And then in addition, the pelvic floor dysfunctions and chronic pain that is common in some of these patients. So in addition to physical challenges, there are emotional issues because of anxiety, and that anxiety can be because of the uh, the risk of the complications which can ensue, and also the risk of recurrence which can occur in these patients. Those who do not handle it well can go into depression. The social challenges are also there, and that can be because of the altered body image. There are issues about the sexual functions, and then these patients who do not adapt well can go into isolation. We have various tools to look at the quality of life, and they can actually look at the what we have to see in these survivors is that fatigue, pain, and illness induced limitations are the ones which reduce the quality of life. And those patients who adapt them well actually are the ones who will present with good quality of life. So what are the factors which affect the survivorship? The most common is the type of surgery, as we have seen and is what discussed in the previous topic. The type and the extent of procedure, which means whether these patients undergo abdominoperineal or low anterior or intersphincter section. So there would be dependent on the procedure, different physical alterations, and then subsequent adjustment which will be required. It is good that today more and more sphincter sparing procedures are being performed, but we need to be cautious, as Dr. Sanket said, that in certain subgroup of patients, we probably have to upfront counsel for stoma. So the impact of these procedures on the quality of life must be discussed and talked to the patients. There are various studies, and they tell us whether they would tell us about a different procedure in different timeline, the outcomes in different set of patients. Like we see that in low anterior resection can have lower quality of life, or it can also have better quality of life in different set of patients, and these are all published in good journals. However, a recent report has shown that the most of the decline is in first 1 year of the illness, and after 2 years they actually achieve a similar functional as well as emotional outcomes. This paper, which came up from Japan, looked at the long-term quality of life, and they found that quality of life in patients who underwent annus preserving surgery was best in high anterior resection group, while in patients who had low anterior resection or APR did not show any difference. We cannot get away when we do annus preserving surgeries from the risk of anastomotic leak. It is an anathema, and it will always be there. It leads to increased hospital stay, increases the morbidity and mortality. It also leads to, as it was felt earlier, it affects the defecation and continence scores. However, subsequent studies have shown that anastomotic leak does have a short-term outcome, but in long-term outcome, the results are equivalent in patients who had and who did not have anastomotic leak. The other factor which can affect the quality of life in survivors after proctectomy is the neoadjuvant treatment. Chemotherapy, because of fatigue, nausea, neuropathy, hair loss, does have a stress on these survivors. Similarly, radiation, as I said, can lead to skin changes, fatigue, bowel symptoms, and this can impact the functioning of these survivors. The coexisting health conditions like elderly, the other comorbid conditions can also affect it. So these patients, when they come, they should have regular checkups. This means there is consistent monitoring for recurrence. I'm not going into the detail because of the timeline now, because of our time. And also, there are other cancers. These patients are no survival for a long time. So we need to screen for other cancers, and that's also important. How do we improve the survivorship experience? We have to adopt rehabilitation programs. We must institute pelvic floor exercises at the right time in these patients. And then there is a role of sport group. Some of those who are here And I think who listened to the story of this girl, Pratham, Pratham, yeah, Pratna. So I mean, that was very encouraging to hear from a girl, young girl, what is the role of that sport group in these survivors after proctectomy. So this is the last slide. What are the future directions? We need to, as Dr. Sankey said, the results of minimal invasive surgery are definitely better in terms of function and outcome. So we need to adopt more of these, like robotic and laparoscopic surgeries. We have to give them personalized, tailored surgeries depending upon the perception of the patient to the stoma and or to the preservation of this anus function. And we have to improve post-operative care, which means we have to improve the pain management techniques. We have to ensure comfort without having more reliance on opioids. Early mobilization strategies are important if we have to improve the quality of life. And then a comprehensive follow-up plan, as I said, is important for improving the survival quality in these patients. Thank you very much.
Thank you, sir. Thank you for highlighting that survival after proctectomy is not only about disease-free survival, but also regarding the quality of life. I think that's something very important. We should not focus just on the disease-free survival. So do you have any questions?
Actually, he has covered all the things with this disease profile, and now we have to follow the different protocol. And the important thing is the counseling with the patient and attendant before any surgical protocol to be executed in these patients for the sake of patient safety and management. So a lot of thanks to organizers. I would like to take the advantage as because here in this stage, I myself and my fellow colleague, Dr. Professor Sanaullah, we both of us come from Bangladesh. So a lot of thanks and my heartfelt thanks to Dr. Deep Goyal for giving us this opportunity to come over here. Thank you all.
For next session, I want to invite next set of chairpersons and speaker, Dr. Avanesh Saklani.
So let's start with the second session. And the first topic is very relevant and very interesting. The rising tide of a rectal cancer in young. And Dr. Avinash Saklani is here to have a discussion on that. So Dr.
Hi, good morning, everyone. So great to be here. Thankful to Dr. Deep Goyal and the Rectal Cancer Management team. Great topic, rectal cancer in the young. When I was 25, I thought I was young. Now I'm 45 and I still feel I'm young. But okay, let's talk about rectal cancer. So I think cancers in the young are increasing all over. In fact, it has been rising. Rectal cancers are rising by 1.8% per year for the last 25 years. And this is more common in 20 to 29. We see it more commonly in India because of the population demographics. So why do you want to study young cancers? Because we don't know. Normally you have a disease, you think there could be genetic factors, environment factors, and some other factors. So that would be called exposome. So, but if you have someone at the age of 15 And that is not genetic, that is the problem. So that is what is happening here. So exposome would be combination of both genetic factors, environmental factors, and now they say gut microbiome. So is it a different disease biology? We don't know. If the outcomes are going to be different, do we need different management strategies? So age alone, should we say we need to give some other treatment for this one? So that is what I think. There is a React collaborative group which we are a part of, and they looked at this patient. So normally, when you think young cancer, they should have HNPCC or MSI thing. So you get MSI testing done. And in this group, they looked at 4,000 young rectal cancers, 4,000 cancers, and of which 400 were rectal cancers, and 12% were MSI high. So these MSI patients who are high, they try to compare with MSI stable cancers. Let's see, was there any difference for these ones? So 10% is quite a high number. And they found those patients who were MSI high were hereditary cancers are more common. The stage at presentation in the Western world for MSI high young cancers was the same as the older one. But with response to therapy, is quite good for complete for after radiotherapy, about 40% complete response in the MSI high compared to this one. So that is an opportunity. So if you have a young cancer and it is MSI high, you give them neoadjuvant therapy, the complete response rate can be high. You can give TNT and you can avoid surgery for them. Most important, when you open on this young people, they're going to live for many years and they will live with disability, urinary and sexual dysfunction. So we should take this opportunity. We also know immunotherapy is available for these ones. So this is, we are looking at the Western world. I'll come to India. And with, if you have MSI high in young patient, the outcomes looks better, but stage for stage, not much different. So obviously there are a lot of factors. People have looked at molecular factors, genomic things and things, but it hasn't made any much difference in either management so far. So for young rectal cancers in the Western world, you would take it as 50. In India, I think median age probably at least in our institution is 47, so we take it as 45. We looked at 6 consecutive months of 350 colorectal cancer patients, and we found only 3% patients were MSI high. So dostarlimab, but not really appropriate. So we audit our results. We want to see whether we are improving survival or not. So we looked at our database 2013, 500 rectal cancer. In 2018, volume increases to 1,000 rectal cancers. And as you can see, over these 5 years, the incidence of young rectal cancers, at least in our institution, has gone up from 50% to 70%. And most of this increase is in low rectal cancer and PDACC. So it is rising, at least from this. Maybe we have got more popular and more young patients are coming, but we don't know. So we decided to do a multicentric study to about 3 years, 2016 to 18, to see what is happening. Unfortunately, I think we were the only ones, and maybe Somashekar who sent some data across as well. But we compared both young and old. Have you got a point? Oh, can't do this anyway. So we found about 1,400 rectal cancers over 3 years, and half of them were less than 45 years of age. So if you look at the median age of young patients was about 36. About 60% of these young patients were in the low rectal tumors. They look like bad biology. Poorly differentiated signet were more common in young patients. They were more advanced on T stage, N stage. However, metastatic disease was the same. So basically, they were presenting with more advanced stage. If you look at MRI also, the chances of these having all the negative factors, mesorectal fascia involvement, lateral nodes, EMBI, was all high in the younger group. Intent of treatment curative, we tend to give more chances to them. Stage-wise outcome, if you look at for these young cancers, for early cancers, young and old, there was no difference. But as you go to more advanced stages, the outcomes were poorer in the younger age group. If you looked at only curative option patients as well, again, the outcome was more or less the same. So when you saw a young patient, like if a 21-year-old with signet ring, you tried to give them neoadjuvant therapy. TNT was more common, almost 44% or so. They tended to default less actually because they wanted to complete treatment. Adjuvant was also given, but they didn't want any exenteration done, so the margin involvement was higher. So despite that, the overall survival before getting the excellent treatment there, the outcomes are still not good and survival is still lower. So when compared to the Western world, even for stage, for advanced cancers is relatively less. we won't go. This is a bit confusing thing. So if you look age alone as a factor and you masked everything else, T stage, N stage, MRF, EMVI, so age alone is not a predictive factor. So what it says is patients are coming at a late stage, and because they come with MRF involvement and lymph nodal involvement, outcome is poor. So you don't need to change the treatment. Why they have more signet cancers in young patients, that is what we don't know. If we can find the etiology for them and treat those pathologies, maybe outcomes can improve that way. So besides all this thing in survival, you have to look at other things. Sphincter preservation, yes, we do a lot of them and we need a supporting thing. Urinary and sexual functions we need to study. And females, so we forget fertility preservation. And it's important to audit. So we looked at our less than 60 years of age who underwent only TME, not APR or something. And almost 8% had severe erectile dysfunction. And almost 50% had some sort of sexual dysfunction. So it is an important problem. So talking to them and discussing how to improve on this is an important thing because these people are going to live for 40, 50 years if they survive 5 years. Other thing, if you look at females, we are not only looking at if they got 2 children and you can take the ovaries out and radiate the ablation. Having normal menses and sexual function is also very important. So we did lap ovarian transposition in young females and we found that 66% had resumption of menses. So it is very important. I saw one female, we had done an APR about 5 years back and she looked awesome, good sexual activity. We also looked at a survival itself. So we see a lot of young patients change in policies, do high pack excentrations. And from 2000 to 13-18 consent, we saw that 5-year survival from the 2013 cohort had improved from 39% to 66% over 5 years. And this is because of multidisciplinary team management and meetings like this. Getting took across, if you had 10 years backline and if someone asked for an MRI and someone would debate it, we no longer debate it. We no longer debate whether you should do laparoscopy or robotic. We also don't debate whether you're going to do excitation. And that is because of meetings like this. And a slow and gradual movements produce earthquakes. So very good. So take on younger patients have a poor outcome because they can present as an advanced stage. Poorly differentiated tumors, why is it more common in young age? We don't know. But we have to work on that. We are working on animal-like models on signet cancers. And it seems to me that irinotecan and paclitaxel works well on this line. So we are doing a phase 2 study to see or if can work on these sort of tumors there. And meetings like this are pretty good for this. We also have to look at functional outcomes and quality of life. Age itself will not change your management. So just because your young patient has come, should you give them TNT? Not really, because there is no data based on this. Advanced stage, and we don't know how we can prevent the disease because the causative action is not low. So a lot more needs to be done. People from academic centers, from JIPMER and admin, we can work on it. Thank you very much.
Oh, thank you, Dr. Avnish Saklani. What the study is showing that in 70% of the cases of rectal cancer in a young is sporadic.
That's right.
Okay.
More than that, yeah.
And we are also getting a lot of cases of younger rectal cancer in a younger population. Is there any impact of lifestyle or something else?
But that's what I said, exposure. Normally, you would have a long exposure to sort of, you think the metabolic syndrome will be there, obesity and diet and all. But sometimes if you have someone at age of 19 and they are MSI stable, so there may be another factors. Maybe in utero exposure to antibiotics itself may be causing them, but we don't have much data so far. So everything is short studied.
And hereditary cause is also playing a very least role, isn't it?
That's right.
So there are so many other factors. So, and overall the prognosis of a young patient of rectal cancer is poor. So again, despite of giving the new adjuvant therapy.
That's right. It depends on the stage. For young cancers, I think it's still quite good.
And the signet ring carcinoma, that is there. So why only the signet ring has a poor prognosis and that is common in a younger, that is again the area of research. I think. Yes. Thank you. House is open for the discussions. Yes.
What we have seen, the younger age group people who are having rectal cancer are not from high socioeconomic status. Most of them are from a low socioeconomic. status. That's just an observation. I have absolutely no, I don't know whether it is
That's
echoed
true.
by
But
others.
I think, yeah, I think probably infection and repeated chronic inflammation can cause that. And gut microbiome may be playing an important role there. So there is a role for research in this. So I think you're sure.
Sir, sir, MSI high tumors, as we know that chemotherapy, it will not have much response. So, sir, any data on incorporating immunotherapy in neoadjuvant setting? Any work is going on, or
You see, most of the data on MSI is mainly for colon and for stage. So stage
In
3, you still give chemotherapy, oxaliplatin. You may not give in stage 2, just 5-FU alone. So most of these we are looking at locally advanced stage 3 sort of thing. So we still give chemotherapy itself.
Dr. Vinash, yeah, thank you so much. Very nice overview. Stage by stage, do you kind of observe or maintain a different protocol for these patients as compared to adults? Anywhere, any incidents or something like that?
For age, we don't do, I think, but for Signet, we try to compare long course chemoradiation versus short course and consolidation chemotherapy. We didn't find any difference in DFS, but metastatic rates were slightly lower. So, but not much different.
Protocol remains the same.
Protocol is almost the same.
Most of the center has not facilities for the genetic study or germline mutations. So that is again the area where we have to.
Yes, I think we have a genetic department. Dr. Rajiv Suryan is looking into this. So as we said, we looked at MSI thing. So MSI high are only 3%. So 97% do not have any genetic link. But we are looking at other rare sources of mutation. So that is all samples are collected and all. So we are finding a lot of variation, but nothing that we can pinpoint. And whether it will change the management itself is not known. So sometimes investing in all those things which are very expensive, but will neither change the outcome nor the management may be difficult. Maybe we should leave it for the Western world.
Thank you very much.
Sir, any difference in the upfront, metastatic disease in young versus the elderly population? Like people coming up with M1 disease more in the young age group, any differences?
I think the stage 4 metastatic rate in both young and old were almost the same. But because the incidence of signet ring is higher in the young, the incidence of peritoneal mets is higher in younger people. So I think even after neoadjuvant therapy, sometimes it is prudent to put in a scope and see how things are. Thank you very much.
Thanks, Dr. Klani, for nice presentation. First of all, I convey my sincere thanks to organizing committee and Dr. Deep Goyal for giving us the honor. May I now invite Dr. Deep Goyal for the topic splenic flexor mobilization and its effect on anastomosis. Dr. Deep.
Can I have my screen, please? Yeah. Good morning, everybody, and welcome once again. As we all know that, leak in the low rectal cancer surgery is the Achilles heel of anastomosis. And we all know there's a lot of controversy in myth and aura around splenic flexure mobilization. It is required for a tension-free anastomosis in low anterior section. How often and how much is the question. This is one of the cadaver study which said that if you do not mobilize the splenic flexure, the length of the descending colon is around 45 to 46 centimeter. And if you do partial mobilization, you gain around 11 centimeter. And if you mobilize the splenic flexure completely, you gain up to 40 centimeter. This was a cadaver study. Another study said that if you completely mobilize the splenic flexure, you gain around 27 to 28 centimeter of extra length of the left side of the colon. This is the vascular supply of the colon. We must know that, marginal artery is almost always present. Sorry. Marginal artery is always present. An arc of Rayleigh is present only in 1/3 of cases. And this must be taken into consideration while you are making an anastomosis, while you have to decide the proximal resection line of the colon. Because if there is an adequate blood supply, then maybe you do not need to mobilize the splenic flexure completely, because a lot of time you need to mobilize because you think that remaining part of the descending colon may not be vascular enough for the anastomosis. Another slide, this is just showing the type of vascular arcade in the left colon. If you see the left branch of the middle colic artery, it has a lot of variation. The commonest is that it comes from a common trunk from the inferior mesenteric artery, and that common trunk gives right and left MCA. And the second common thing is type 3, where you see that MCA and an accessory middle colic artery comes directly from the inferior mesenteric, superior mesenteric artery. And these are important because they will make your left side much more in vascular supply. So you can probably avoid doing splenic flexion mobilization completely. Type 4 and type 2, again, there are different variations. So it is important to know these variations. Another important point is artery of Moskowitz. Sorry, what is artery of Moskowitz? It's a branch from the superior mesenteric artery, which is joining the left colic ascending artery branch. And why it is important? If you have arc of Rayleigh, then what happens is your distance from the interior surface of the pancreas to the marginal artery is much more. These points are important to remember, because while you are doing splenic flexion mobilization, you have to be aware what all vessels are going to come while you are mobilizing it. If arc of Rayleigh is present, then the distance between the arcade and the anterior surface of the pancreas reduces to 4.5 centimeter. And if artery of Mikowicz is present, then this is less than a centimeter. So you are likely to cause torrential hemorrhage if artery of Mikowicz is present and you are not careful while mobilizing the splenic flexion, and then it will jeopardize your vascularity of the left colon. So it is important. These are the three different approaches of splenic flexion mobilization: supracolic, infracolic, and lateral to medial. Depending upon, again, how much mobilization is required, you will choose which all method to be applied. A lot of time, splenic flexion mobilization can be complex and challenging, and there is a steep learning curve. That is why we normally do not want to do it in every patient. One has to understand the anatomy, especially vascular anatomy and the embryology, and it should be done routinely or not. Again, it's still debatable, and I will leave it to the choice of individual. People who are proponent of splenic flexion mobilization will give various reasons that it will prevent leakage, it will prevent anastomotic stricture, you can get more R0 resection margins, there can be less local recurrence, post-op bleeding and SSI are lesser, and chances of reoperation are lesser. But if you take into account everything overall, you are likely to increase the operating time if you do complete splenic flexion mobilization. There is evidence to suggest that if you are not well trained and you are not doing it routinely, you are likely to cause more intra-op and post-op complications. So one has to be really clear in their mind in which particular case it is required, and you should be aware of anatomy, embryology, and technical skills. So there is a lot of knowledge gap in this particular field, whether it should be done or not should be done. Body topographies may be an indicator for difficult splenic flexion mobilization. Whenever you're doing an MRI, CT scan, especially CT angio, you have to take into account the anatomy, especially the vascular anatomy. And people who have a higher BMI, higher weight, higher height, the difficulty level is higher. And in men, the splenic flexure is likely to be away from the midline and higher. So it makes it much more difficult as compared to women. This is a small video of case where we are doing a robotic low anterior section. And these are the different methods being shown in this particular video. This is the dissection between the mesocolon and the retroperitoneum. You can see the difference in the fat. You can see fascia of Todd, the white line. Traction, counter traction, as we all know. And soon you're going to see the pancreatic tissue here. That's the mesocolon and the gyrotous fascia down, differentiation. Either you can go into the lesser sac from medial to lateral, or you can open these both spaces separately and then join them. That again will depend upon your expertise and the habitus of the patient. What is the BMI? How much visceral fat is there? Clipping of the IMV right at the origin, just close to the DJ. And once you do that, you will directly come to anterior surface of the pancreas. and gently you have to go on the anterior surface of the pancreas, behind the colon, going up till you find the spleen in this area. And as I was telling you, once you open this, you are into the lesser sac. So this was the infracolic approach leading to mesocolic, supramesocolic area. But you can approach these both spaces separately. And then coming to the lateral to medial dissection. Another important point which comes during discussion is at what stage of surgery you should choose or you should do splenic flexure mobilization. We normally tend to do it in early part when we are doing the inferior mesenteric pedicle ligation, because once you have realized that you will require dissection and mobilization of the splenic flexure, it is better to do it at that time, because once you have, mentally you think that you have finished the surgery, you're now ready to do anastomosis, and you find that your descending colon is not coming down, it can be a lot of disappointment, and you are already probably tired by then. So it's better to do that. It's another video, I think I will skip that. So there can be certain set of complications which you can encounter, like splenic laceration because of various ligaments which you dissect, gastric injuries, pancreatic leaks, pancreatitis, duodenal injury, vascular injury, and renal injury. One has to be careful and one has to be very efficient in doing these procedures. Again, I think this we have discussed when to mobilize. In literature, also it favors that we should mobilize in the early part of the procedure. Well, this is something I found. It's a very nice book by Stephen Howard, How to Go from Mindful to Mindful Leadership. And whenever you're making important decisions in the surgery, if you make better decisions after thinking rationally, it will lead to better outcomes. Thank you very much.
Thanks, Dr. Deep, for nice presentation and demonstration. The house is open for questions.
Yeah, nice talk.
Thank you.
Two comments. I think we also need to emphasize that splenic flexure mobilization should be combined with ligation of the IMA proximal to the left to have the complete benefit of the mobilization, because otherwise you mobilize and then
restricted.
At that point you will have the pedicle restricting the mobility of the vessel. Also, another comment is you mentioned about that accessory middle colic. It's there in because when we actually critically look, you'll be able to see it. We also observed that it actually gives one branch to the pancreas in some patients. So while doing that medial to lateral mobilization, we need to be careful to ligate only the pancreatic branch. Otherwise, we might accidentally injure the
Absolutely
middle colic, and that will affect it. Nice talk. Thank you. Enjoy.
I don't know what is the practice in other institutes, but if patient is coming to us without a CT scan and we are ordering the CT scan, we always order a CT angio or a triphagic CT where we can see the vascularity. We obviously don't, if patient already carrying a CT scan, we don't ask him to do it again. But if we are the one ordering, we always order that way.
Any other query, any questions?
Yeah, thank you, Dr. Deep. With the advent of robotics now, obviously many people would probably, as a rule, mobilize the splenic flexure first. When it was laparoscopic, half of the people would do it the other way. I do it the other way. The problem is that you have to change the positions. Surgeon many a times will have to come
in between legs.
In between the legs. So you have to have the monitor on both the sides for the assistants also. So it was very cumbersome. We started with that strategy to do it later, after resection, after annual placement, after closing the abdomen. We continue with that till date. And I'm not sure what the experience, I mean, the literature says differently, but what percentage of your total rectal resections require splenic flexure mobilization?
So if you have to answer that question in generality, that some form of splenic flexure mobilization in almost all cases. When I say splenic flexure mobilization, so as you said very rightly, when you're doing laparoscopy, As much as we can do is standing in the same position, we do that. And lateral mobilization is very easy. We do it as far as we can do it in same position. Most of the times you can get away with that. But yes, I would think around 20% of cases, around 20% is in cases.
Yeah, maybe
1/5.
10, 20.
Yes, thank you, Dr. Deep Goyal, and nice presentation. As far as our experience, I think Rajesh, and I'm agreeing with Rajesh that less than 10% we require the total mobilization.
And you know in which patients, since the number is so less, I think that it makes sense as what you're saying is that you take that decision later on, that if it is required, we'll mobilize.
And sometimes, I mean, I am not aware of any standardized procedure which can tell you to begin with whether it will be
required or not required.
Because if you start following that universal protocol of mobilizing it, you will not probably come to know as to how many actually needed.
So what we think after reading the literature in West and in India, the difference is that we have a lot of redundant sigmoid colon. So probably it is required lesser time as compared to what is quoted in literature. And that's why they probably do it much early. So now with experience, we also come to know that whether in this it will be required or not required most of the times. But we tend to do some form of splenic flexure mobilization in all cases, which is done easily standing in the same position if you're doing laparoscopically.
Is there any studies which has shown that complete splenic flexion mobilization is important, and the leak will be more if we are not?
No, sir. So the endpoint is a tension-free anastomosis.
Exactly.
If you at any point of time feel that you will not be able to do a tension-free anastomosis, you need to mobilize splenic flexure as far as possible, which will give you tension-free anastomosis. So it is not the splenic flexure mobilization which is important. It is to achieve a tension-free anastomosis.
Exactly.
So the leak rate, if they are less or more, whatever it is because of the tension-free or tension-less anastomosis rather than because of the mobilization of the splenic flexure.
Okay, thank you.
Yes, please.
I think as a beginner, we tend to err on the side of more splenic flexure mobilization because we're worried about tension on the anastomosis. Is there any concern of having more redundant colon? Would that have any detrimental effect? If we were
not really. The more the redundant colon, the better for us, as long as it is properly vascularized. So the more redundant colon, you have to be careful about making sure that if you're saving that colon, it is properly vascularized.
My doubt is if we have too much of redundant colon, would it cause defecation and constipation later on? Defecation issues.
If it was not causing in the original person, then it is unlikely it will cause, and now you are taking away the rectum also.
Thank you.
Thank you.
It's a time for a short tea break. We will continue after.
Sir.
Thank you for everything.
Very good troubling you guys with this.
So delegates and faculties, kindly assemble for the next session. Delegates and faculties, kindly assemble for the next session.
For next session, I invite the next set of chairperson and speaker, Dr. Venkatesh Manikrishnan, sir.
So we are back now. Now we'll have in this session we'll have a keynote lecture, and that will be by Dr. Venkatesh Krishnan from Apollo Chennai, and he'll be speaking on laparoscopic LAR, ultra low anterior section, ISR, a standardized teaching model.
Thank you, Deep, for inviting me. So I've been asked to speak on standardization of robotic rectal cancer surgery. So the question is, why do we standardize any operation, robotic lap open? One, so that it makes the operation easier. Two, we avoid complications. Three, we get the excellent outcomes we want for our patients. And four, it is a cost-effective program which is scalable so that a program goes and grows and we have more people adopting it. So let's look at how do we standardize it and what we have done in our experience and how we can achieve the outcomes which we want. So just looking at what is the evidence for rectal cancer with minimal invasive surgery, particularly robotics, we know that it's got a longer operative time, similar oncological outcomes, shorter length of stay, lower risk of conversion to open, but at a higher cost. So with these, what are the challenges we're going to face when we want to standardize robotic colorectal surgery, in particular rectal cancer surgery? The challenges would be, how do we reduce operating time? How do we get better surgical outcomes? How can we reduce length of stay and readmission rates, cost? And how can we standardize and have a scalable robotic colorectal surgery program? So I'm going to be sharing some of our experiences, how we've done this standardization. When you start off, obviously we start off with the patient. I'm not going to go into how we diagnose CES because that's pretty much out there, and I'm sure other people are speaking about it. But the most important thing I would like to highlight is the MDT discussion, which I think gives you a platform where you could discuss your patients and have an agreed way of managing whether you want to do preoperative chemorad, TNT, upfront surgery, whichever you want to decide for your patient. Then comes the surgeon. And I think that's again a very important factor. And there is enough evidence in the last 2-3 decades that subspecialization is the way forward. The more you do, you're better at it. You get higher volumes, you have better outcomes, you have better disease-free survival and overall survival, and you do more reconstructive procedures and less permanent stroma. All the data evidence has been there for the last couple of decades. And then comes standardization of the procedure itself. Looking at what we do and based on evidence, this is what we adopted. We have a admission day prior to surgery, bowel prep for reconstructive procedures, any left-sided resections, LARs, APR, not APRs, APR just get enemas, and the right-sided resections get 2 enemas. Epidurals for APR because of the perineal wound. We have a Ryle's tube during procedure so that the stomach's not dilated, and the catheter in the first 24 to 36 hours. The procedure posted for the first procedure of the day. So that's what I think that works very well for us, and I think it should work for most of us. If you want to start off, particularly when you're in your early part of the learning curve, you want to post first so that you're not following another person because they may have a challenging case. You want more time. You want to, so even if it's posted at 6, I would get into theater by 4:35, get your team there, take your time to set up. And as the experience grows, you will see that you'll get faster and then you'll save some time. And having dedicated robotic theater and theater staff, so routinely wheel in at 5:30. Now these days I'm wheeling in at 4 o'clock because I want to be done before the hospital wakes up. So there's no disturbance. There's nothing to, unless we need frozen sections and things, which is not a big part of my practice. The robotic platform itself, we know that the high definition camera is under surgeon control. In our practice, we use 2 arms only. We don't use a third arm. That again is very flexible. You could use one of your fellows to retract or use a third arm, but I routinely use a monopolar hot shears on my right hand and a fenestrated bipolar grasper on the left. And I keep my third arm tucked away unless I don't have a fellow or I want to use it. And retraction using a standard bowel grasper or a suture traction, which I will show. I routinely use a smoke evacuate. I think makes a big difference, particularly for rectal cancers, low rectal resections. It maintains a pneumoperineum smoke evacuate at the same time, works a treat. Our patients are set up routinely with a steep head down, sandbag into the pelvis to break the pelvis so that the small bowel is tucked up higher up in the abdomen and slightly rolled towards the right. This is my routine port placements, three ports for the robot. The camera port is 1 inch to the right and above the umbilicus, and then a right port for the monopolar hot shears and the left port for a fenestrated bipolar grasper. And then I have my air seal port on the left side through which where you can have your third third arm come in to assist, or a fellow can put in a Johans retractor to retract the bowel, and a 12mm assist port. I don't routinely use suction because it sucks the gas, although I have a smoke evacuator and an air seal device, but I just use swabs, like something like tonsil swabs, so that just to dab any blood or fluid, because it just saves time on swapping instruments. This is my bedside team setup. As you can see, the orange arrow shows our arm tucked away. You can use it depending on, again, this is because we developed a standardized procedure, which is cost effective. And I'll show you the data to support that. And at the end, this setup, you should have an empty pelvis where you have your 2 instruments and ready to start the procedure. And I think once you achieve this day in, day out, I think it becomes, as you can see, my assistant is holding that with a Johans retractor, but you could get the third arm to come and grasper to do the same. So you just have that flexibility so that you don't think about how I'm using 4 instruments, 5 instruments cost. Just get the program going, standardize it, and you can do whatever you want. So you can see I've tucked my small swab at the root of the mesentery so that you can use to dab. So then we start off with making the incision, on the peritoneum, letting the gas in, opens up the planes. Obviously the robot gives you much nicer pictures, stable pictures. I'm sure good high definition lab stacks do the same. But again, you could drop the nerves, use the articulation of the instruments to dissect around the vessels. We use standard lap Hemlocks, Hemlock applicator to apply the Hemlocks for the vessels. I've always used it. There are robotic instruments available. It just adds to the cost. These are cheap enough and it's very controllable. And so my view is when you're standardizing a procedure, use the for particular robotics, use the robot for what it really does, fine dissection, deepen the pelvis, and good vision. Retracting, applying clips can all be done with standard lap instruments. And then so you start to develop the medial to lateral plane. You drop the ureter, you drop the gonadal vessels, and you go do a medial to lateral dissection. And then this will bring you on top of the TME plane, where you see the angel hair fibers beautifully described by Professor Bill Heald. And then when you see it, you're in a good plane. I think take your time to do that bit of the operation, getting the vessels medial to lateral, because that's the key to a rectal cancer resection. And once you get that, rest of the operation is I think much easier than a right hemicolectomy. But then I'm biased. So the other thing which I do is either early on or when I'm just reaching up to the peritoneal fold is to put a pelvic peritoneal suture to lift it up, because that again, that's what you use a robotic arm to lift that peritoneum up, or an instrument. That suture keeps that peritoneum hiked up so that your anterior dissection is easier. And or you can, if it's a female, you can put the suture through the uterus to hike it up again. And so that is stable and set. So that's these are little things which you can standardize, which will make your operation easier. Then the steps of the TME. So we do a posterior dissection to the pelvic floor, then a right dissection, left dissection, anterior dissection, and intersphincteric as required. So now that we've done the vessels, medial lateral, we can start doing the TME. And I think the key is using your left arm. The entire operation is based on your left arm, whether it's lap or robotic, giving that traction. I think it takes a little bit of time to get used to the force these robotic arms and instruments will exert. You will get used to. Just start off slow, take your time. But once you start using it effectively, you can see it just opens up that plane, and those angel hair fibers, it's there everywhere, and you need to keep watching for them. And once you see them, you are in the plane, and you keep developing the plane, and use your tip of your right instrument, which is the monopolar hot shears. In our program, we use it like a paintbrush, just to use the tip, stretch, dissect, stretch, see the fibers, and sharp dissection, and you will have a beautiful bloodless field. Even if it's post chemo edematous, you will still see it. You just need to develop that gentle plane. And when there's a lot of edema, I use the swabs to just dab. I leave them for 5 to 10 seconds. It just absorbs all the fluid further up in the dissection planes. Really helps. And so just keep moving down. Use the left wristed joints to lift up that the back of the mesorectum, so that stretches there. You can develop that plane. It becomes such a nice operation. The more you do, you'll start enjoying it. But as you can see now, I'm on the left lateral wall. Again, stretch, dissect, keep moving down. And this is getting down to the pelvic floor. Again, it's another patient. Keep moving down. You can see the angel hair fibers are there to guide you, and it's like a cheat note. It's there always. So whenever you're in trouble, just go back to healthy tissue, find that angel hair fibers, and then get into plane, and it just becomes a enjoyable operation. Ideally, you should put on your favorite music. It really helps, and then it becomes enjoyable, and you will standardize that in your head too. So again, traction, counter traction. Just be aware, because when you're in the early part of your learning curve, the traction of the left arm, you can rip things, and when you have a post chemo mesorectum, it can bleed easily also, and then there's blood there, and you just dab. You have bipolar grasp in left arm, just diathermy it, and and that's the great advantage, because compared to laparoscopy, where you have to change instruments, with robotics, you can use the bipolar grasper to keep the plane free. So you can see we're developing the right lateral angel hair fibers. Just keep that in mind, and then the operation is just so much easier. And then release the the attachments on the pelvic peritoneum on the right side, and then you can do it on the left side. This is obviously speeded up at 4 times. I'm no way as fast as this. Maybe Avanish is. He's always fast. And so you've already done your medial lateral, and you can see, now you can see you've done so much dissection because you've gone all the way to the pelvic floor. The posterior dissection is the most key, and and then you release the right peritoneum, and then you do the left. So much more easier, and you just basically unzip that peritoneal attachment right up to where the pelvic peritoneal fold is. So I used to transect the bowel or put a loop. It just made it bloody. Used to, right, left. It just made the rectums wobbly. And then this is much more controlled, stable, posterior, right, left, anterior. And I would highly recommend it. I picked it up from Amjad Parvez from the UK. And so what we do is we score the pelvic peritoneum about maybe 4 or 5 centimeters just over the fold. And then you can start to see the non-villus. So the important thing to remember when you're doing anti-dissection is the fat stays on the rectum, right? Fat stays on the rectum. And when you are not in the plane, you just go laterally, the mesorectum, then come back medially, either side. And so whenever I get confused, particularly post-chemo, when it's all stuck, you go laterally, come back into anteriorly. So this is another patient just doing that. You can see how that hike really helps to open up that plane for you. And then again, angel hair fibers. So it's an easy operation. We just need to, get that worked in our head. So anteriorly, again, between the denon and the fat on the rectum, you would see that again, the angel hair fibers. So it's there to guide you. If you're seeing rectum at this point, that means you've gone deeper. You need to come out. And if you're starting to see the prostate and then you have gone one deep onto the denon. So just maintain that, and you will sometimes it will happen when it's stuck. So you go laterally on either side, find the mesorectum fat, and then come back onto it, and always works. So stretch, counter stretch. You can get your assistant to come and help you further if you need, or you can put a robotic arm there. Again, stretch. You'll see the angel hair fibers all the way up to the when you have to cone onto the rectum. So again, if there is a bleed like that, use your bipolar grasper on your left. So that's the advantage with these advanced systems. So I'm just going to flip to the next one. So you can see the pelvic floor showing up over there. Traction, counter traction. Again, you can see there is fat there, which is in the anterolateral wall, on the pelvic floor. So you don't take that, because that beyond that are the nerves. We call that the pelvic tonsils. Leave that fat there. You can see a nice angel hair fibers between that and the mesorectum. So that's where you need to stay. And you can see when you hit the pelvic floor muscles, they'll start to twitch, and you can carry it. And the great advantage is the pictures are stable. With the air seal device, you can see great views right up to the pelvic floor. And you can see you just getting into the intersphincteric space there. Okay, so then what else do we have? So we didn't have these stapling devices until end of last year. So we started using them. No way going back to traditional staplers anymore. It is just such a superb device. Expensive, but I think with, on overall, I think it adds about 35-40K to use the instrument, and then 7,000-8,000 per fire. If it will work out to similar costs, maybe 10,000-15,000 more, but I think stapling becomes under your control rather than assistant, or you have to descrub from then and go do that. It used to be a struggle. Now it is brilliant. So if it is upper rectum, sigmoid, upper rectum, mid rectum, you can get nice transverse fire, as in this case. But if it is low, ultra low, ideally you should go 12-6. You can go really down because you struggle to get a 45 in a narrow male pelvis. So you go all the way, push it down like the picture I've showed you here. So go down and 12 o'clock to 6 o'clock on fire. You may have to do 2 or 3 fires depending on how wide the rectum is. So once you go and clamp and then you press the blue pedal, it says clamped and ready to fire. And then you press the yellow pedal, it fires. It keeps assessing. It sends about 1,000 measurements per second or something to the system, and it will give you a feedback if the tissue is too thick or less, and then you can readjust accordingly. Very controlled. You get a nice straight staple line, ideal for rectums. And you can see at the bottom of the screen it says clamping down there. And it's ready to fire, and then you press the yellow pedal. So it gives a countdown and then it fires. And it unclamps on itself, so you don't have to do anything. It's just done. So much more smoother. When the bowel is dilated or wider, you may have to do 2 or 3, and it can be a challenge. And avoiding dog ears, I think, is important. But when you have the staple under your control, and I'll show you. So if you look at this data, this is when we started using it. We were able to do more than 45 degree angulation with the robotic staplers, because that was not achievable with standard lap staplers. And I think that's where it has impacted in our little subset of patients, 55% of those fires. So it will help you to get a nice transverse fire, less number of staple uses as well. So if you're doing intersphincteric, you can take it even further down, get into the intersphincteric plane. So I'm just going to skip that because I think we've seen that. So if you do, if you're doing intersphincteric or coloanal anastomosis, you do a transanal intersphincteric dissection using a Lone Star retractor, and then you deliver the bowel and then transect and do a coloanal anastomosis. Obviously, you can use Firefly to make sure that your bowel is well vascular. Or when you look at it, traditionally you just cut the bowel and see if it's bled. The technology is there; it's going to get better. You can use it for many other things. People are using it to look at ureters, look at lymph nodes. You can see, obviously, you give the dye 5 minutes before you want to assess. We made a small cut and delivered the bowel. We can confirm that there is well vascularized segment which you want to transect and put your anvil and staple back. It's particularly useful for high risk people, diabetics, smokers, and old, and it just gives you that reassurance, helps you sleep well. The evidence is there but not there, but I think technology is there. We reassure ourselves and we know that we've done it, and that's what we do. And you can do the same even if it's a coloanal anastomosis. You can give some dye, make sure it's flowing well before you transect and anastomose, so that you don't have any diebacks. So looking at our data itself, so we standardized it. What have we actually done? So we've done more than 600 of these robotic procedures, 565 using the Da Vinci and 40 using the Hugo. Standardization is key. It doesn't matter which platform. It just still, as long as it's the technique and the TME. Once you learned it, it's the same with any platform. Obviously, it's a first generation Medtronic device. It's pretty good. And compared to Da Vinci, which is 4th generation, it's got different set of advantages, but still does a beautiful job. So yeah. So looking at our data, we started looking at our data early on. We didn't have a MDT in 2018, 17. We started doing international collaborations and talking to our colleagues around the country and started looking at our data. We started seeing that reporting changed from 2017. The completeness of rectal specimen was 97%. Our nodal harvest was between 12 and 14. Leak rates were 2 to 3%. Margin positive was about between 5 and 9%. Our length of stay was between 4.5 to almost 6. So we looked at in 2021, looked at our data of 235 rectal resections compared to the NESQIP data. So the gray ones are open, darker gray is lap, and the darkest gray is robotic. And the gold bar is our data from Apollo Chennai. And so our margin positive is 4.6%. Leak rates are less than 1%. We routinely For any mid to low rectal tumors, we put a covering loop ileostomy. It's our routine. Wound infection rates are 1.4% compared to 5.2 in the NSQIP data. The length of stay is 6.1% compared to 4%. 6.1 days compared to 4 days in the NSQIP data, which again, our patients tend to stay longer because a lot of them come from out of town. They'd rather have a good bowel movement or stoma working. Everything is done. I've tried my best, but it's a difficult challenge in private practice when saying like, I don't want to stay in a hotel, I want to stay here. And so like, I'm looking at data, I want my patients out so that I can someday publish my data. But then we also looked at the readmission rate. Our readmission rates are 2% compared to the 20% in the NSQIP data, which sort of suggests that whatever issues they will have, they get addressed in that first extra 1 or 2 days they stay. And also we standardize the operations, so the complication rates are lesser. And so that's that data coming out. So compared to our first 150 to second 150 cases, our console procedure and console time have come down. Our margin positivity rates are 4.7%. Nodal harvest rates about 13.89%. We've had 3 conversions of 300 cases, which we looked at, which is about 1%. If you look at published data, laparoscopic LAR's conversion rates are about 14%. Robotic is about 7%. So robotics has half the conversion rates compared to laparoscopy. And again, the data is there. If you open your My Intuitive app, it will just throw out data, which is just incredible. And you can look at what you're doing. As you can see, I've done 565 cases, and I can come and bullshit here as much as I want, but My Intuitive app, anyone who's using it, if you look at it, it's there. So more than 50% LARs, we've done, 63 APRs, sigma colectomy is 26. So all that data is there. So this what will happen in the future is your hospital managers or the management team look at this data and to see how effective you are or how much instruments you use. You can see most of the instruments are only 2 instruments and the sure form, there's nothing else. So that's your data on your app that is available in the public domain if they wanted to. And you can see our console time is all coming down, which goes what I'm saying. But the most interesting or what we've achieved with standardization is this slide, because so we've looked at how much does it cost. Polo Main is a private hospital, so patients come there with anyway, it's a model which you all know anyway. So our operating room is where most of the money they spend. For OT rental, the robot rental, they pay around on an average 1,12,500. OT consumables, which is robotic instruments, which I use too, and the staplers and the robotic staplers, about 1,32,870. OT pharmacy, all the drugs is about 20,000 rupees. Hospital stay, the average in this 300 patient subset is about 25,800. Because we've standardized it, they stay those 6 days. The operation is the same operation again and again and again. They don't go to ICU. They do rarely, but we haven't had to transfuse blood unplanned. And we haven't had any leak rates, as I said, was about 1%. In the surgical team, that's an average. And so it's about $5,100 or $200. Now, the published data looking at cost, in the USA is about $20,000. Europe is about $13,400. South Korea is $12,000. And we have achieved about 5,200 without standardization. So with standardization, that's the question we want to ask. Okay, all that is okay. Is it going to working? Is it working? We reduce the operating time with experience. We're getting better surgical outcomes. We're reducing length of stay and readmission rates. Can we reduce cost, which we've tried to do? And can we scale this up? Can we get it to the masses with robotics and good results? I think the answer to all of that is yes. And so I would say once you standardize the operation, it becomes easily adaptable, can scale it up, and you can be cost effective with excellent outcomes. Thank you so much.
Excellent presentation, Dr. Venkat. Very small question. Why do you use 2 arms rather than 3 arms? Basically, we use 3 arms of the robotic. You use 2 arms. Right. Do you see any reason for that? I mean, you have, just to save cost or only cost? No other benefit? No for the avoidance of crowding instruments?
No, not at all.
Not at all. And this international standard conversion rate is somewhere around 5 to 6%. Why do you think your conversion rate is so low? 1% you said. Any particular reason for that? Do you select your cases?
I think
Anything else?
I think it's to do with how many cases you do, experience, subspecialization. Because if you look at the UK, the average UK surgeon does about 30 colorectal resections a year. I do about 70 to 80 rectals a year. They're colorectal itself, the entire bucket. So I think more operation, subspecialization, standardization. We do the same team, same steps, day in, day out. I think you would achieve that.
Hello, sir. Sir, my question is regarding the learning curve of the robotic rectal cancer surgery. As the three options are available, open and the laparoscopic and the robotic. Someone is well versed in the open surgery and he want to switch to the robotic surgery. So it's better to undergo first the laparoscopic surgery, then the robotic surgery, or from open to robotic surgery. As the curve of the laparoscopic is difficult as compared to the robotic.
See, I think learning the technique is very important. I learned it open, and I think that's the most important stepping stone to it. How you do it, and again, accessibility to whether you have a lab program, which has done, if you have access to a lab, but if they're not doing many rectums, it's not going to help you. So you need a good high volume unit where you know where your planes are. It doesn't matter whether you're doing open lab, you need to get that crystallized in your head, and okay, with minimal, you're going to see better. So you need to, the short answer is find a unit which does, but you need to have your technique sorted out. It is a technique, and then you're using all this advanced technology to get better results, pushing it.
Nice presentation, Dr. Venkat. I want to ask two questions. One, is there an advantage of firing a 45 mm stapler first when you're doing ultra low dissection?
Only thing, if it's a male pelvis, I can't get the 60 in. If I can get it in, great. But most of the time, our subset of patients, the Indian typical male patient, subcontinent patient, is narrow male pelvis, big tumors, and to get below them, the 60 is a big challenge. So anything low, 45.
And is there any decrease in number of covering stomas that you make, like with the advent of robotic surgery?
No. Even in spite of the ICG, for the mid and low rectums, which is anything within about 4-5 centimeters from the the rectal junction, I'm always cautious. And if I'm doing a low anastomosis, I just protect it.
Ultra low cancers, like what is the percentage of covering stoma that you make in
Ultra low, pretty much 100%.
So regarding the sequence of the dissection deep in the pelvis, posteriorly, laterally, or the anteriorly, what you followed, and for the posteriorly, is from central to
posterior all the way down, and then do 180 degrees where you do most of the dissection, because controlled, you can see it. You're not changing everything. See, the whole point is that once with that technique, you're not coming out, going in. You just have to clean the camera, because sometimes with a lot of edema, these splashbacks, just hold it up and do that 180 degrees. You've done most of the dissection. Then it's just easy, right and left.
Thank you, Dr. One more question. Just a comment. As you do more and more robotic rectal procedures, you feel that some of the rectal tumors, you wonder how I used to do this laparoscopy.
Yeah.
And when I was doing laparoscopy, we used to wonder how we used to do this open technique. Do you feel the same way?
100%. I mean, I just freak out when I think I have to. If you can't do it robotic, you can't do it lab, that's for sure. Only thing, you can't get the instrument, the stapler in, or sometimes something's happened. On the rare occasions, I just sweat going back to open, because you just can't see. Whatever you can't see the way things you see. That's the only thing. But that's the way we trained. And you just used to put the what's that curve thing? The contour. Yeah, and contour, and right there, do a PR, push it. Just push it. Just go as far and fire. And and we all grew up in that way. Now you're seeing everything. Now, so you can't really screw up. That's the problem.
So some of the fixed tumors, bulky tumors, you find it very, very difficult now. Once you do it robotically, that how we used to do this laparoscopically.
100%.
Other disadvantages now, if you have to do laparoscopic rectal section as a matter of choice, it's very difficult to do in a 2D camera. It has to be a 3D camera, because your mind is trained. These are some of the disadvantages.
Yeah, for us now, we have a intuitive. We hopefully get a second one. We have the Hugo, For me, that itself is a choice. I like for a low risk section, I need my intuitive because I've done so many of those there. Hugo is good, it'll still do it, but it's still newer technology and I'm getting used to it. So I guess you get spoiled, but it is amazing technology and the operation looks better. At least my operation does come.
Sir, one question. You have very low rate of conversion compared to the international standards. So what were those 1% of the patients in which you had to convert? What were the reasons?
Couldn't get the stapler in, the narrow pelvis, couldn't, that was the main issue most of the time. And sometimes, it's a perforated tumor, which is, you've gone up there and you find a little perforation and then, it's stuck and it's not able to, which you would have converted even with slap. So, yeah, and otherwise, pretty much you're able to do everything about it. Thank you. Oh, sorry.
Thanks. That was a brilliant video.
Thank
you. Just wanted to know, like, the total time taken for one procedure, say LAR, if you're doing it robotically, docking, undocking, etc. How many cases are you able to pull off in a day?
So
say sometimes if you have multiple cases.
So my slot is say 6 to 1 o'clock. I start at 4. I'll do 2 before 1. Thank you.
Thank you, Dr. Venki. I think the take-home message is one, standardization helps, and the second would be that probably it's a philosophical statement. Life and surgery are about getting into the right plane all times. That is perhaps which is important. I mean, this is something that we have to identify them, otherwise we so now for the next talk, this is the third keynote lecture. This is by Dr. Avnish Saklani, and this is on extended resections in rectal cancer beyond boundaries.
Okay, can you end? Good morning again. I think a great presentation by Vanki, and I'm so glad with the panel. Anand is one of our fellows here. So great to see him here. And of course, Pradeep, Dr. Bojwani, and Himanshu Nordgate investing. So I think for the rest of you, I think this is only for fanatics. Okay, Mister, this is a bit crazy people who do this. Okay, it's like me. So I think things are changing now with TNT coming in. A lot of people are going to do wait and watch, and what we are going to be left with be in the extended dissection ones. So I think when you're going to do procedures like this, you need the whole team. This is the GIDMG. I'm the convener. So you need your help from all your colleagues, either the liver team and this one. So I think we started 2013 and we had found metastatic rate for colorectal cancer was not bad, but the locally advanced were a problem. So in 2013, we used to have cases like this and, require an exentration MIS was really very low. Of course, we had Reena here, the brilliant radiation oncologist and the medical oncologist, and we formed a team and we decided to take on challenges. This is what you think it is. Have you got a pointer or something? So normally you have the TME, what Venki showed, but if you go beyond boundary side, if you see anteriorly, you can see the seminal vesicle and prostate. If you see laterally, you have the nerves, the vessel, the ureter, the posteriorly you have the bone, and inferiorly you have the levator. So anything going beyond the rectum is there. You wish in your life that you were doing a TME and everything looked like that, but that is not true. Okay. And you have to know everything else. So what is beyond TME? So if you take all the organs out, prostate, bladder, then it becomes total pelvic exentration. If you take only the uterus and rectum, it becomes posterior exentration. You can take the bone out as well. But if you take part less than 2 organs, then it becomes an extended TME. So if you see top row of picture, that is the TME plane, you can see the mesorectal fascia, and that will be a TME procedure. If you see the second row there, this is involving just the seminal vesicle. So you may excise only the seminal vesicle there, and that will be an extended TME. Where for lower one tumors, the prostate is involved, and you're going to have an exentration. Should you do procedures like this? I think there is good data from Pelvic Collaborative, which we are a part of, that 5-year survival for primary cancers is about 60%, for recurrent less than that. And you can do, you can push your boundaries, excite both sciatic nerves. So the component for this is you'll have to learn in stages. So you have to learn the lateral node dissection, the vessels, dissect the boundaries well, and then operate. So normally this is a combination of many procedures. You're going to excise the rectum, the bladder, then you have to form an ileal conduit. Okay, so you have, and then do a Weaver-Plastisor. So when you have a procedure like this, the complications will be a combination of all these procedures. So you can form an ileal conduit, lap, robotic, things like that. So you have to gear up for that. So over a period of 10 years, we have done about 364 exentrations, and actually 50% of them have been minimal invasive. So there are 110 MIS total pelvic exentration, posterior 45, and bladder sparing are 19. So almost all primary procedures, not recurrent ones. Okay, I won't go to this one, but none of this is without complications. So let us see, should I start with the procedure first or complications? Anyway, it's coming now. So this is a locally advanced tumor, levator is involved. So this is, I'm showing one of the procedures for it. Okay, sometimes it gets a bit boring. So initially you start with mobilization. This is a locally advanced tumor with a large pelvic node sitting on the sciatic nerve there. The first part, when you want to go on any extended procedures, you have to go along the vessels there and dissect the nodes. So here you're clearing the vessel there. There's a lot of you are surgical oncologists and you'll do this. The second part you have to do is to dissect the ureter and go down to the pelvic floor. And once you have done that, then you find the obliterated umbilical ligament and create the spaces. So now you can mobilize the ureter completely. Initially, you have to leave the ureter hanging till below, but once I made a decision, now I cut it off. This is the obliterated umbilical artery. This will go down to the internal iliac artery. So everything is landmark. So I think it's all about how you plan it out, sort of thing. So it is about force physics mainly and anatomical. So you create the planes, and then you use your graspers and retractors and mechanics and do the same thing. So the anatomy, that way you can see external iliac. So the obturator nerve is seen both proximally and dissectal, and almost a split and roll of the obturator nerve. Thing is, if you do an exentration to ligate the vessels, now this is the large node which is sitting on the lumbosacral trunk. And as you do more and more, so to clear that, you realize you have to see the lumbosacral trunk. So you have to visually, you have to see, now this is the large lumbosacral trunk which goes down there, and which after exiting the sciatic notch, okay, will be forming the sciatic nerve. So once you know this, how to preserve it, you can cut it as well and go laterally. This is the first part. So these are the branches of internal iliac vessels. So all the branches will come medially. Only the pudendal vessels goes below the sciatic notch. So you can take the internal iliac artery. In this one, the node is touching the pudendal vessels. This was the first part we had taken the internal iliac vessels. So if you want to take the internal iliac vessels, see the lumbosacral trunk laterally, S234 medially, and you can take them without any bleeding. Because the node is very going in there, and you have to take the pudendal vessels there laterally. So actually, the most important problem is before you handle the problem in the center, sort out the site, cut off all the blood flow. Okay, that's what you would do to a terrorist. Cut off the funding, don't attack. Okay, so this is the back tumor. So you do this for one side and another side, you cut the nerves there, and you go ahead. The communication, the hypogastric nerves are cut. So you can see all the root, all the vessels are done, and looks good. I could do a lot of talks on how to cut it, but if you see this, you have it in your mind there. Similarly, you do the same thing on the other side, and you mobilize the ureter well. Once both the ureters are mobilized, taking down the bladder takes nothing, but you go in the space of resius there. If you're going to do a total pelvic exentration, you don't even need to ligate the DVC because you can do it from below using a ligature there. So you reach the pelvic floor, oh, you can take superficial veins there, you can take the TVC, but next you cut the rectum, staple it and leave it there. We leave the ureters long with a stitch so we can find them through a small mini laparotomy, or sometimes we can do. Then we take from the bottom and you can excise the whole specimen. Cutting the sacrum at what level is to be decided. So you have specimens like this. When you do an exentration, so there's a big empty space in the pelvis, and last thing you want after doing a big procedure is to have empty pelvis syndrome. We have something called a Bakri balloon. We put in there and then we do a BY-plasty. To a small mini laparotomy, 5 centimeter, you bring the ileal loop out and you form a conduit. If you do an intracorporeal conduit in robotic, then you can do that as well. Okay. I'll just move this forward because I don't want to see it. In this, you can do the same thing with robotic as well. I'll just move forward because. So now you're doing the same thing with robotic. I think Venki showed a really good video. So again, you can do the same thing. You can do posteriorly. So now we do a lot of rectal resections. So MIS rectal resections, no, maybe about 600 a year. So we have a lot of control. But if you don't do that many, then maybe robotic offers a good way to do all these dissections. So it's the same thing that you did laparoscopically with a lot of control. So you're showing all the branches of internal iliac. So everything is in your mind. So you know the left side is easier to do because when you put the patient on the left side, all your branches are flowing in there. For the right side, it takes some. Here again, you can see the internal iliac vessels and the pudendal vessels which are going down to the pelvic floor. So this is not to be taken lightly because if you do this procedure and your nodes haven't been removed completely for lateral node, your recurrence rates are almost 20 to 25%. And then to operate on them is really a big difficult thing. So whatever you do, make sure you have a good team who have a high volume. Okay, good. So something it should look like that. But this is extended resection. Sometimes you may just have rectal cancer with lateral pelvic node. If you're doing an exentration robotic, then you would cut both the ureters off. And you take the bladder down. With the advantage for these ones, if you have a high BMI patient and you want to do an intracorporeal conduit, then sometimes the small mini laparotomy may not be that easy. You also have to learn from your colleagues. Urologic colleagues will do robotic RCIC with ileal conduit, and they would do it in 3.5, 4 hours. So nothing great about it. We have to realize one thing as surgeons, what one man can do, another can do. And thankfully, because of all these videos and web search there, if you have the technical skills, you have a right sound mind and you have knowledge, okay? The knowledge before skills, okay? And the right aptitude, you can do it. So here you're making an intracorporeal conduit, identify the loop of bowel, and you do a stapled anastomosis. And once you do that, you lift both the ureters up there and join. We don't do many of these because sometimes forming a 5 centimeter thing is okay, but can be done in high BMI patients. So you can form a conduit and that is okay, good. Sometimes for older patients where the disease is advanced, what you can do is preserve the left colic, bring the sigmoid out, and with the both ureters, you can bring it there. And you can join them to the ureters, but you staple the 10 centimeter of the sigmoid and form a transverse stoma. So that is an important one. So now if I see anyone over the age of 65 who needs an exentration, then I would probably do that. So I preserve the left colic, bring the sigmoid colon out, put a stapler close to the sigmoid itself and join both the ureters there. And I bring a transverse stoma. There is small blind loop there, but for the elderly patient, this is better. A lot of anatomical variations. No operation should be complete without knowing what goes wrong, okay? Because you can run into a battlefield When you're young, you want, and you join the army, you want to be on the battlefield. But this is what you see when you reach a battlefield, okay? You're doing lateral node dissection and is bloodshed. So in that case, your assistant has to press the bleeder and then you go to the root, take the artery. So you have to disconnect all the blood flow first proximally. So you ligate the internal like artery and vein from the top. Then you go near the bladder and disconnect it. So very important, not to be taken lightly. So that is one of the things to be done. Other thing is you form a conduit, use the sigmoid colon, always put in a scope in laterally. You can see you put the ureter on the sigmoid and the small bowel loop has gone below the ureters. You pull it out. These are very simple procedures, but because there are so many procedures involved, you may get tired and take a break in there. So you can see, okay, you put the bowel on top of that, that is okay. Other thing, empty pelvis, everyone is worried. I think we have a recent paper in Langenbeck's now. After abdominoperineal resection, bowel falling in the pelvis is 5%. After exentration is 22%. If you've done a big operation, taken 8 hours, and you go back in again for obstruction with your conduit, you're looking for trouble. So we can pull this out and then we can put a Bakri balloon there. But there is no well-known method. I mean, I know a colleague of mine, Anand, showed for APR, you can put the bladder and suture it to the pelvic brim. We use this. This looks okay. Okay, next one. So there is no trials for randomized trials for T4 rectal cancer. So when you do something, you have to audit it. We compared our result with MIS versus open exentration, and the results were comparable. Blood loss was less, but complications were comparable. We have done only 165 cases. There is a learning curve. We doubled our cases and we checked again, and the outcomes were still okay. We also have to see our shortcomings to improve outcome. Urinary reconstruction leak rates of 5%, strictures for 10%. How do you improve it? Do lesser procedures. You can excise only the seminal vesicles there. So we have, or extended resection. So we are the only ones probably have done 40, 50 seminal vesicle excisions with MIS approach, and outcomes comparable is there. So we have data that you can do that. Other thing what you can do is if you have a tumor, which goes and invades the prostate there, what you can do is you can take the rectum and prostate out completely, leave the bladder in place and put a suprapubic catheter. So that is the safest one. So that can be done as well. So that is called bladder sparing exentration. We have about 19 patients. They still have urinary leaks from the neck on the bladder, but they can be managed easily. I won't go into that one. Sorry. So you can do all this, but so you have a learning curve. So we have last 1,000 rectal dissections, we have a learning curve. Outcomes improve after 100 cases. Even for lateral nodes, minimum lateral node dissection should be 19 to improve your outcomes and decrease recurrences. Then you keep on doing smaller procedures and you get better. You find out your shortcomings. If you have complications, work on that. If it is empty pelvis, then you look at Bakri balloon. If you have problems with the perineal wound, you do VY advancement flaps, and you require everyone from the team, the plastic team, this one. And if you think stomas are a problem, then you look at alternatives. So we are looking at a trial where we're doing staple stoma formation, a ring of staplers across there. So it will prevent parastomal herniation. And most important thing, selection. 20 to 25% of the patients that we operate on them will either die within 6 months of recurrences. So that is futile. So you have to select those patients. So we have this paper in EJ, so we have looked at futility. So now I have a young patient who comes to me with a poorly differentiated cancer, bilateral pelvic node, requires a sacral resection, has limited peritoneal disease. I technically can do all of this because I can do exentration, I can do HIPEC. But will the outcome? The data is showing 100% chance of futile exentration. So while technically I can do it, I should not. Okay. So to become a good surgeon, you need knowledge, skills, aptitude, and performance. And the third part is very important. So sometimes you have your senior, younger colleague who just go away. You have to pull them back because they are in the danger zone for the patient. So our job is not only to operate, but improve outcomes and quality of life. And sometimes not operating may be better for them. Thank you. So you can do a lot of them, but be judgmental. Thank you.
Thanks. How often do you do sacral resection also?
I think we sacral resections about 25 or 30, but depending on whenever it is available. Initially, we were doing mainly with the orthopedic team. We don't do high sacral resections because our orthopedic team doesn't do that much. But I know places like Ambani, they do quite well. For the low ones, anything below the lumbosacral trunk origin, so we do it ourselves. But bone resection was one of the things of futile exentation. But the low ones, so we do quite routinely.
And when you do this low sacral resection, what's your approach? You start posteriorly first, or you start?
I think we do only if it is very high, we turn them prone, but otherwise we do from supine only. So we take them almost 6 to 8 inches off the table sort of thing. But we still have a long way to go to improve on the outcomes. So I think a couple of my fellows were working in Hyderabad. They went to Mike Solomon units in Sydney and they were very impressed.
Singapore also, they do quite a bit. Thanks.
So doing these kind of resections, you do a lot of, roomy pelvis empty. What do you do to, close the pelvis? What is your procedural choice? Because the primary closure is not enough in these cases.
That's right. So now we looked at many things. So we did flaps. Now someone tried to put, obviously with these procedures, put a momentum in this, but we had looked at a lot of literature. It was not working. And putting, after doing MIS exentration, putting a VRAM again should do it because it would have parastomal hernias. So now we are using this Bakri balloon. This is a 500. Again, we learned it from gynaes. One of the gynaes allied had come. So this is a 500 ml balloon. We inflated and we looked at timing of getting it out. So by 8 days, we start decompressing the bowel and then taking only 10 days. But we have looked at it systematically. So we've looked at CT scans after surgery. So after 8 days, it forms a film of peritoneum there, not all patients, 70 patients, and that gets filled with fluid. So the bowel is above the level of the pelvis. So in open surgery, so it definitely works with lap. So we have done about 100 or so. We have published that as well, but not perfect. If you have many techniques to prevent empty pelvis, that is not there, but at least we have something to look for it. I mean, I know Dr. Subramanian Rao has also put a lot of folies there and things like that, but it's a problem. So for us now, I think that is the standard where you don't spend much time and not much effort. But VRAM is very good. Hi, sir.
Just a quick comment. Now you have started doing circular stapler en masse for the stoma. My only concern is that you have a staple line on the edge. Will that not aerate into the bubble which is coming out?
No, it is done only as a part of trial. So phase 1 trial is there, but I think normally if we want a fibrotic thing ring, if you put mesh for parastomal herniation, it tends to shrink and you have hernia. But if you go in the abdomen after anastomosis, the fibrosis is maximum in that. So, but that was a concern. That is why as phase 1 study, we have done 22 patients. Follow-up is 1 year and we didn't have any problems like that.
He's brilliant as usual. I just wanted to know what is the failure in these patients? Is that do they fail locally or do they fail systemically?
Systemically, the local recurrence is less than 3 to 5%, because with that clearance with nodes and this one, it will be less. If you operate signet, the recurrence is going to be signet. They'll come back with ascites or systemic sort of thing. Most of these are young and PDSC. So, yeah, thank you very much. Take care.
Patients with rectovaginal fistula and carcinoma rectal. Or you divert routinely or recommend together for diversion before sending the patient for chemotherapy or.
Right. Okay. Miss, I think if you're talking about rectovaginal fistula, then you're looking at T4 cancers. So they definitely require neoadjuvant therapy. So you will divert them and give the stomas to prevent sepsis and things like that. And then depending upon the level of fistula, you would decide. If it was at the level of very high up in the vagina, then you could do a posterior exentation. It could be technically challenging. It requires type 3 hysterectomy. For very low down, then you would see middle somewhere you could excise the vagina itself and suture it. For low down, if you want to save the rectum, you will have to do a pull through, or you can do a Turnbull procedure, leave the colon hanging in vagina. So, but again, or even after standard resection, 5% people will develop rectovaginal fistula. So best thing is to do intersphincteric resection and Turnbull. Again, I would say if I'm going to go lap again, which we do normally, I would do a diverting stoma. But the chances of prolapse with transverse stoma is almost 25%. So you have to look, if you're going to operate on that, definitely transverse stoma. If you're not going to operate, If you think it may be palliative, then ileostomy better, because otherwise you'll have to operate on them again. And elderly patients avoid ileostomy. Thank you.
Next session, challenges in rectal cancer surgery. And I would like to call next set of chairpersons and speaker Dr. Nihar Ranjan Dash.
Should I wait for the chairpersons? Oh, sorry. Hi, good afternoon. Should I start? Respected chairpersons, dear Dr. Deep, the organizers, the respected faculties, delegates, thank you for making me a part of this nice update. I have been instructed to discuss a very controversial thing, that is the decoding the stoma, formation of stoma in rectal cancer. There are certain points I need to answer. I will not go into the point as point-wise manner, and hopefully the discussion would clarify them. This is the topic which has been more or less discussed in parts by most of the speakers. You may find familiar. I'll just try to summarize and consolidate them. Little bit of background. About 7 lakhs of rectal cancer patients are found at every point of time in a particular time of the year all over the world, and having the moderately high morbidity and mortality. But with the advent of multimodality management of the rectal cancer, the survival has been extended, 5-year survival to 80%. In the multimodality management, surgery forms the cornerstone of the management in form of various rectal resections, depending upon the position of the tumor, the extent of the tumor staging, and associated patient factors. It ranges from high anterior resection above the peritoneal reflection to low anterior resections, ultra low anterior resections, sphincter preserving resections with coloanal anastomosis. And finally, the sphincter is not salvageable, then abdominoperineal resection or excentrations leading to a permanent stoma, about which there is no question. The other indications of stoma, definite indications, are growth with complications of perforation, bleeding, obstruction, unresectable lesions, the peritoneal disseminations, locally advanced growth requiring a neoadjuvant therapy, and patients who are unfit for surgery. The main problem with this colorectal anastomosis is the anastomotic leak, which occurs in expert hands in around 10% of cases, and it accounts for 1/3 of all the deaths and a huge number of morbidities if it is associated with sepsis, bleeding, strictures, internal or external fistulas, and sinuses. And if you need surgery, resurgery for this, the morbidity, we work in a hostile environment, that is contamination, the edematous bowel, and adhesions. And there is a very high chance of having a permanent stoma in these patients if we re-explore. And all these lead to increased stay, increased readmission rates, that's about 25%, and a 10-fold rise in cost, severely decreased quality of life, and possibly worst oncological outcome in form of recurrence. I don't know why recurrence occurs when we have a margin-free anastomosis there. And apart from various preventive measures that are described, I'll just enumerate in the next slide. The important one which is having the maximum controversy is the diverting stoma. The rationale is that it would prevent fecal contamination of the anastomosis, and if there is a small hole, then it may make it a bigger one. The stoma would be able to prevent that one. But is it so? The benefits and indications are actually very debated. Cochrane review of 21st major studies says that stoma formation can reduce the risk of clinically symptomatic leak, re-explorations, and severe sepsis because of severe contamination in coloanal anastomosis. However, the flip side is we have to remember the high rate of complications in these patients, the poor quality of life, skin problems, fluid electrolyte loss, obstruction, particularly problematic in obese patients, and other complications. They have a high readmission rate. Of course, they need a second surgery to close, and the complications of the second surgery is to the tune of 20%. So how to make a decision to make a stoma? Now, if I summarize all the studies that I have read, the summary would be first assessment of the risk of the leak in these patients. So there are many risk factors, elderly age, comorbidities, obesity, whether they have been pre-operatively optimized nutritionally or not, whether they were operating in emergency, with the prolonged duration of surgery, low 5 centimeter of the rectum, and technical factors. Whether we have done a study for the vascularity, either by surgeon's experience of bleeding or by doing a ICG test, or we have there is a tension-free anastomosis, well-mobilized bowel, and the sutures. Hand-in sutures have increased leak rate in comparison to staple anastomosis. The leak test, whether it has been done or not, is done in 3 ways. Either you do by inflating with air or dye of 200 ml, or you're putting an endoscopy and seeing for the leak and the unhealthy mucosa inside around the anastomosis. If you have done a repair of the leak, the primary surgery, then the higher chance of having anastomotic leak in the post-operative period. So once you assess the risk factors, if there are a good number of risk factors, you think of forming a stoma, and then you have to weigh with the consequences of the leak of the patient versus the complications of the stoma. It all depends upon the patient factors again. Whether these 2-3 points after this actually are not supported or well discussed in the literature, but in my experience, I would recommend to look at these factors, whether mechanical bowel preparation has been given or not. Aesthetically, it is good. And obviously, it reduces the contaminations, particularly the hard feces or solid feces. If it remains in the pelvis, it's very difficult to remove that one. And if it is a mechanical bowel preparation, it has to be a good bowel preparation with antibiotics. That's what the trials say. And if you have been able to surround the anastomosis by a omental flap, it's good. And some people do staple line reinforcement. I do reinforcement if I find the staple line visible on the staple side. So those areas patchy or wholly, I take a seromuscular suture. If they have been taken, it appears that the leak rate would be less, but actually the randomized trial do not support that one. Either if I put an external drain or an internal drain through, which I used to put in low rectal anastomosis in most of the cases, multiple holes in the catheter passing across the anastomosis. Again, no literature to support, but retrospective studies, they say that they are helpful in reducing the morbidity in the post-operative period. So this balancing between the stomal complications versus the risk of the leak and the complications and severity of the complications with the tolerance of the patient to repeated surgeries and recurrent and management of the stoma, take the quality of life with him lifelong. all the or part of the life decides whether you should form a stoma or not. So more or less, I would say it is individualized. At times you need stoma after re-exploration. So if you re-explore, the better result is if you re-explore within 5 days. This is trial proved. And if the management with resuscitation, antimicrobials, and source control fails, which is likely in more than 70 years of patients, multiple comorbidity, severe illness, and high intraperitoneal contamination, then if you have exhausted the or not taking account the conservative management, take the patient for re-laparotomy, preferably within 48 hours of diagnosis. Most of the people like to salvage the anastomosis nowadays, but if you see the literature, the common practice is to take down the anastomosis and do a permanent stoma. So if you I try to salvage the anastomosis. It all again depends upon the patient factors. And if I try to salvage, I either, if it's a good stump available, then re-anastomosis and a drain, or repair of the leak site, reinforce or do not reinforce, or you simply put a drain and come out, but all of them are to be associated with a diverting stoma. So if it is less than 1/4 circumference, most of the studies would advocate anastomotic salvage and a loop ileostomy. We must discuss with the patient and remember that there is a good chance of having a permanent stoma in these patients. In fact, up to 1/3 of these temporary stomas may never be able to be closed in long term, particularly in the elderlies. The risk factors which are described are age, stage, narrow radial margin, ultra low anastomosis, and adjuvant therapy. But unfortunately, most of these factors you cannot decide, or you have no information about them in the first surgery. So it is very difficult to say whether I should go for a permanent stoma in the first surgery or not. So which stoma? We have many types of stomas, but the controversy is between a loop ileostomy versus transverse loop colostomy. The comparative studies are there. The loop ileostomy requires a small cut. It has less odor, easier to manage, and it is associated with early bowel movement, and it has less systemic infection. However, the disadvantages are the skin problem and the fluid electrolyte imbalance. In contrast, in a loop transverse colostomy, the size is bigger, so more chance of infection, more chance of parastomal hernias, but it is associated with less intestinal obstruction, ileus, because of its site where it is situated, and it has more odor and difficult to manage because of that. Both have poor quality of life, but both are safe. So because of this comparative parameters, most of the literature says they go for a loop ileostomy. But I know that most of the people would not agree to this. They would go for transverse loop colostomy. There is no point to discuss how. I have been given 3 points, so I'm not discussing about this, but I have to mention that the 3 points you must remember while forming a stoma. One, and very important, is patient counseling, and he must be really agree by himself to go for this. Second is the site of the stoma. Ostomy triangle, all of us know, whether a transrectal route or a pararectal route, a pararectus abdominis route, there are trials, and systematic review doesn't show any difference between them. So I would suggest that better go by the habitus of the abdomen, the obesity, the scars, the contour of the abdomen, and be 5 centimeter away from the bony prominences, and be in the ostomy triangle, should be easily visible for the patient to be managed. That is the area that is most important to form a stoma. And meticulously adhere to meticulous technique is very important in these patients. So in conclusion, I would say that there is a range of surgical procedures which form the cornerstone of the multimodality approach to rectal cancer. So a good number of patients require a temporary stoma, and most of them to protect an anastomosis. But we must remember there's a major chunk of these people where we do a low colorectal anastomosis, but we do not do a stoma, may have, would have low anterior resection syndrome in long term, which is difficult to manage. We will discuss this one in some other talk here. But it is quite debilitating for the elderly people and of course the younger people. But there is no study to say that if you form a stoma and you would be able to prevent a low anterior section syndrome. But retrospective studies say that you have a stoma, the chance of having a low anterior section syndrome is less. I cannot tell what is the mechanism of that. We have to weigh the complications of the stoma, and stomach and therefore is to be individualized. And again, lastly, I would reiterate and stress that stomas, it should be we should adhere to meticulous technique while doing a stoma patient and not leave our junior colleagues to do the stoma at the end of the surgery. And this is because a properly formed stoma would give a very good function and good quality of life to the patient, better quality of life in the long term, and a poorly formed stoma would make the life misery. We are seeing a lot of these stoma problems I have been a part of the society which is functioning since last 30 years, and they are really very worrisome. I bring blessings from our senior stoma members, 2,000 of them. Out of that, 30% have crossed 20 years to 30 years of their lifetime. Blessings for all of you. Thank you.
Hello. Thank you, Dr. Ranjan. You have spoken in detail about the stoma. In the last line, in the conclusion, you said it is meticulous technique. But that is most important, and one should be careful because parastomal hernias are very common and we are seeing day in and day out. So now topic is open for discussion. Any questions?
Excellent presentation, sir. So I have a question that a patient who underwent ultra low resection post TNT and was discharged with diverting stoma. Finally, after 8 weeks, at the time of when we think of closure after 8 to 12 weeks, we did a CT cologram and it showed the sinus presacral signs. So what are the options now for the patient who is pressing for the closure of the stoma?
I think it will be discussed in the next session most probably, but I would tell my own opinion. We face this thing in maybe 3 out of 100 patients, wherein we find a small terminating sinus by the side, and then the radiologists say, leave it, wait, and finally we have done a closure of the stoma without any problem. So based on that experience, I would say 3 months, if the sinus is there, wait for another 3 months, that's all. Can go for close. Yes.
Thank you.
Actually, clinically, it doesn't. We know that in 40% patients, radiologically, they can be having leak and could be leading to a lateral blind ending sinus.
Some other experience in the house regarding the same?
So most of the times I would agree with you what you've mentioned. I'd like to point out one case that I came across in my practice. Now this happened in the year 2018. I'd come across an elderly gentleman who had been operated for a bladder tumor at Vinamta. During the course of that surgery, they had a rectal perforation. The rectal perforation was a large one, so they did a transverse colostomy. The GI surgery unit did a transverse loop colostomy. 8 years after that event, that patient presented to me. He wanted a closure of that stoma because he had a parastomal hernia as well, and his quality of life had deteriorated because of that and stuff like that. So we got a imaging done. That imaging showed that, in fact, that shown on repeated imaging that there was an iliorectal fistula that was there on the imaging at that point in time. This patient went back and forth to Vedanta, then back to me, and every time. Finally, we decided to close him up. We closed him up, and after like 15 days, there was pelvic sepsis, there was leak. So this was one case where maybe even after 8 years down the line, we had this kind of an event. Maybe something which is very rare, but most of the times I would go with what you.
But ileocolic fistula, you didn't detach, you didn't do anything to that.
We didn't do anything to that because it was mentioned it was a very small, like kind of a thing, and this patient did not have diarrhea or anything of that sort as well. So I mean, this was only evident because the rectal contrast had been given at that point when the study was done. It was a very small fistula. The patient hardly had anything coming out of his anus at that point in time as well. But once we closed it up, this really became terrible.
Anything regarding the size of the sinus, opening and length of the tract when we decide on closing at the final?
If the size is big, the radiologists say the tract itself acts like a diverticulum. It will empty itself into the rectum. So
we have a small opening sinus. Is there anything that we will just make it bigger and let it drain so that it finally everything drains out when we close the stoma, rather than a small sinus which may precipitate a sepsis, a pelvic sepsis later in case some infection seeps in.
So there are two types of sinus like that. One goes up, one goes down. So which one is up? See, if you by chance close and then that gets infected and becomes abscess, it will drain out into this one. But if it is a down one, so it would end up in a fistula. That is my thinking. I'm not read about this.
So what I would feel is that if in few situations that we have faced, we have done 2 subsequent contrast studies, and if they don't show any change in sinus, as Dr. Das said, it doesn't make a difference even if you close. If the patient is symptomatic and he has, you think that there is an abscess developing there in the blind sinus, then it would be better to do an endovac therapy, put in a vacuum assisted closure. That is something that is developing and it works well. That is what I would feel. Dr. Dash, one question from me. What is the role of doing an end colostomy or a Hartmann's like procedure in this patient? Where does this procedure stand now? I mean, in a rectal cancer management.
In the rectal cancer management, there is no question about a end stoma. If the patient has an abdominal perineal resection, there is peritoneal metastasis, there is obstruction with bleeding, leak, or perforation. And if you think that it is too locally advanced and would need a neoadjuvant therapy, so in those cases, some people leave behind the distal part inside and go for a terminal one. But I have found the stump opening up with the obstruction. In case of obstruction, if it is a blind loop, so in those cases, you have to do a double barrel stoma that will act like an end stoma. Otherwise, now the end stoma is limited to those conditions in low anterior resection, wherein you are going in for a second surgery and finding that this is a big one, too risky to anastomose and salvage. Discuss with the patient and better do it. That is the commonest practice now.
Also, there are more chance for pelvic sepsis if we are not resecting the root and making the end stoma.
Yes. But pelvis is actually closed by the peritoneum, so it doesn't go into that until unless there is a growth below the peritoneal reflection. Then there would be a pelvic sepsis. It occurs sometimes. They burst through the perineum outside and fungate. That also we have seen.
Good afternoon, sir. Very nice talk. So one case scenario I would like to discuss, sir. In case of ISR, when we do a colonal anastomosis and divergent stoma. So there was a case where after 1 month, everything was fine. It was patent. He completed chemo. After 7 months, he came. There was complete anal stenosis at the suture site. So, like, what is your experience regarding that?
Oh, very poor experience. And I have 2 patients just now, I think over this last 1 month to manage, referred from outside. So I had a literature review for that. So it is clearly written that only dilatation, dilatation, dilatation. That is the only chance you are having. and no surgical procedure from down below will help these patients until unless you have a good stump to do a reanastomosis. But I've done a patient, I've done a surgery in a patient for this reanastomosis. I couldn't go in, and while removing those scar tissue, I damaged entirely the lower portion of the rectum and ultimately I had to do a stoma. So it's not possible, dilatation or a end stoma. That is the only thing we can do to these patients. Very unfortunate,
Thank
but
you,
this
Dr.
happens.
Dash. Sir, one question. In the obstructed lesion in the rectum, the patient is obstructed and we are planning for the neoadjuvant chemoradiation. How to choose the site of the stoma, whether it is sigmoid, transverse or the ileus?
Sigmoid.
It is not depends on the site whether upper
Sigmoid, because you are removing that, where you are removing the entire thing along with that, and then you have to just reconstruct the stoma after removing the.
I think I would slightly disagree
No,
with you, doctor. Transfers would be better because if you are planning resection and anastomosis, if you are planning APR or an end stoma, then sigmoid is better.
Yes, you are correct, but just read one trial which says that if you are living, if you are, the stoma, the distal is better, but if you are going beyond proximal to the splenic flexor, better remain with the ileostomy side rather than do a transverse colostomy. But there are no hard and fast. I would agree with you also. I have done transverse, I have done this, but only thing wrong I find with this is if they do a radiation or something, they find it difficult to manage the stoma part if you do a pelvic. So it is always safer and away to do a transverse loop colostomy. But if I'm going for a APR later on, better I would go for this.
Depends on the extent from the anal verge side of the.
Yes.
Now we'll call for the next speaker.
Sir, thank you.
Rest of the question can be discussed during lunchtime.
Sir, thank you very much. Thank you, sir.
Dr. Deepak Govind. He will be speaking on early reversal, who and when.
Welcome, sir. Thank you.
Thank you, Chairperson. Thank you, Deep and the team for giving me this opportunity. I think it's a wonderful conference, wonderful idea and a great detailed conference. I was just going through the topics. It's really covering everything in great detail. My talk today is early reversal, who and when. I think it's an interesting topic because I'll be just covering it under these headings. What is early reversal exactly? And why should we consider early reversal? The available literature, the advantages and disadvantages, who should be considered, a little experience we have. We started it in last 1 or 2 years. Now, timing for stoma closure, it's very uncertain. Even when we go through the literature, majority would say after 3 months, but early it ranges from 10 days to 3 months to 6 months. Routinely, it is said that if a patient asks me, I would say 3 months or probably 2 months today. But there are ranges which are available even in the literature, which vary. What is early reversal? Again, I have gone through the whole literature. There's so variable definitions, but majority would say that probably less than 2 weeks they consider as an early reversal, and more than 8 weeks or 12 weeks they consider as a delayed reversal. At least 12 weeks, after 12 weeks is considered as a delayed. And the literature is also very variable on all these terms. Some has taken 8 to 13 days as early reversal and more than 4 weeks as a late reversal. So these are very variable, but I feel that more than 12 weeks we consider as a delayed one, whereas less than 4 weeks or less than 2 weeks we consider as an early reversal. Now, how did this concept come? I think to us, probably we started thinking of it when one of our patients, because of the adjuvant treatment required for the these rectal malignancies, a lot of these patients would start on chemotherapy, and you can't wait for chemotherapy too long. And they have majority of patients who come to us are relatively advanced lesions, would require adjuvant treatment, and therefore the stoma closure usually got delayed to more than 6 months or sometimes to even a year before we were able to close the stoma. And therefore, we started discussing with our medical chemotherapy people that can we delay the chemotherapy a little so that we can close it earlier. But they said that if you start it 8 weeks later, after 8 weeks, the effect of chemotherapy is a little suboptimal and the 5-year survival is affected. And therefore, we started thinking that we should probably start considering early reversal of the stoma. Now, why early closure? Again, obviously, stoma is always associated with quality, which is a low quality of life. So, quality of life measures, late complications with the stoma, cost effectiveness of management of the stoma. Again, adjuvant chemotherapy, as I told you. Then the logistics, like a lot of medical tourism, a lot of patients come from outside with rectal cancer to surgery here, and they have to go back. So to logistically decide when do they want to come, how do they want to continue, you may sometimes land up with an early closure stoma of the stoma. Regarding the literature, this started almost in 2002 when these were the studies which came, which said that they can do it probably at day 10 in the same admission, they could consider closing the stoma. There were these two studies from Netherlands and other place, and they considered very early closure, although they were very low number of patients, but they gave this concept. And then there were certain studies which were done. And this was a study which was done, which showed that early stoma early stoma closure is feasible. Sorry. Early stoma closure is feasible in selected patients with reduced hospital stay, bowel obstruction, and medical complications, but a higher wound complication rate. This was the result of this study. As you can see, this showed that there were surgical complications were similar in these patients, but the wound complications were higher in early closure patients. And you can see the small bowel obstruction and medical complications and other complications were lower in patients with early closure of stoma. So we had a little higher wound complications, but other complications were reduced when we closed the stoma early. Then there are various studies, and this study showed that it's a shorter, easier, and a less expensive operation. And this showed that the median duration of operation was significantly shorter if you close it early. Closure were significantly easier in the early group. There were no significant difference in the median total length of stay. Now this came easy trial, which had a randomized control trial, and where they had almost, I think, 55 and 57 patients in both the groups. They had early closure, which was from 8 to 13 days, and the late closure, where 57 patients were there. There were more females in this group, and they found, again, the stoma-related complications were higher in the late closure group, which were 77% as compared to 24% in the early closure group. And these varied from skin irritation to stomal ulcer, parastomal infection and leakages, high volume output. All these were higher in patients with late closure. And whereas the other complications, they were similar in both the groups. The post-operative complications in the later part after 12 months were again higher in the group with a late closure. So overall in this easy trial, they said that the complications after 12 months follow-up were significantly lower in the early closure group, and the grade Cleveland into grade 3A or higher complications, there was no significant difference whether you did the closure early or late, and the stoma-related complications were higher in the delayed group, although the wound complications were higher in the early group. So now the downside, again, this study showed early ileostomy closure appears to be associated with an increased wound infection rate, but otherwise appears to be a safe alternative to a traditional closure in selected patients. Then these were studies, they said that probably with the ERAS becoming popular, again, this early closure of protective ileostomy came, and there were studies which said that the cost also is decreased and the patients can be discharged earlier, and hospital stay can be reduced with the use of early closure. The cost studies, again, they said that with the early closure, this was a US thing, around $4,000 for early closure, whereas it was almost $7,000 for a late closure patient, the cost effectiveness. The cost analysis of early versus delayed, again, case match study, this also showed the same thing, that I think most of these studies told that the wound complications are higher in an early closure group, whereas the hospital readmissions and the other costs and other complications are higher in the delayed group. Then this is an interesting study, functional outcomes from a randomized trial of early closure of stoma. In fact, as Dr. Raj also told just now, that probably there is some literature that a little better results with LARS, LARS in cases where there is a stoma made. Similarly, for early closure, they said that probably their functional results become a little better if you close the stoma early rather than you close the stoma late. And this study showed that the patients undergoing early stoma closure had fewer problems with soiling and fewer had a permanent stoma and reduced LRS, but this was not statistically significant, but so that we can really not go too much with it. Then this again, 2 versus 12 weeks after rectal resection, a word of caution from these studies, again, tendency of, there are studies which showed that there is an increased chance of leak if you do the closure earlier, and therefore the popularity came down a little, and therefore they said that the wound complications, the leakage from the anastomosis were a significant little higher with the and local wound complication, oozing and other problems are higher. So these are the problems which probably we face with the early reversal, bowel edema and inflammation, adhesions. A longer, in fact, when we were doing early closure, we've done it in almost 10 patients, and we found that the duration of surgery is longer because the adhesions, the bowel is edematous, and to dissect it takes a little longer time. The chances of serosal tears and relatively all those issues are a little higher, increased local wound complications, and probably an increased leak rate. Now, most of the studies say that in selected group you can try this, but nobody identifies how do you select that group. So I just put down things which came to my mind, that in these patients probably you can consider doing an early reversal if the patient is nutritionally well-maintained patient with a good R0 resection and a good well-vascularized anastomosis without tension at the time of surgery. Very clean post-operative period, no wound infection or intra-abdominal collection. And patient who is not on any immunosuppressors or steroids, especially patients with IBD. Even now, patients with IBD, we are closing the stomas at 3 months strictly. Other stomas we may close at around 4 to 8 weeks also. But for IBD, we don't close it before 3 months because these patients are on immunosuppressants. And certain soft logistic indications, sometimes you consider closing the stoma early. Again, these are the two important parts of the early closure of a stoma. If you decide on early closure, you have to counsel the patient properly, perioperatively, even before the index surgery. And it's a shared decision. Like the patient also has to agree that maybe in the same admission or after a week of discharge, he may again has to be admitted for a resurgery for a closure of the stoma. So patient and other thing which now today with the TNT becoming more and more popular, I think, and the kind of patients which we get, they are locally advanced lesions. So I feel we should consider more of a TNT treatment, and then the ileostomy closure need not be delayed, because the main reason for a delay of ileostomy closure was adjuvant treatment, which is required for these patients. So we started just last 1 or 2 years. We've done approximately 10 patients in last 2 years. One patient, we had a lot of difficulty in the surgery, but post-operatively, fortunately, he did well. Overall, definitely dissection takes more time, and we are not very convinced that we'll send every patient. I think only for logistic lesion reasons, we may consider this sometimes, but not as a regular practice. So now this is another trial which is coming on TIMES trial, which is timing evaluation of stomach closure early versus late. This is the ongoing trial which is recruiting right now, and we would see the results later on. So to overall conclude, I would say that early closure can be considered in selected cases on a case-to-case basis. Good perioperative counseling and shared decision-making is important for these patients. It can be done within 2 to 3 weeks of surgery. Early closure has shown better quality of life and cost effectiveness with similar post-operative complications as compared to late closure. Locally advanced lesions may be considered for a TNT approach to avoid prolonged stoma with its associated complications. Thank you.
Thank you, sir, for such a nice and lucid talk on early closure. I have two questions, sir. First thing, the definition of early closure in the literature is very variable, starting from 8 days to up till 4 weeks.
Yeah.
So what according to you is early closure?
I would say if because usually 3 to 4 weeks people are very reluctant to operate because the edema and other things make it more difficult. If you have to operate, usually less than 2 weeks is the period when it is usually. Most of the studies also say 8 to 13 days have been taken in the easy trial. They've taken 8 to 13 days. Less than 2 weeks is the preferred one, which usually majority of the studies would say less than 2 weeks as an early closure, and more than 2 months is the standard closure period.
So what is the anastomotic leak rate as per you after the early closure of the stoma?
See, I think for the anastomotic leak rate, there are only few studies which have shown that probably the anastomotic leak rate had increased, but majority of the studies did not show any increase in the anastomotic leak rate following an early closure of the stoma. That was to the tune of 5 to 10% for the studies which showed a leak rate, but otherwise it's not been shown to increase
The
the leak.
difference is insignificant as compared to the.
There are studies, they said that it is significant. There are studies which have shown, but obviously there are multiple studies available, but 1 or 2 studies have shown increased complications in the anastomotic. Yeah.
My question is just extension of the last question, actually.
Yeah.
After any major surgery, the time to go back into the abdomen at second or third week is the bad time. So most of the times there's edema in the bowel, and do you think in your personal opinion, if you do anastomosis at that time is small, or the chance of leakage of small intestine will be more as compared to when you go after 3 months?
I feel so.
So you have
So
done
not
10
very
cases,
convinced,
right?
frankly.
Okay.
Yeah, that at 3 to 4 weeks, I would not be very convinced. But early, we have tried in very few patients for logistic lesions, mainly, but in few patients, we had 1 or 2 patients we had problems, but other patients we were able to do well. But these were the patients who had done a very good post-operative course earlier, and they were convinced even before that if everything is fine, we may close it a little earlier. So if the patient is willing and you've discussed it in detail with the patients, you can consider it in selected patients.
Actually, I have a very limited experience on this. We have done in 2 patients, in fact. We had to go in early because of the obstruction. And we utilized this time to close the stoma also. We had to go in the second week.
Okay.
In fact, they both did very well.
Yeah.
So that is why we started thinking about this. But we do not have much experience. You have more experience than us, and that's what.
And we tried this, but I'm not very convinced, frankly, about it. Only in very selected patients we should consider it. If the patient is well, the localized lesion, good resection, good anastomosis at the time, post-operative period has been clean without any problems. And those patients with robotic resection, especially, we have started considering that early closure. And since the patients sometimes come from outside, so we give them an option that we can do it a little early also.
So, like your talk, specifically fact that adjuvant therapy is something that is hovering around here.
Right.
Because you have done this procedure, the medical oncologist talks to them that you need to come back to me about 3-4 weeks.
That's right. Yeah.
And then you help the patient back, and you run into rough weather with the stomach closure, which is not considered as a cancer operation, but considered as a repair operation.
Right, right.
So that has been the worry why early closure did not pick up so much.
Right.
So what is generally done is you do this and relax because you relax because the patient has a stoma, and then you send for 2 cycles of chemotherapy, and when they come back, it's 8 weeks.
Right.
So with TNT, this should really
That's right.
come to
Yeah.
really stress that one.
That's right.
In case
of I'm just trying to be the devil's advocate here. So if the patient was good enough to be closed at 2 weeks, was it a good idea in the beginning to have done that stoma?
I thought definitely somebody would ask that. But I think,
Add to that, is a ghost ileostomy an alternative? If you're going to.
yeah, I think I've gone through it, but I didn't do it in any patient because I'm not very convinced, frankly, that will that work, because you can't just make a stoma. And I haven't seen it working. So I haven't tried it. I've just gone through the literature and found that there is an option. In some patients, in fact, at the end of the procedure, you feel that probably you may get away with such options, but practically, I'm very liberal with the ileostomy in our practice.
So we actually did it in 5 patients. Very funny thing happens when they are started on diet, they start having a lot of hiccups, which immediately stops once you put the bowel back in.
Okay.
So I didn't know what was the cause. Probably it was an vagal irritation which happened because the mesentery is stretched.
I thought it's a good idea, but practically I have not tried it.
Anil, I think
Just a comment.
Yeah.
I disagree with this last point he made. I mean, if the leak occurs, it occurs within 2
I think
weeks.
that's-
It never occurs after that. It's very, very less likely that leak will occur later on. So even if you close the stoma after 2 to 3 weeks, it is fine. It is leak. You have to demonstrate by radiology before closing the stoma that there is a leak or not. So if it occurs within 2 to 3 weeks, not after that.
Thank you,
I
Dr.
think-
Govind, for a very interesting talk. Rest of the question, I think we can discuss today.
Yes, one more question.
Last
So
one.
In case of recurrent rectal cancer, with poor histology, both times margins were negative and the patient completed the new adjuvant also. So in the recurrent cancer, the timing of the stoma closure will remain same or it will be delayed?
I would consider it should remain the same. I would consider, because if it's recurrent cancer, obviously the chances that of it coming again at some other place or even at that place are higher. I would not consider anything. I think we are very liberal with the stoma. In fact, to answer that, we are very liberal with formation of the stoma, because I think almost everybody would have burnt his fingers once or twice. So we have become very liberal in considering so. That's right.
Thank you, Dr. Govind, for a very interesting talk.
Thank you.
Now I call upon Dr. Pradeep Chan. His topic is pelvic closure after APR and ESFP.
Can I first slide? Yeah. Good afternoon, everybody. First of all, I'd like to thank Dr. Deep Goyal and the management team for having me here. So we know that the procedure of choice in lower rectal cancers, particularly when they involve the aneurysm, is the APR or the ELAP. So, but when we do this procedure, we improve the local control and the survival can be increased after that. But simultaneously, it leaves a large non-collapsible pelvis space with wide perineal wound. So after doing this procedure, we have more dead space with the fixed bony walls. And most of these patients, they have preoperative chemoradiations. And many of these have undergone exenteration simultaneously. So after doing this procedure, this is a perfect recipe to have an infective and non-healing complications after this procedure, because we can have a lot of seroma, abscess, perineal discharge, sinuses, and later on the perineal hernias also. So with these complications, we have increased morbidity, increased hospital stay, that leads to increased cost, and sometimes there's a delay in adjuvant therapy, so there's more chances of recurrences. So this packing and the delayed healing has been a thing of a past. For the last 4 or 5 decades, we have been doing primary closure of the perineal skin, subcutaneous tissue, and sometimes the pelvic muscles. But the overall complications is too much. I mean, we can see the complication the tune of 80%. In fact, in my patients also, when I do primary closures, the complications, whether it's minor complication or the major complication, it's more than 50%. So what do we need to do to prevent these complications? So we have to fill up the cavity to prevent complications through accumulation of seroma or the fluid. and there should be known tension closure of the pelvic floor. And the skin closure, the skin of the perineum should be very well vascularized to have a good healing. So what are the options we have? We have options of using the autologous tissue, or it can be enhanced by the mesh repair. The selection of procedures depend on many factors. The factors like age, the body habitus, the performance status of the patient, whether the surgery is undergoing minimal invasive or open surgery, patient is having any previous abdominal surgery or scar, the patient's position. Sometimes we do APR in the lithotomy position, sometimes we do in prone position, and the previous irradiation of the perineum and the size of defect we get after the APR. And it overall also depends on the surgeon's comfort, whether surgeon is particularly interested in which kind of repair. The autologous reconstruction can be with the myocutaneous flaps, perforator flaps, and very rarely free flaps. The autologous reconstruction with myocutaneous flaps, they have a nice, good tissue, vascularized tissue. So they fill up the dead space, they provide the vascularized tissue within the irradiated field. And associated, this leads to less rate of infection. And the most of the donor sites for these myocutaneous flaps are rectus abdominis, gracilis, and the gluteus maximus. About the perforator flaps, with the perforator flaps, we have a good vascularized skin flap which are based on the perforator vessels, and thereby avoiding any sequelae related to muscle transfer. Because if we go for the big myocutaneous flaps, the problems with the donor side is much more as compared to the perforator flaps. The most of the often used abdominal flaps are the VRAM flap, or the transverse rectal abdominis muscle flap, or the deep inferior epigastric perforator flaps, or the muscle sparing VRAM flaps. They're very reliable, but the bulk is more, and there's no need of additional scar if the surgery is being done open. There's a problem using VRAM flap when you're doing the minimally invasive technique, and this is taken, the VRAM flap is taken from a non-irradiated area. But simultaneously, it has a disadvantage that there's a lot of potential for the hernia, the potential need of use of synthetic mesh, and additional scar is there if we are not using a minimally invasive technique. And they're not suitable for patients who may require multiple ostomies. Sometimes we have to reside the ostomy. So these are not a good flap method for them. And when you use these big flaps from the abdominal wall, there's a poor healing when the patient is obese. This is the photograph of the VRAM flap. There's a large bulky flap which is based on the deep inferior epigastric vessels. And this can be tunneled from the retropubic area to the pelvis to have this kind of repair in the perineum. Thigh flaps can be from the posterior thigh or the lateral thigh based on the pudendal area. These are based on descending lateral circumflex femoral arteries or the internal pudendal arteries, middle circumflex femoral arteries. The advantages are that they avoid abdominal incisions, and we can use, if we require more tissue, we can use both side flaps, and they are potentially more inconspicuous scars. The scars are not that much visible, and the minimal functional morbidity of the donor site, and potentially from the non-irritated areas. But the disadvantage is that the rotation of the arc of rotation is very limited, and the bulk is very less. So we have to use bilateral harvesting, but they are less reliable skin flaps as compared to the VRAM flaps. This is an example of the thigh flap, the gracilis flap, which is being used in this case. And because the bulk is less, so sometimes we require both side flaps to repair the perineum. The perineal flaps are basically based most upon this superior gluteal artery flap or the inferior gluteal artery, or they can be VY advancement flaps, perineal turnover flaps, or the gluteal turnover flaps. They're all based on superior and inferior gluteal artery. Again, they have the same kind of advantages as we have from the thigh flaps, like the avoid additional incisions. We can have both unilateral as well as bilateral flaps, potentially more inconspicuous scars, and the minimally functional disability. But again, the arc of rotation is limited, less bulk, and they're less reliable as compared to the VRAM flaps. This perennial turnover flap, they're the most and the least complicated flaps, and can be used from the local tissues. We have to just know the perforator sites, and we have to mark them in advance, and then we can raise these local flaps like perennial turnover flap. Like you can see in this case, This cross is the perforator site, and there's a local raise. This flap is raised, and this flap before it putting into the pelvis, this is de-epithelialized, and this rotated inside the pelvis cavity and suture inside and gives a bulk, and then we can have the scar, perineal scar like this. This superior gluteal artery flaps or inferior gluteal artery flaps, they can be used simultaneously when you reach more bulk. Otherwise, or a single flap is good enough to cover the perineum when the gap is not that much big. Again, the double VY rotator flaps, the both side flaps, after knowing the perforator in advance, we can use both of them to give a lot of bulk to the pelvic cavity. These propeller flaps, these are the flaps which are used with the 90-degree axial rotation. The arc of rotation is less, but they can be used for the smaller perineal sinuses once we have after the APR. And this gluteal perforator flap, this is again based on the superior gluteal artery perforator. Pudendal flap, the same as we use in gluteal flaps. Overall, if you see this is a very, there's a lot of heterogeneity in the literature. The overall the quality of literature available is not that good. All are retrospective and very little information is available. And we've seen that we will compare all flaps, whether it's abdominal, this perineal or thigh flaps. Overall, there's no difference in the morbidity and the rate of recovery. The only difference we see is in abdominal flaps where the hematoma prevalence is more as compared to the perineal flap and the thigh flap. About the omentum is a very good friend of abdominal surgeons. It is always happy to help, like a Vodafone dog. And we can raise these flaps, the omental flaps, either based on left gastroepiploic or the right gastroepiploic. And we can have if the patient is slightly on the V side, we get a large bulk and we can fill up this omentum into the pelvic cavity. About the literature about the omental flap use is again only systematic reviews are there, no RCTs, and most of the times we have seen that this omental flap this is a past study. This is a study of 2013, and they have shown that it reduces the perineal wound morbidity and minimal additional operative time. Overall, the time taken to raise these flaps is nearly 20% or 20 minutes. And this is a new study which has looked into the perineal wound healing at 1 or 3 months postoperatively, perineal wound infection rate, perineal wound healing period, and they've shown that the omental transmission flaps, they did not affect much about the perineal wound healing after the APR. Another method we can use is the mesh repair. This can be synthetic mesh in the form of dual mesh or a Vicryl mesh or just Gore-Tex mesh. We can also use biological mesh, porcine dermal collagen, human acellular dermal matrix, and acellular porcine small mucosa, small intestinal mucosa. And the studies about this is I think this is it's an old study about the Gore-Tex mesh, and they have after using the Gore-Tex mesh, they have concluded that the reconstruction of pelvic floor using Gore-Tex mesh results in quicker postoperative recovery and could decrease the risk of postoperative intestinal obstruction. Again, this is a RCT done recently, and it's a biopac study, and wait just a minute. And they have concluded that the reconstruction of pelvic floor using PTFE graft results in quicker postoperative. So I think, this is a biopic study, and they have shown that the symptomatic perineal hernia rate at 5-year follow-up after the APR resection for rectal cancers was significantly lower after biological mesh closure, and the biological mesh closure did not improve the quality of life, though they improved the symptomatic perineal hernia rate rather than the quality of life. This is another BioPAX 2 study which is undergoing right away, and the results are still not available. They will be comparing about the gluteal turnover flap with the primary closure after APR. This is a comparison of VRAM flap with the mesh, and the only difference in the favor of mesh repair is the less operative time and less operative post-operative stay. The rest of the things overall are the same. And this is again another systematic review of perineal wound closure after the APR And they've shown that the results of VRAM flap, particularly without VRAM flap, in reducing major complications in APR, and they're better than the primary closure. Another method to decrease the wound complications in perineal closure is by using the negative pressure wound therapy. If we apply a negative pressure incisional wound therapy after the surgery, the infection rate gets delayed. Overall, the number of infection rate is same, but the infection gets delayed, and the clinical course of these infections are less severe as compared to if you're not using these flaps. There's another systematic review which has suggested that because the overall the evidence in the literature is very sparse and very bad quality, so we need good quality data. We have to get RCTs to get a good, the conclusion of these repairs. So there is a lot of confusion in the literature which kind of flap we should use and whether at all we should use these flaps or not. So this is a small flow chart which is good at this time. When we are doing this APR in the supine position, then if we require a great volume, then we can use a VRAM flap. And if we require a small volume, this defect is small, then we can use a gracilis flap. But if the patient is in the prone position and there is a satisfactory local tissue and suitable perforators available, then we can use pudendal flap or a VY gluteal flap. But if we require a bigger volume, so we have to turn over the patient again in the supine position, in the lithotomy position, and then we raise the flap and use it. And if there's a small local flap is there, so local sinus is there, then we can use a perforator flap or a VY flap locally in the lithotomy position itself. So my take-home message is perineal morbidity is high after APR or ELAP procedures. The primary closure is not enough. We have to do something extra to decrease the morbidity. And it is better to do something extra and add more time on the table rather than losing more time in the complications later on. And we should always choose the procedure very wisely, taking the patient's factor and the surgeon's comfort in account. And we should always collect the data, all the data prospectively for future insight to the younger generations, because we do not have enough data to suggest a particular procedure in these kind of situations. Thank you so much.
Thank you very much for that, Dr. Pradeep sir. So do you recommend in every APR or ELAB we should do some kind of a flap? Or?
No, we should basically, as we know, the overall morbidity is very high. So primary closure is never enough. So we should add something into that. Either we use a omentoplasty to fill up the gap in the pelvis, or we use some kind of mesh repair. So overall, the morbidity, if we use either the omentum or a mesh, is less. And the literature overall also suggests if you use microtennis flaps or turnover flaps from the perineal side, the complications and the morbidity is less. Definitely. So we should always add something into it.
Excellent, Doctor. And that last slide of that flowchart was lovely. VRAM, I think what happens, especially in minimal invasive surgery, as you rightly said, then the pedicle really is under risk. And you can never rely. We have had a flap necrosis after minimal invasive surgery of the VRAM, then it becomes a disaster. So we have started using gracilis, and that is working quite well. We don't have to change the position as well. In the same position, the plastic surgeon raises the gracilis flap.
Nowadays, more and more people are using turnover flaps based on the perforators rather than using microtennis flaps, because the morbidity of microtennis flaps is more as compared to the turnover flaps from the perineum. So we have to localize the perforator, side of perforators, and raise a fasciocutaneous flap from there, deepithelize the skin and turn it inside. So that gives a volume also, and overall the morbidity is also less because they are very well vascularized.
Gracilis, there's hardly any morbidity.
Okay. Yeah, no, I know it's not that much of morbidity, but you have to give a long incision in the inside of the thigh. That can be, in particular in females, that can be a bit troublesome cosmetically.
My question is, we have seen the closure from the bottom, but from the abdominal side, we have seen sometimes the bowel stuck out in the empty pelvis. What measures we can take to prevent?
In both the cases, if there's a big, roomy pelvis is there, we have to fill up that cavity. That cavity can be filled either by the omentum, raising the omental flap. That takes hardly half an hour. or we can give a microtennis flaps because we need bulk in that case. So for in those cases, you need to fill it up either with the momentum or a microtennis flap.
Because sometimes the patient after APR want to maintain the continuity through the perineum. Not quality of life is not good with the permanent stoma. You want to inverse to the perineum. What is your experience regarding that?
After APR?
Yes, sir, after APR, like grassoplasty or some other.
There are few people, Dr. Abhijit Chandra is doing a lot of work on this from Lucknow. They make the artificial sphincter. I mean, they make a sphincter from the pyloric channel and they transpose that on a vascular graft down in the pelvis. But after doing many cases, he has shown that overall the complication results are bad if you're using that in a situation of carcinoma rectum. But when the patient is having loss of sphincters of the trauma, in those cases, he's having good results. So he started doing this. Yeah, basically after doing this pyloric sphincter, using pyloric sphincter, later on the second stage, he reinforces with the gracilis.
No, but it was an excellent diagram showing the momentum really coming up to the skin. How often do you have such bulk coming down?
No, this as I added this point because this kind of bulk we get from obese people. If the patient is thin, lean and thin, you don't get that kind of bulk. In those cases, you can't use.
And it comes down easily in a short, stocky woman, actually, is it not?
No, if the patient is fatty and you raise it nicely based on one artery, whether left gastrophilic most of the times, it comes down there. I've done it myself sometimes.
So there is some advantage of being fat.
Yes, reasonably fat.
Okay, I get it.
Not more than 100 kg.
Thank you, Dr. Jan, for an excellent talk. But I got only one question. Once you are doing a mental filling, incidence of herniation. Secondly, you said you will use dual mesh. Why not Prolene mesh? Because we are closing the peritoneum.
Prolene mesh, I'm a bit skeptical because I think the chance of infection will be much more because we are already working in a hostile atmosphere. We're doing a colonic surgery and your intestine is open some point of time there. So in those cases, the chance of infection will be more. This is my personal, there's no hard and core literature available on this. But it's my personal choice that I'll not like to use Prolene mesh.
Thank you, Dr. Jan.
Thank you so much.
Any other comments? Session is closed now. Thank you.
It's great. We are running on the time. Now it's time for the lunch. Delegate and faculties, please have the lunch at the backyard. Thank you.
Hello. So we are going to start the next session in another 5 minutes. Delegates, please assemble in the hall. फोटो ले ले यार मुझे उसके भी लिए देना पहले भी भेज देना उसके क्या 5 minutes. हाँ. एक बार बोलते उधर जाके तगड़ा हो गया खड़े हुए हैं ना सर इसलिए मिठाई के बगैर ही आगे चल So we are going to start the next session. I request the chairpersons, Dr. Sankat Mehta sir, Dr. Rajesh Bhojwani sir, Dr. Shashikant sir, Dr. Amit Gupta, Dr. Vikas Gupta to come on the stage and to chair the session. Please sir. Anu, बहुत चला है, बहुत चला है। So there is an important announcement for the delegates. The robotic simulation is kept in the backyards. So those delegates who want to practice hands-on, they can go anytime. Today it is available and tomorrow it is not available. So those who want to hands-on training on the robots, it is kept there. And another important announcement is there. As per the NMC guidelines, we have cancelled the gala dinner, which was supposed to held today. And now post lunch, we are going to start our next session. I would like to call upon next speaker, Dr. T. Subramanieshwar Rao sir, to deliver a talk on laparoscopic LAR, ultra low LAR, and interseptic resections. And I request the chairpersons to come on the stage and chair the sessions. Thank you.
Good evening, Chairman sirs, friends. Let me thank Deep Goyal. I think IAGS has done loads of good for me. I've not been into the active core of IAGS for a long time, so I regret for doing that now after meeting Deep and a few other friends. Standard instrumentation, all of you are, many of you are real experts in this. I'll skip that. That is the operation room setup and positioning. 2 monitors always, because these are procedures which can be tiring, especially in obese patients. Those are the ports that we prefer. We still continue with the midline trocar, the optical trocar, although there are quite a few surgeons who have shifted to the right side of the midline for access to the inframesenteric artery. We do lots of midline procedures like the retroperitoneal lymphadenectomy for gynae cancers. So we continue to be comfortable with this. When you are operating on either side of the midline, then a midline optical trocar is generally much more preferable. So a good complete diagnostic laparoscopy before we proceed. And then a few gauze pieces go in so that without much trauma, the bowel goes out. We do this for most patients, especially women, when whenever we do a robotic procedure, especially we do a T-lift for the bladder also, because we don't want the third arm to be consumed while retracting the bladder. So it works well. Initially itself, if you do it, it creates a space for the surgeon to continue. And then you start resecting here. The standard beginning at the promontory, and then directed towards the inframesenteric artery. Standard approach. The point is to hug on to the inframesenteric artery, because what is dorsal to it is generally not lymph nodes that belong to the rectum, but the hypogastric nerve plexus. So important to hold on to the dorsum of the inframesenteric artery. What's happening? Oh, well, we have skipped quite a few videos, but anyway, that's what it is. So especially in elderly patients, when there is a good sigmoid, good redundant sigmoid, we prefer to preserve the left colic. The fact that it restricts the bowel from falling into the pelvis is accepted, but more often than not, this maneuver will help us in, and that's how it is. That also gives you a plane dorsally. And then the vein is ligated later on. We do the vein first also, depending on the surgeon's preference. There are some surgeons in my unit who do the vein first. I do the artery first. And then we get into the pelvis. The TME plane, preserving the nerves. Got skipped anyway. We do a fluorescence angio assessment for every patient before we staple the proximal end. That is the left colic vessel, and then we clamp it and check for vascularity. And this is one procedure. The previous one was a stapled anastomosis. Most of you would have seen lots of them. There is some problem with the system. So about 55% of our patients don't actually pay us a pie. It's a center which does treat patients of every type in both the Telugu states. So these procedures can become very expensive. We do about 350 to 400 rectal resections, colorectal resections per year. So they can become very expensive on the hospital. So we started doing this, and we have done about 120 Anchun anastomosis, and that can get down to really deep into the pelvis as you actually learn. It's a social adjustment to a scientific problem, but we are extremely happy with this. You can actually see that this is below the levator ani. We pulled it up and then cut, and then it just disappeared down. The urologist was doing a robotic surgery on the other side, so we waited for a while and docked the same robo with the same instruments and did this anastomosis. So this low maybe robo is definitely very useful, and what we understand is you achieve a 5 to 6 centimeters anastomosis, because we are anastomosing the rectum using the entire lumen of the rectum. What a stapler does is it actually restricts the anatomy of the lumen of the rectum according to the stapler size. So the maximum stapler you have is 34 mm. So the stapler decides the lumen. Here the rectal lumen decides the anastomosis, because we do to the side of the colon. So colon you can cut to in any length and anastomose. So a 6 centimeter anastomosis. Although it's not a randomized study or anything like that, it's biased by the time during which we have operated. We have never seen a stricture after we started doing this fluorescence study. and then a hand-shown anastomosis. The least you achieve is around 4.5 to 5 centimeters anastomosis, and generally about 6 centimeter anastomosis in most people. So that's how it looks colonoscopically on the table. It works well, and all these patients would have undergone, most of them would have undergone long course chemoradiation. Short course and the TNT is something that we started recently. So most of them, practically every patient would have undergone TNT. So we don't see too many early cancers because we don't have a strong gastroenterology unit. It's a tertiary referral cancer hospital. So unless you have a strong gastroenterology unit, you don't see early diseases. Patients who are either told that they will have a colostomy only walk into our hospital. So there is a difference in the spectrum of patients in a gastro unit, surgical gastro units and surgical oncology units in the country, especially if they are not attached to a multi-specialty hospital. So and then we do the natural orifice extraction, or the commonest that is done if it is a bulky tumor, we use the ileostomy site itself to extract the specimen and then do an ileostomy. Ultimately, what the patient has is an ileostomy as a wound and nothing else. It costs nothing because we use 2 vlogs, which costs about 4,000 rupees for the entire anastomosis and the procedure. Government pays 60,000 for 1 year follow-up, investigations, surgery, and the follow-up investigations. So that's how you need to adjust money. Posterior resection is something. Coloanals are also done in the institute. Whenever you cannot achieve from above something that is very low, various options for the various rectal resections depending on patient and tumor factors, and it depends on the surgical expertise and the constraints. Oncological safety should always be much more important than sphincter preservation. A standardized approach is something that is important in any institute. Thank you very much. And a minimal access anastomosis is possible in practically every patient. Yes.
New edition. We have crossed even 200 cases intracorporeal hands.
That is, you are a guru, sir.
No, sir.
I bow to you, honestly. Yes.
Because, sir, our city patients, they are also poor. We developed the minimal access and we are doing plenty of our reconstruction in GI by intracorporeal simple suture.
Salute you, sir. It's not easy at all. See, I think the passion to do minimal access is something that drives you here. So these are not lesser inventions. They are innovations to suit the patient's needs, and they are actually good for the patient. And what it also does, sir, is teaches your residents how to actually suture. If you are a surgical oncologist, vagina is something that excuses you irrespective of how you suture, because vagina need not be sutured actually. A lot of gynecologists don't suture the vagina. So it actually teaches you how to suture. And this is the other area where even in depth, different levels of the pelvis, when a resident learns to suture, they become supremely confident of suturing elsewhere. So in a training center, it works well. For the patient, it works well. In about 120 patients, we had just one leak, and that leak also healed. So it is not inferior to stapling. That's what I would want to tell.
Nice presentation, sir.
Yeah.
Sir, is there an increase in parastomal hernia site, like if you remove the specimen from the ileostomy?
No, we closed that ileostomy in about 6 weeks, is it not?
But
It's not a permanent stroma. If it's a permanent stroma, it's a cause for worry always. We would not have done it. Yes. It's not a permanent stroma, sir. Yeah.
that good GI team there. It's actually good because they won't let early cancers come to you. They will
Oh,
do
really?
EMR, ESD. They won't let early cancers come to you. Believe me, we have a very strong GI team
Hmm.
at Gangaram Hospital, and never T1 will come to you. It's only T2
That is
sometimes
interesting.
will come to you.
I've gained significantly from this meeting, sir. We have the boss of Asian Institute of Gastroenterology here, who is a bigger victim of the gastroenterologist. He himself is a gastroenterologist. I have great admiration for him. We work together. We continue to work together even now. For the past 25 years, he is an elder brother, and I have tremendous respect for him as a complete surgical gastroenterologist.
Thank you, sir. Following colonal colonoscopies, do you face any problem?
Oh yes, sir. As soon as there is a colon anastomosis, I have discomfort, voiding, and things like that. It's not easy at all, sir. It's not easy on the team. It's not easy on the patient. 1 out of 2 patients become your relative. So, and a relative who has no control over himself and his senses. So they become a problem. I don't know. I won't mind sending to others, but those choices are not there at a certain age and stage, sir. When you are old, you must endure, sir. That's where you are.
That's the best description of polo and the rest of
Thank you very much. Thank you, Deep, and thank you, Chairman, sir. Thank you.
We go on to the next talk by Dr. Saklani. It's presenting on function preserving rectal resection.
Hello, I'm sorry, man. You have to torture. Into my torture again. Sorry. Okay. बस वीडियो चालू कर देंगे करेगा.
You hear the comments of the law or
Yeah, of course I had him. Yeah. I share his grief. Okay, come. Okay, on हो जाएगा. Okay, so I think we've already seen a lot of videos. So now this is the bladder preserving excentration. This is a young chap. Lesion is about 1 centimeter from the anal bulge, and anterior CRM is positive, and their outcomes are quite difficult. You give them neoadjuvant therapy, and if the anterior CRM is still positive, so prostate is actually involved, but the bladder per se is free, so you can actually see from here. Difficult to show from this side. So the anteriorly you can see a mucinous tumor which is going into the prostate. So the plan is to make a cut to the neck of the bladder so the prostate comes out, but the bladder is intact. So you're doing a different sort of thing. But this is not a new thing. People used to do it before. So it's a standard thing, you're going to go along the inferior mesenteric vein, and I just have to make and then go along the artery, and that should be okay. And trying to go posteriorly. Sorry, all this is done before. I think sometimes if your vision is good, then you try to enjoy yourself. Okay, it is just called prolonging love. Sometimes surgical videos are like this, they go on very slowly. You go a medial to lateral dissection, I think, Dr. Then you go posteriorly as well. I think this is probably Anand has made this video, if I'm not wrong. So for extended dissection, I think you always start defining the plane. So you identify the vas difference, and you have the ureter which just goes below the vas difference. So you have to find the junction between that, and everything medial you can go. So you cut the vas, you can see the ureter just traversing below that. And unlike a TME where you go in front of that, here you're going to take the seminal vesicle first, both sides. You do the same thing on the right side as well. The dissection from the left anteriorly comes very easily. So now you can see both the seminal vesicles are going there. So that is what I'm telling you. One thing leads to another. First you were resecting seminal vesicles, now you can resect prostate. When the urologists do it every day in and out for when they do a prostatectomy. And if you can do, so you keep on going down, you can see the seminal vesicles which are ejaculatory duct, which will enter into the bladder. But if the disease is anterior, you stop at that point, sort of thing. So because you don't want to enter that plane where the denon villus is involved. Lateral dissection, you go completely, you can save the hypogastric, and then you keep a sponge in there. You transact the rectum. So if we had a really good urology experience, we could have done residual sparing and cut the bladder from there. Here we take the bladder down. So all the pedicles of the bladder are intact. So we cut the puboprostatic ligaments. And so the plan is to cut the neck of the bladder. So you mobilize and you check where the neck of the bladder is falling. So in the beginning, you can call the urologist to see where the neck of the bladder is there. So, but we are not planning to join a urethral anastomosis because the disease is very low down and even the urethra is likely to be involved. Or even if you join it, if you cut all the sphincters and levator ani, then the continence is not very good. So there is a paper by Saito where they said if they try to join it up. So here you can see you cut the anterior neck of the bladder and the posterior neck of the bladder. And you should find your, if you've done good dissection from below, then you should find your gauze piece there. So the seminal vesicle and the prostate remains with the specimen. You have the neurovascular bundles on this side. You can put a clip or you can just burn it off. Here you can feel the neurovascular bundle. So it's all about anatomy. Then you just put a gauze piece in there. So the plan, you can join this to the urethra, but we know because of incontinence on R1 margin, you won't do that. So you'll close the neck of the bladder and you'll put a suprapubic catheter. Why do you do this and not an exentration? But if you form an exentration, you form an ileal conduit, urinary leaks are 5%, stricture rate are 10%, and mobility rate is high. So why not use the bladder as a conduit is a sort of thing, because the bladder is already there, urine is already falling in there. So you put a suprapubic there and hitch the bladder to the abdominal wall. So the specimen comes out there. So also we've done quite a few of these, about 19 or so. So you just have to make sure the suprapubic catheter is changed, because someone doesn't change the suprapubic catheter, gets blocked down, you have a leak from the perineum. Easy to sort, but I have problems like that. Sometimes you are ended up in a situation like this where someone has put it on the list, and these are locally advanced cases. The conversion rates are low, not because of patient selection. Also, of course, you plan out your surgery, what you're going to do. But if you look at the conversion rates earlier on, classic was high, color 2 was 16, and most average was about 10%. High BMI does a thing. We cannot say we don't have high BMI patient, but low BMI patient is there. Locally advanced is very, if you're a very thin patient, locally advanced, it will invade the surrounding organs. So extended resections are quite common. So our conversion rate may not be BMI, it may be locally advanced. So we have to learn how to do it. And the most common cause for conversion actually was 41% were advanced cancer sort of thing. So we'll have a look at the view next time. Is it moving or stuck? Sorry. So this is a 34-year-old gentleman. Growth is 2 centimeters from the anal verge. So you can see the scan not looking very pretty. You've done CT/RT, MRI. Fat planes with seminal vesicles are a bit gray. You've given chemotherapy as well. So you put your ports in there. So now this looks a bit tricky now. Okay, it's not that you can lift up and make a cut or find the promontory and things like that. You cannot have traction as well. And sometimes it looks like focal peritoneal filtration sort of thing. So in this case, you have to use all your tricks. So you can do vein first approach. You can go on the promontory. You can artery first. So here you do a vein and you go close to the root of IMA. So in robotic, a lot of these times, once you see the inferior mesenteric vein, so we take the inferior mesenteric artery at the root. So you learn from that. You find the root of the artery and you try to go in the presacral plane. For extended resection, you cut the peritoneum along the light of the iliac vessel. So the whole peritoneum moves there, all the anatomy is seen well. You have plans to preserve the ureter, so you get the peritoneum out. And you see, when you start doing all this thing, then you think, oh, you can do peritoneal resection, so why not laparoscopic site reduction surgery? So one thing leads to another. Next thing is to trace the ureter and do it laterally as well. But this requires a good team. So you require a good cameraman, a good assistant. Air seal helps as well. So even for laparoscopy, I think we use air seal as well. I think there is a price to pay for everything. So I think if you want good thing, you have to spend money. So now you can see the ureter on the left side as well. This is the right side. So we're tracing the ureter down to the pelvic wall. The whole thing is to do all the peritoneal excision, trace the ureter till you reach the seminal vesicle. So here you can see it very well, ureter going below the vas. And so the plan is, because it is not completely mobile, the safest thing, instead of trying to go anteriorly, is to take both the seminal vesicles. This is the artery to the vas which is going there. And the peritoneal cut has to be higher up. You know, with cytoreductive surgery that you can now take the whole bladder peritoneum down. To do this again for the right side, because the tumor is stuck on this side, slightly difficult to see. You keep on tracing the ureter. Take the vas down. So sometimes with this tricky procedure, it takes a really long time. It's like flirting. It takes a really long time, but then it starts working, and then, okay, you get freedom. Now this is the hypogastric nerve. So we know we have to take the presacral fascia down. So once you cut the hypogastric nerves, you can preserve them as well. So we know where to cut them. So you got laterally, we've seen both the ureters and preserved them. Posterior, we cut both the hypogastric nerves. Anterior, we cut the vas deferens. And then you go down to the level of denon-villus fascia. Well, seminal vesicles are really high up. So actually, once you do this procedure, you can do a lot of intersymmetric resections as well. But in this one, this looks a really advanced sort of thing, and tumor is not that bulky. So we'll go down completely. We'll cut the denon-villus, or you can leave the denon-villus intact as well. So now I leave the denon-villus intact. So when it comes out, it's easier. So with this sort of view, for advanced thing, you wouldn't get it even in open. So you may say you're doing an advanced thing there for locally advanced one, but I cannot see that well in open. So these are good. So now I have decided patient didn't want an excentricity. Till I've made my decision for excision, I keep the IMA intact and I take the IMA at the end. We do the medial to lateral dissection first and go down to the pelvic floor, and we have decided to do an APR. And then you cut the lateral thing. Here you cut both the hypogastric nerves, so apart from the ureter, you can cut. There's also a plane between S2, 3, 4 and the rectum. So for all signet, I think the best way to have a barrier of fat, because they spin well, is to cut both S2, 3, 4 on this side, and the recurrences are low after that, and outcomes are good. I have quite a few ones. And functional outcomes are not that bad. So once you've done that, you put a swab on stick there. Then you put a pack, and for all our APRs, we normally tend to do is put a pack in the perineum. When you come from the perineum, you don't try to find the plane. You cut the coccyx and keep on cutting, and you have to see the swab. Okay. It is the old thing, takta or takta, throw no coffin. So for all these procedures, morbidity is better than recurrences. So you may have a lot more bleeding, but it's okay. So you cut the coccyx, enter the swab in there. And we do a supine extralevator APR. We use the Devers for this. For these ones, sometimes you can do circumferentially. We were able to avert this. That is okay. And then you do anteriorly. The best way to do an APR is to see the prostate, cut on the prostate always. Don't try to find the rectum. And the urethra comes last. I think APRs are a very underrated procedure. Pradeep Jain showed some really good videos, but I think probably we must have done 1,200 or so, but still sometimes you do some difficult APRs and that specimen looks like this. So technically done excision looks okay, but can be done. So you can do the same thing with intersphincteric resection as well with the judgment. Thank you very much.
Your videos are always like Mission Impossible 7.
All the bad ones come to us. You take all the pretty ones.
It's always so fascinating to see that what can be achieved. And do you take help of urologists so usually, or you do it yourself?
No, I think all the teams are pretty busy. So, but if we need, they come across or we go across the night side. But because they are busy, we do it.
Yeah, nice videos. So, any specific complications which you find when you resect with the seminal vesicles compared to a conventional TAV, when you compare the post-operative
We see
complications?
when the urologists are operating, they're not operating with radiotherapy. So they're getting the seminal vesicle down and prostatectomy easy. Here you give a lot of radiotherapy. So when you're dissecting, you make sure you don't make a hole in the bladder. That is the only thing. But that happens normally in, but that is the thing. It's not to get carried away and see the seminal vesicle well, because you can sometimes enter the bladder in there. And if the ureters are entering into the trigo, then you're suturing, then you have to be careful. But other than that, it's okay.
Thank you.
If I tell that to you, I don't know how patients will come to me. Just joking. I know you swear and rant and then you just persist. I think the thing about conversion is about persistence. Okay, so you just keep on hanging there. Make sure you're not damaging anything. So I think it's okay. So I think after some time you have a level of fibrosis, but once you cut it, and then you start saying this is more so because our radiation oncologists have started giving boost to the pelvis. So now with boost to internal iliac vessels, we are doing pelvic node dissection. So thanks to our radiation oncologist, we are getting better. Adversity brings out the best in people.
So I have one question. Is there any way, I mean, is there a level at which you cut the rectum once you've done a lateral pelvic node dissection?
Oh, sorry, sir. Sorry.
So when you do a lateral pelvic node dissection, is there a level where you cut the rectum? Or do you, I mean, even for a high rectum, you can go and do a lateral pelvic node dissection?
No, I think we cut the rectum, which that is required. But nowadays, now with this wait and watch as well, nowadays we do lateral pelvic node, even without taking the rectum out as well for neuroendocrine tumor. So now for it is like the pelvic floor approach. I think you just go down from bottom and see it from all sides. I mean, it's like beautiful for gynae. So it was a bit difficult initially, but we can do it. So I think at any level, even with intact rectum, you can do it, can become difficult. But you do the same operation for the rectum, which is there. So you will see the epigastric mass.
After APR, how do you close the perineal node? Do you put any flap or do you just primarily close it?
You will see I'm very silly. No, yeah, for these ones, we do a Viva advancement. We just make a cut, what Dr. Pradeep Jain said, but we don't find the perforator. We cut the fascia and it slides in. 1/3 of the flap medially, you can take it off the fascia and the vascularity will be okay. You don't need to see any perforator. If we do it ourselves, we do 100, 150 year, so that is pretty okay. It doesn't fill the gap that much. Sometimes if you think the perineal defect is very narrow and you have thing, we put head down, patient head down for 2-3 days. It works, believe me. I know it will sound silly. Or if you think a patient is very pressure, then we put the Bakri balloon. But incidence of bowel falling in the pelvis and having problems is 5%. So we have a data of 1,200 patients. So I think data is important, retrospective study. So all of you now can put your data together and you get a larger data series. So we are such a populous country, data can move mountains. Thank you.
When you close the bladder below, the chances, because that is the dependent of a leak there are there, even if you do an SPC and pull it up. Would you do prefer a flap there, something like gracilis?
We used to do gracilis at the beginning, but most of the time, gracilis tends to atrophy over time. So even with that, there is a lot of perineal hernia. So I think for 18 or so, what that is what people said. You're given radiotherapy and closing the bladder, neck, and leak. But most of the time, you can see when suturing, it is quite supple and it works well. Only thing, the catheter has to be changed at 6 weeks time. We have done about 19 or 20 over 2 years, so we don't have long-term experience. What urologist says that suprapubic for a young patient or something, no, when they have problems and cystitis in the future. But if patient lives long enough, you can work up.
My worry was not herniation. My worry was primary healing itself.
But I think suprapubic drains it out. So we didn't have any problems immediately post once, only if they were not changed.
Good to hear that actually.
How often do you a sphincter sparing procedure when you do an anterior exenteration? How often do you get to do it?
So we
Because
do
with posterior, it is of course easier, but with anterior, it becomes sometimes very difficult.
for anterior thing and saying sphincter saving.
Yes.
Yeah, I mean, if it is not that bulky, so you just the denon-villous fascia below the seminal vesicle is very thick. So you have to go really low down and see the rectal wall. We do it because there is almost 6 centimeters between the seminal vesicle and rectum. So if you select the patient well, which is not bad, so you can do it. You can do stapled ones as well. So we have quite a few videos as well. So, but the thing is, the denon-villous fascia is a very thick structure once you go below the seminal vesicle. So you may have to cut through 1 centimeter of area before you see the rectum. So that judgment is required. Suppose if you feel the denon-villous fascia is also involved, then it is better to do an APR because the whole denon-villous comes out with going flat on the prostate.
So you're basically talking about middle rectal cancers, not lower.
Yes. Yeah.
Sir, if I may ask just one question. For prostate, do you do shaving itself is sufficient with 2NT protocol when we get higher PCRs, or you prefer if it is involved initially to go ahead with the total prostatectomy with the specimen? Now,
Are you an editor of a journal? I have this paper I've been sending around. No one seems to accept it. So we had this, we looked at, we have done about 1,200 abdominoperineal resection. So about 20% of this at presentation were T4 cancers. So we looked at them, we gave chemoradiation and downstaged them. Okay, so, and we have managed to do an APR. We did a lot of exenteration, prostate shave, we do again quite a lot actually. So we compared the outcomes of this downstage T4 to the high risk one, which are only T3 and CRF positive. And you would expect local recurrences are more in T4 which are downstage and you didn't do exenteration, but the outcomes are similar. So if it is downstaged and you perform an APR with prostate shave, then it is okay. But again, prostate shave also requires a lot of experience out of it. So you people always say if it was a T4 cancer, even if it is downstage, you do an exenteration. But I think that is an overkill. So we have tested your question, but no one is accepting it. We may have landed on moon, but we are not there. Okay, thank you very much.
next talk by Dr. Shivendra Singh.
Good afternoon. And first of all, I like to pardon me because of a communication gap. I was not aware that it is a video lecture, but still I'll show some video of ELAP. So as you know, the rectal cancer milestones have been the APR by Miles. Healed introduced the TME and the ELAP came in 2007. So Miles gave that the levators and rectal fat and perianal skin was the most highly dangerous tissue, and they were the most common site of recurrence. And they reported that 31% recurrence occurred in rectal fat. And that is why they proposed that it should be excised completely till the pelvic scale and taking all the levators completely like a cylindrical disc. And that is what we have now come down again in ELAP. So, but the Heel changed this concept that the most of the nodes are mostly in the mesorectum, not in the fat rectal, and that is why the inferior hemorrhoidal nodes need not to be taken, and that is why he proposed the concept of TME, and that has changed the outcome of the rectal cancer. And this you all aware that this is the mesorectum that you need to excise in all rectal cancers. So as you know, for lower third cancers, either you do ultra low sphincter preserving or APR. But APR is only required in the if the levators are involved or typhoid transanal tumors in which the levators are involved or sphincter complex are involved. And these are the patients in which APR is required. And this is the classification that we use that is very important classification to categorize your patient for lower rectal cancer management. The aim of low rectal cancer surgery should be that the APR rate should be less than 20%, operative risk should be less than 2%, local recurrence less than 10%, and disease-free survival of around 70% 5-year survival. As you can see in all the studies, the initial, there are most of the APRs, all the low rectal cancer, almost 90 to 80% required APR, and with gradually with experience, it has come down to around 25 to 27% and APR rates. The problem with APR is there is a high recurrence rate because there is no cushion of rectum in the radial margin. In the lower rectum, the surrounding mesorectum is reduced by the size and disappears at the level of sphincters. And below this levels, only the sphincters form the CRM, and that is why the CRM positivity rates are high. And it is always a difficult dissection deep in surgery, deep pelvis, especially in male and male with narrow pelvis. There is always also loss of planes. That is why you can see this as compared to LAR, the APR has always had a high recurrence rate and poor overall survival because the recurrence rate was quite high. And this is also, you can see in all the landmark trials, you can see the APR has the CRM involvement higher than as compared to low anterior resections. And if the local CRM is positive, the recurrence rate was also higher, up to 30% in APR as compared to the LARs. Also, the other problem is when you're doing the many times the tumor gets perforated, the chances of perforation is high in APRs. And once the perforation occurs, the chances of recurrence also increases and also survival decreases. So what has changed the concept is there are 3 different approaches for APR, whether it is intersphincteric APR, extra levator APR, or ischioanal APR, depending on the extent of involvement. The intersphincteric APR is required when not because of a sphincter involvement you need to do APR, but if a old patient with poor anal encounter tone, then many times you need to do a APR even for mid-rectal tumors because you don't want to do a lower anastomosis in these patients of poor sphincter tone. In these patients, you can do an intersphincteric resection. Most of the patients in which a real APR is required in at present, where the sphincter complex is involved or levators involved, you need to do a ELAP to have a better R0 resection and lesser tumor perforation. Ischioanal APR is many times required for mucinous tumors and with the levator and eyes are involved, ischioanal fat is involved, or where the perirectal abscess was drained by outside and involved the ischioanal fossa. So this is the plane in which the intersphincteric APR is done. You have to come down here because there is no tumor lower down. Tumor is higher up, but you need to do a APR because of the sphincters old age. You want to do you don't want to do any lower anastomosis. So also intersphincteric APR is better than low heart mass because of risk of pelvic sepsis and discharges and risk of metachronous lesion in these retained rectums. So extra levator APR is what most of the time we need, in which you need to exercise whole levators and then come down. Don't dissect the mesorectum of the levators when you incise the levators. And this is the mostly the required in at present in the APRs. Ischioanal APR is when the ischiorectal fossa, ischioanal fossa is involved, then you have to exercise all this fat also, and this is ischioanal APR. And this is most of the time required if there is a lot of ischiorectal fossa is involved. Most of the time, these are mucinous tumors which were drained outside by suspecting it is a perianal abscess. This is similar. You can see the mucinous tumor. This was drained outside, and then you need to do a ischioanal APR. So coming to the conventional versus extra levator APR, I think it might have been covered. The conventional APR, because of it is done in supine position, so sometimes access to rectal dissection from the rectum is always difficult, and the chances of rectal perforation is slightly higher. In the conventional APR, you take out the mesorectum from the levator and then excise the node. So there are always a coni occurs at the level of pivorectalis or levators. So that is why it has been shown by various studies that the maximum coni occurs at the level of pivorectalis. And in ELAP, because you start and divide the levators outside, so the coning doesn't occur and you get a good cylindrical specimen and chances of CRM positivity is less. So this concept came in 2007 and which showed that the reduction in CRM involvement and intraoperative perforation was less as compared to standard APR, and CRM involvement was reduced from 49 to 20%, and that is why it was proposed to be a better option as compared to the standard APR. But there was a risk of perineal wound complication increase from 20 to 38%. So pelvic in this ELAP, you have to keep in mind that you have to stop dissection at the level of coccyx at the posterior and don't dissect the mesorectum of the levator sani. And it is usually we do a perineal approach, prone jackknife position, and it can be done in supine, but I feel that the prone is much better, have a better view, and you have a better control from if the anterior place tumor is there, you can well dissect from the prostate, and if you can do a shave off from the prostate also. So that is why the limits are if posteriorly you have to stop at sacrococcygeal joint, anteriorly you have to stop at seminal vascus level or cervix, and laterally you have to divide the ligaments. So this is how it requires in the perineum. You have to under vision, you can remove this, and this is how the defect looks like. And dividing the coccyx gives more space in delivering the specimen, and dissection is easier. So prone versus supine, the pros I think is better. That what I feel is prone is takes the time into changing the position, but it gives much better vision and better control, and usually easier for retraction for assistant, lesser CRM positivity and perforations. But it changes operation time increases, and many times you can't use a Grassley's flap or rectus abdominis flaps in prone position. The most of the time you have to use the gluteus flaps or VY plasty. You can do it. So this is the not go. If you do compare, the risk of perforation is decreases with the prone extralevator APR as compared to when a supine extralevator APR. So we prefer doing a prone position APR ELAP. The reconstruction is mostly various techniques are there. Practically VRAM. If you are doing a supine ELAP, then the VRAM is a good flap you can use. Otherwise, if you're doing a prone, then the inferior gluteal artery perforator or a simple VY fasciocutaneous flap is the best, easily available, and you can close it. We have been using mostly the biological mesh in all our ELAPs, and we have done more than 200. And but if the defect is bigger, then we need to do a local flaps. This you can see this is a gluteus maximus flap. And Grassley's, the problem is the bulk is less. So many times if there's a bigger gap, then the bulk is less, and usually it atrophies with long time. The rectus abdominis is still better if you're doing a supine ELAP position. This is one operation in which we have done a VY plasty advancement flap, and this is much easier, available locally, you can do it. This is another patient in which we have done a biological mesh reconstruction. You can see the cylindrical specimen. So I will not go into detail of the biological mesh versus that. I think that Dr. Pradeep Jain might have covered this topic of the pelvic closure. So these are the various studies. So most of the studies I will just go into these are the studies which started and published in 2007, which showed that the ELAP extralevator APR is much better, especially for T3 and T4 tumors. Chances of local recurrence was lesser. And that is why the proposed was it was the ELAP using biological versus conventional APR, that there was no difference in perineal wound infection or perineal hernia in the long term. And this is another multi-center experience which has shown the extralevator associated with lesser CRM involvement and intraoperative perforation than standard tear surgery. So I'll just come. This is the study multivariate analysis. You can see all the results are better with extralevator, whether it is intraoperative perforation, CRM positivity rate, or local recurrence. It is much better in ELAP as compared to standard APRs. So if you could, these are few studies in which they have found that there's no difference in between the ELAP and standard APR. But the problem was most of these studies, the 90% of patients were below 5 centimeter, in which might be compared to ELAP group as compared to 64% in the standard APR group. So this the ELAP is associated with improved CRM with no difference in intraoperative perforation. This is a randomized trial. The CRM positivity rate is lesser as compared to standard APRs. And This is the recent meta-analysis. This also has shown, published in 2019. This has shown also again that the intraoperative perforation and local recurrence are better in ELAP as compared to the standard APR group. So always you can do MR guided. You can see where the rectum, where the levators are involved. You don't need to exercise the levator on the both sides. If the one side is involved, you can tailor it, exercise the levator on that side, and preserve the levators on the other side to have a lesser defect and lesser complications of perineal wounds. So that is called a tailored APR. If you can see, if this is the standard, if there's no levators involved, you can just do a ELAP, taking 1 centimeter margin, leaving it for closure, to leave the levators 1 centimeter. If the only one side of levator is involved, you can take the levators on that side, leave the levators on the other side. If the both sides are involved, then you have to take all the levators on both sides. And that is why it is called a tailored APR. You can preserve the levators if that is not involved on that side. Recently, what has come that I've seen that you can do I have not done, but this is published, that you can do a transperineal extra levator APR using a TIMES device. You can incise this perineal, and after dissecting of a 2 to 3 centimeter, apply the TIMES system, and then you can do under vision and divide the levators from that. Advantage is you need not to change to prone. You can do in the supine position, and then you can excise the levators on the both sides. This is how it can be done to provide the device of TIMES and then do a transparently using our laparoscopic instruments. The conclusion is ELAP is better than conventional APR. Biological mesh is also safe in reconstruction, but a tailored approach might be better in external APR, but more larger trials are needed. So I'll just show a video. I'll just see if I'll show the perineal part. It is not playing. Alexei, I put it there. That is right. So I'll skip the abdominal part. I'll just come to perineal part. Usually we divide the rectum, then put a swab, stitch the swab with the distal end so that it can be delivered easily. And then we make the stoma. This is and this is the perineal part. This is done in prone jackknife position. This is the incision line, and we usually take down the coccyx most of the times to have a better and easier access. Similarly, if the ischial fossa is involved, you can excise more and do a ischial APR. Then we use a lone star retractor to retract the skin edges. That gives a better retraction and a good access. This is the coccyx we are dividing. Once you access the inside, reach inside. This is how I think we have entered the abdomen now. Then under vision, you can divide the levators on our finger. Go as lateral as possible. Divide, excise all the levators. Both sides similarly, you divide the levators gradually and then take out do the anterior dissection later on. Now you can see we have reached, and now the drain that we have placed, that is visible. And on the left side, we are dividing the elevators. Take out the specimen. Then under vision, you can see that the prostate will be seen, and you can dissect from the prostate. Always be careful that you should not injure the urethra. Be careful, but always it is easier to do because under it is everything is under vision. Last bit also. Good. Even if there is some bleeding from the prostate, you can always suture it using proline. And that then we place usually a biological mesh. We usually place a drain over the mesh and then close the subcutaneous fat. And this is how it looks like. Thank you.
Any questions? Sir, I have one question. What biological mesh do you use, or is there any replacement because it's not available in Mumbai?
Yeah, it is available. It is many times it is out of stock, but it is the barred mesh we have been using that you can use. It is available.
So it's been for a while, it has not been available in Mumbai.
But it has been available for last almost 8 years I have been doing, and biological mesh they have been available. It is sometimes short, but keep your stock because most of the time it is difficult. But you can use the proceed mesh also. Worst case, you can keep the vehicle side on the other side, but the chances of infection is slightly higher with this. Otherwise, VY plastic is easier. You can just do it.
We do it with VY plastic.
We would like to invite next speaker, Dr. Sheikh Mohammed. Interesting videos, transanal resections.
Thank you very much. And thank you, Dr. Deep sir, for inviting me and giving me this opportunity. So I'll be talking about the transanal procedures for rectal cancer. Transanal procedures for rectal cancer can be used both for early rectal cancer as well as for advanced rectal cancers. And they can be classified as open as well as minimally invasive. Traditionally, open procedures known as transanal TAE, transanal excision. They can be used for lower rectal cancers within 5 centimeter, 6 centimeter from anal verge. And then Harold Buse in 1984, he devises the TEM platform, which is still used in many centers. And then Sahamatullah in 2010 popularized TAMIS. which is very popular and gained rapid acceptance across the world. And then this was followed at the same time by TATME by Patricia Celia. I think she's speaking today. So what is TAMIS? It is just a transluminal minimally invasive surgery, first described in 2010. We put a port which is specially designed for it, and it sits across the sphincter complex, and it has a gel point path from outside, and then further dissection can be done once we put the instruments through these channels. It's very easy to use, and indications are T1 rectal cancer or TIS, or wherever there's a doubt there is an adenoma or a cancer, and you don't have a great gastroenterologist around who can do it, or do an EMR or ESD and lands up with you. But since I do colonoscopies myself and I also do EMRs myself, so I prefer to do a TAMIS wherever I find that this can be cancer and I should take a full thickness, thinking like a surgeon. So the indications have been very much described, and you can find them less than 1 centimeter, less than 3 centimeter from the should be the size ideally. But we have studied the indications as our technique improved and our experience improved. The workup is as for in cancer. You suspect it is a cancer, and please work up exactly thoroughly for cancer. Take biopsies initially, so that it should not be poorly differentiated. It should be well differentiated. There are two platforms which can be used. Dr. Atalay described it with SILS-port, and we also started with the SILS-port initially in our hospital. We didn't have gel point path available at that time. So you can just insert a SILS-port. It's cheap, it's easily available, and it can be just inserted, just cost 11,000 rupees. You can just put it inside, put the ports, and then start the work. And now we have shifted to gel point path. Because it is time specific, it's transcranial specific, it gives more versatility. And once you remove the specimen, or you want to put a gauze, or you want to do any other maneuvers, you can just remove the cap and let the port, the channel stay there. So this is the reservoir bag. It gives a continuous air supply and not a pulsatile air supply, because mostly what we use is the abdominal insufflator, carbon dioxide. So position is always thought to me. The surgeon stands in between the legs. So this is a representative video. We had done around 36 cases of TAMIS so far, and we've published our results in various journals. So he's a 48-year-old gentleman who came directly to me that do TAMIS on me. So he had a relative in the US, and he told him that go find a surgeon who can do TAMIS, because it was T1 cancer. It was a cancer, and two surgeons had advocated LAR with a early closure of ileostomy as well. So when I saw him, I said I will do the sigmoidoscopy myself. I assessed him and then planned for TAMIS. So I had edited this video, but unfortunately, it couldn't get downloaded. Can I just fast forward it? So this is the lesion. As you can find, it is present at around mid-rectal valve, which is around 10 centimeter from the anal verge. Mid-rectal valve corresponds to the peritoneal reflection. Since it's lateral, anteriorly, if it is located, most of the times you end up in opening the peritoneum as well. So first you assess the lesion and then start scoring it. How can I fast forward it? Can you please help me in forwarding it further? In forwarding the video? Excuse me, the IT team, can you please just help me? So feature होता है ना, जिससे you can I can forward the video. Yes, thank you. Thank you. So you assess the lesion after putting the TAMIS platform, and then use a conventional hook and cautery, and then score the lesion around 1 centimeter. Then deepen the dissection. Deepen dissection. This is the same laparoscopic hook which is used for laparoscopic cholecystectomy. The crochet bowel grasper, which is used for handling the bowel in abdominal surgery. No special instruments are needed, but if someone wants to use the curved instruments, then it's the personal choice, but we don't use any of them. Deepen the dissection and expose the perirectal fat. So this way we dissect all the layers of the rectum. So the T staging is more accurate in it. This is mesorectal fat. You have to just go into that, and this means that your dissection is full thickness. And once the specimen will be analyzed with the pathologist, there will be better interpretation of how much it is. It is T1, T2, or T3. Whereas in ESD or EMR, you only remove superficial mucosa. You don't go beyond submucosa. So this is a further advantage, that the staging is more accurate, and the dissection and the oncologically, I think it's sounder to do TAMIS when you suspect a cancer than to do an EM or an ESD. Just deepen the dissection further, and then what you have basically, the advantage is that you get an intact specimen. You don't get a fragmented specimen. The chances of specimen fragmentation with TAMS is very low because everything is under vision and it is under control. And then you take the entire specimen out and then you orient it properly on a cardboard and then give it to the see, this is an intact specimen. There is no fragmentation. It's very well controlled. Very little bleeding in it. It seldom bleeds. So then this defect is usually closed with 3 V-lock sutures. I use 2 V-lock sutures from 2 ends. I find it easier to start from the corners rather than go and just narrow it on the one end. So you can close it the defect transversely depending upon the size of the defect, or you can just close it longitudinally depending upon the orientation in the rectum. As you can see, the timing by 33 minutes is over. It's a very fast procedure. I mean, I'm considered as a slow surgeon. Within half an hour, it's over. If you do ESD, the gastroenterologist does an ESD, he takes like 5 to 6 hours, even the trained ones. And then after that, then you have this is how the specimen is then mounted on the. I use this thermocol which is available in the OT, and then I will go to the pathologist myself and tell him that please cut it vertically, and then tell me about the depth of the lesion so that I can take further steps. And you have to tell patients preoperatively that your disease might be upgraded. So be prepared for a formal resection or any other surgery. I always take a consent for that. In this patient, final biopsy was T1 cancer, and I recently did his follow-up sigmoidoscopy. It was normal. I did actually colonoscopy, and he will be having normal. It was a smooth muscle upper, only 1 millimeter, just less than 1 millimeter was involved of the submucosa. So he's under follow-up. He no LAR and nothing for him. Now we shift to the transcendental total mesorectal excision. It is basically same. You have been seeing excellent and marvelous videos of TME, which are mostly from upside. So TME is up from TME from upside down. So basically, you go from below for low rectal cancer, so especially within 5 centimeters from anal verge, which are difficult to handle in a narrowing pelvis. The most important part is how to get a good distal margin. One of the risk factors for local recurrence is actually having not adequate distal margin. And if you fire stapler blindly from above, then you can't have an accurate idea of the distal margin. Especially all the staplers will end up in coning the specimen and cutting it in a oblique fashion. So you don't get a good transaction line perpendicular to the specimen. Either you do a TATA, what is known as Tata procedure, or you do TATM, whatever you're comfortable with. So there has been a lot of evidence. This is the color. This is a video lecture. So again, this procedure is same. You stand between the legs. TAMIS is the starting step for the TATME. So first step, surgeon should start with TAMIS and then shift to TATME. So basically, this is how you see. I don't from above you can never measure distal margin. From below you can. Here I measured distal margin. I demonstrated it. That look, we can see 2 centimeter, 3 centimeter, whatever you want. You don't have to imagine. Just see it and then take a pulse string. So now with that concern of Norwegian trial, which which they had initially problems with the local pelvic wall recurrences. So I always take 2 pulse strings from below, so to make the lumen more secure, so that there is no splage of contents and possible splage of theoretical possible splage of tumor cells. So after I take 2 pulse strings, and the next step is to irrigate it with the betadine solution. It's supposed to be tumoricidal, so I always do it. And once you take, this is for low rectal cancers. I cannot take a pulse string by putting the plate. See, the tumor is so low that I cannot put a TAMIS platform and then take the pulse string. We have done it very in some cases, as will be shown in a video subsequently. So you just insert a gel point path, and then it's very easy to install once you secure with the silk sutures or silk sutures the channel. After that, you put the gel point path, then connect the reservoir bag, because it gives you a continuous supply of carbon dioxide and not the intermittent one, because of which there is no pulsatility, there is no billowing of the rectum. So the rectum doesn't collapse once you're doing the surgery. So then connecting to the reservoir bag, it makes it easier to perform the surgery. So this endoluminal pulse string can also be taken. If the tumor is a little bit high, then you can just insert the gel point path or Sills port first, and then under vision take a pulse string suture and then tie it. So this opportunity comes very rarely. So we done only once or twice. So this is then you at the end of these mucosal folds, then you start doing the rectotomy. So you can start by the side of the midline, or it is around, let's say, laterally, and then start going start in the midline, not exactly in the midline, say around 5 o'clock, 7 o'clock position, and then go laterally, and then accordingly then ask the abdominal surgeon, the abdominal assistant, who is usually a resident or your colleague, to guide you once you are closer to the peritoneal reflection. So from above, he can just put an instrument and then see whether you are going to the right plane. And it's a combination of dissection. The abdominal assistant will guide you how to correct your planes, because these planes are not normally, we don't enter these planes normally. Most of the surgery is done from above. So here then we make a rendezvous. We can make a rendezvous posteriorly as well as anteriorly. Wherever it is, though it is recommended, you should do the anterior part last, but you can do it initially also if you are having any issues or trouble in finding the correct planes, and then extend the dissection laterally as well. So this is I have combined couple of videos to demonstrate the salient features. So this is the atraumatic grasper, 45 centimeter. So the abdominal assistant just pushes it in the anterior peritoneal reflection, just below the prosthesis. This is a male patient. The previous one was a female patient, and then the dissection can be guided from above. And as you can see, this is the posterolateral dissection, and this is the TME plane. As Dr. Shivendra said, you stop at the elevators from above, and then you can dissect from below. You can also have this option as well, and you enter exactly the same plane as you are entering from above. So these planes are preserved. If you have entered from above, you have not disturbed the planes from above. From below also, they'll be preserved, and then you enter exactly into the same plane. As you can see, the mesorectal envelope is intact in this patient. And going to the avascular plane, the holy plane of Bill Hill, you can just go into that, and then subsequently make a rendezvous with the abdominal part. Once you have done the abdominal dissection, the pelvis is empty at that time. Usually it is heralded by discharge of some serous fluid, or you can just feel the abdomen. As you can see, the posteriorly here, the abdominal rendezvous has been made. And then extend the dissection laterally and divide the further attachments. As you can see, these are those Billy's buttocks. As you can see, the bulk of mesorectum is intact. So we do both since we have an organ specific specialty at Gangaram Hospital, colorectal division. So we do both for benign as well as malignant. It helps to correlate the principles in both, and it makes our job easier. So the laterally, there is if you go too laterally, then there's bleeding. If you have to stay just closer to the mesorectum, and then divide the final attachments. In this perineal part, we don't push the rectum, pull the rectum, we push it. So we don't, there's no stretch on the specimen. It is always a push towards the abdominal cavity. That makes it less traumatic for the rectum. And if you have secured the pulse string well, then there's no spillage of cells. These are the final parts of the dissection. It should be sometimes if you go a little later, there's bleeding, and then that has to be controlled. You can use it with cautery, or you can use it any energy source that's comfortable. And then freeing the specimen, I usually avoid taking them out transcendentally, because the cancer surgery, rectal cancer surgery is specimen-oriented surgery, and I don't want to disturb the bulk of the mesorectum. I don't want to disrupt the mesorectum. I always make a small pen and steel incision and deliver the specimen from there. And then the pelvis is empty, and as you can see, it is a sign of complete dissection. You can appreciate the nerves as well. So the anastomosis after this can be hand sewn as well as stapled. We end up most of at the times doing coloanal anastomosis. I think our time is up. Thank you.
Indication of TATM, because I somehow not able to perceive that it gives us any advantage from what we do.
See, the real indication for TATME is sphincter preservation for lower rectal cancers, especially in you can do insert. You make the perineal pelvic part of the lower pelvic part dissection easier. Now, the indication what I find is your choice of distal margin. You see the distal margin and you choose it. So either you do a TATA, or what is now, you first choose that you first see the distal margin, choose it, take a pulse string, make a dissection around, and then you start the abdominal part, what is known as data operation. Or you do it under vision and then see the dissection margin yourself, take a pulsing and proceed under vision rather than blindly. Because instead of firing from above, you disrupt the rectum from below and make a transverse transection of the rectum from below. Absolutely.
Like what you say.
Every patient does not need ISR. In classical coloanals, most of the patients which I have shown, they did never, none of them I did ISR. So these patients, you can do ISR also. If you do robot, you can go up to lower down and then do ISR, take a pulse string and proceed with the dissection above. It's entirely the choice of the surgeon. But for coloanals, most of the times, and I always use for coloanals, where I have to choose a distal margin, it's very low, and I have to preserve sphincter, there I use, and especially the patients who are females, especially patients who have high BMI. The highest BMI which we have done is 42. And so that is how it helps us. And we are registered with the International TATME registry. So our results are continuously being monitored and continuously data is coming out. Recently data came from 2,300 patients. It is safe, feasible, and oncologically sound. It's not inferior to the lab. Color 3 trial is going on, which will tell us whether
Complication rate of TATMA is reportedly very, very high.
it is not very, very high. In fact, since this is a video lecture, so that is why we see in our what we have our limited experience. So we just have we just had one leak and we just did an IR. So we did, they are all coloanals.
Injuries and bladder injuries are.
We have not seen in our series bladder injuries. It has been reported the urethral injuries occur. Initially, Patricia Celia also reported because she's the one who did the most initially. So then the surgeons adjusted to the plane and they didn't go into the urethra. They went just below it. That is why it was a urethral injury was initially reported. Subsequently, it was settled down. So the complication rate is not very high compared to the conventional coloanals or any procedure which we do in which you do lower rectal anastomosis.
Sir, I have a question.
Yes.
Have you used instead of the gel port, have you used the rigid TATME, the Castors?
I did it once at TEM platform. It is very cumbersome, time consuming, and does not give the flexibility of moving in all quadrants. And then it takes time to set up and it doesn't have the same. I would say I personally have used it only once. And then I found that it's expensive as well. So I dropped it. Yes.
Thank you.
So one question.
Yes.
Gel ports are how many times we can use like this?
Gel ports, usually they are single use gel ports, but in India we have been reusing things. So you can use it it costs around 80,000 rupees. You can distribute the cost among 4 or 5 patients. That's how we make it economical.
Thanks.
Okay, thank you.
So we would like to invite next speaker, Dr. Respected Subramanyeshwar Rao, on the topic conundrum of enlarged pelvic lymph node.
Thank you. Thank you. This time I saw so many videos on YouTube. Good evening. Thank you, Deep, and all of you in Delhi. Clinical stage 2 and 3, lower rectal cancer, especially that is at or below the perineal inflection, develop metastasis to lateral pelvic nodes. The common iliac, internal iliac, external iliac, and the obturator nodes. And what is important is these lateral pelvic nodes are located outside the surgical field of TME. Studies report an average of 18% incidence in T3 or T4 low rectal cancers when dissected, when they are negative clinically, radiologically. When dissected, you find 18% of them are positive. Why did we choose to discuss? Obviously, the optimal strategy to deal with lateral pelvic nodes in locally advanced rectal cancer still remains controversial. Those are the heads on which I will be discussing. The lower rectum is distinct from the intraperitoneal part of the rectum in its lymphatic drainage to the iliac artery lymph nodes. Both in venous drainage and lymphatic drainage, it's distinct. Number of anatomical studies have demonstrated the distribution and drainage of lymphatics to these nodes along the pelvic side walls, which lie beyond the mesorectum. That's where they are. The lower rectum drains along two major routes. Generally, the lymph nodes follow veins, but here they follow the named arteries, the superior rectal artery, the middle and inferior rectal arteries. The standard TME approach dissects around the superior rectal artery and the inferior mesenteric artery, but the lateral group nodes are not routinely resected. The TNM staging understands the presence of pathological lymph nodes in the internal iliac group as regional disease, and when it goes to external common iliac lymph nodes, they are treated as metastatic disease. One distinct feature of TNM for any organ system is for rectum, because all pelvic nodes in any other pelvic organ are considered as regional except in rectum. Japanese consider them as all regional lymph nodes. MRI is very important. It's been discussed for the past 2 days. I realized the low rectal cancer study group and Japanese Society of Cancer of the Colon and Rectum suggests nodal size measured on MRI and or CT scan to determine which nodes might be needed to be considered as malignant. It's not just the size, but the nodal characteristics, which are also very important. You can see the scans and the dissected part that the region is completely different. So basically, you need to step aside to do these dissections. In any GI organ system, west and east do not meet, at least in the initial part of the journey. So they've been drifting apart. TME has been the gold standard, whether you talk about the holy plane or the importance of TME in saving lots of lives by decreasing the loco-regional relapses. And then CRM is the focus, whether it's for the pathologist or the surgeon and the other specialists. It's all about CRM, which is the strongest predictor of local recurrence. So neoadjuvant chemotherapy and radiation therapy has been the practice in the West. So lateral pelvic nodes are neglected and ignored. Whereas the East, lateral pelvic lymph nodes become loco-regional. So anything that is loco-regional needs to be dissected by upfront surgery. So routine dissection for low rectal cancers below the peritoneal reflection. Evidence is there for both the groups. The Dutch rectal cancer trial and the Swedish study concluded that metastasis to the lateral pelvic lymph nodes are not important enough for local recurrence in rectal cancer. And they surprisingly got support from 2 Japanese studies by Watanabe and Nagawa that PLND is not necessary as a curative option, and neoadjuvant chemotherapy radiation reduces the irreversible risks of postoperative functional disability associated with pelvic lymphadenectomy in advanced rectal cancer. Therefore, North American and European guidelines, societies and guidelines do not talk about prophylactic lateral pelvic lymph nodes as a routine. Only when they are clinically suspicious or stay on the MRI, only then they are dissected. Despite the known benefits, what we need to understand is pre-op chemoradiation prior to TME, the literature consistently supports the fact that when dissected, you have nodes, and when left alone, you have relapses. The truth is that the lateral pelvic lymphadenectomy was explored by the West. It's not generally Japan and the East takes leadership in terms of lymphadenectomies. We are the ones who are chasing the lymph nodes in general, but here West started investigating this, but they took a step backward because the morbidity was significant when compared to the advantage that it gave. In Japan, the surgical approach has always been to chase lymph nodes in every GI organ system. So, and they've also justified it by dissections, which showed anywhere from 15 to 20% of patients with clinical T3, T4 low rectal cancers showing a pathologically positivity. Is it regional or distant? When you look at, if you look at these graphs, they actually converge at N2A and beyond, which means N2A and intrailiac lymph nodes, when dissected, when treated adequately, the survivals are the same. So a mesorectal node, a classical mesorectal node or a lateral pelvic lymph node, if it is treated adequately, the survivals are the same. So which only means that the node is regional. Metastases extending beyond the intrailiac area, however, are associated with poorer survival, and that justifies the TNM labeling anything that is external iliac or common iliac as distant metastasis. The landmark study, the prophylactic lymph node dissection study from the JCOG, showed that the relapse-free survival, it's a large study of 701 patients. Most of the tumors were below the peritoneal reflection. There were increased complications in the lateral lymph node dissection group, much higher than the other group, but not statistically significant. But when you look at the early results and then especially the long-term follow-up results, the pelvic recurrence, when you look at, is significantly less in those patients who have been dissected. Cumulative local recurrence and the lateral recurrence-free survival, when you look at, it seems to be better in the lymph node dissection group. The long-term follow-up data did not support the non-inferiority of the mesorectal excision alone, and the Japanese would now suggest that in stage 3 you need to dissect. In stage 2, probably you can leave them alone. Extended lymphadenectomy and pre-op radiotherapy studies done, observational study in T3 or T4 rectal cancers, the neoadjuvant chemoradiation seems to be an equivalent alternative to lateral pelvic lymph nodes. Support for the West, there was a comparison between a study in Netherlands and Japan, which says that both extended surgery and radiotherapy plus TME give equal control. But however, both the studies, the indication for the lateral pelvic lymph node dissection was not strictly defined. When dissected, a systematic review, 20% of radiologically responsive nodes also contained metastasis, and 25 to 83% persistently clinically suspicious pelvic nodes following neoadjuvant chemotherapy radiation therapy actually contained pathologically proven disease. So it has been a roller coaster ride for the lateral pelvic lymphadenectomy. A large meta-analysis suggests that the lateral lymphadenectomy does not offer any oncological advantage. Post-neoadjuvant chemotherapy, is TME enough? Once again, a Japanese study says that when MRI, the node size is more than 7 centimeters, and then after chemotherapy, if it persists beyond 4 millimeters, there was a 50% risk of local recurrence, and if it was lesser, it would drop down to 8.7%. So you can actually see that the size of the node becomes extremely important. Size before chemoradiation, size after chemoradiation, both. Can chemoradiation allow for omission of lateral pelvic lymph node dissection for advanced rectal cancer? Patients with short axis diameter anywhere around 10 millimeters are a potential subgroup for high risk nodal disease even after chemoradiation, so they deserve to be dissected. Chinese study, post chemoradiotherapy, lateral pelvic lymph node, short axis diameter more than 7 millimeters, and poor risk histology, signet cell or mucinous adenocarcinomas could be used as for predicting local lateral pelvic lymph node metastasis after chemoradiotherapy. So lateral pelvic lymph node dissection should be carefully considered in patients who have lymph nodes already beyond the obturator or internal iliac region, because it may be considered metastatic and may not actually benefit the patient. A prospective ongoing study started in 2000, ongoing now, enrolling patients with locally advanced low rectal cancer and enlarged lateral nodes with different strategies of interiliac and obturator nodes, as well as standardizing MRI measurement and lateral pelvic lymphadenectomy with peer-reviewed video analysis a very strong study. We should await what is going to happen from here. The primary aim is to understand the lateral local recurrence at 3 years. Lateral lymph node size and distance, when you look at distance from the anal verge, what seems to be important is initial size of 6 millimeters or more with tumor below 5 centimeters from anal verge. So lower the tumor, the size becomes lower, size of significance becomes lower, or initial size of 8 millimeters or more with tumor above 5 centimeters of anal verge may deserve to be dissected. So is it time for a global approach? It doesn't seem to be so at this point in time, but you can, whenever you cannot decide clearly, you divide them into scenarios. The TME alone for the low risk, TME or TME plus lymphadenectomy for the moderate risk, and then the high risk for all of them, lateral pelvic lymphadenectomy. That could be the suggested algorithm. NCRT to include pelvic sidewall and restaging MRI after 6 weeks. Non-responsive nodes more than 4 millimeters, do a lateral pelvic lymphadenectomy. Responsive nodes, you could do a TME and keep them on surveillance. Could sentinel node be attempted? We started doing a small study. It was an extrapolation. We've been doing lots of gynae sentinel nodes, which has become a standard of care now. And this is one of our few patients. We are in single digits now, wherein you inject peritumorally after chemoradiation. There is a significant yield of lymph nodes, although it's never equal to a virgin pelvis. For endometrium and cervical cancer, the channels are much better seen, but for the rectum, there are nodes seen and nodes that can be dissected. There's a clear channel there, and there was a node that was dissected. If I can complete this video, that's where it is. Laparoscopy and robotic versus open. Once again, the short-term outcomes are better, and then in those depths, I think minimal access works well because you can see the anatomy better. And what is also important is to bring in extrapolation from gynecology. I don't know if Avanish is there. Avanish has learned from his wife, who's a very eminent gynecologist. I've never been as lucky because my only wife is not a gynecologist. So. And what is important here is to understand that the nerves are in the middle. They are in a different plane again. So there are 3 planes here: the lateral pelvic plane, the rectal plane. You can see the pararectal fossa, and what is important is the dorsal mesoureter. That's where all the nerves are. That's where all the nerves are. So you can actually see, as long as you preserve this, the morbidity should be less. Both the vessels and the nerves of the ureter come from behind and come from lateral aspect. So I think oncologists trained in gynec surgery, or their husbands, spouses rather, are at an advantage while doing pelvic lymphadenectomy, because Japanese took an hour extra, 1.2 hours extra to do the pelvic lymphadenectomy, which is a very rare situation for an oncologist because it's done on a daily basis. So I think it's good to learn from others the way Avanish did the prostatectomy. It's important to learn, keep on peeping into other operation rooms, not bedrooms, operation rooms, and learn. Thank you very much.
In this sentinel lymph node biopsy in rectal cancer, how much and where do we inject the ICG dye?
We did it peritumorally. We don't know what is the best, to be very honest. We just started. It's a part of a Dr. NB resident's thesis. We just started. Not much work. Japanese again are ahead of us, but not much work again from them. So We just wanted to do it because otherwise we are a believer of not doing it if it is not, if there are no nodes. Either there are no nodes before treatment, or if there are no nodes after treatment. Somehow I cannot believe that there can be so much morbidity. Somehow I cannot. Once you increase, do numbers and preserve these nerves and the blood supply, I think the morbidity will come down. Like any other procedure, when you did a 3-field in esophageal cancer, the morbidity was tremendous. It's come down significantly. So I think it's important not to be caught down by initial morbidity. Same thing happens to TATME also. TATME, it was almost forbidden for a while, but now slowly there is renewed enthusiasm, and that's the reason why Deep Goyal must have included it.
Thank you very much, sir, for your excellent talk. So thank you very much.
I thank Anvesh for helping me with the presentation. Thank you, Anvesh. Anvesh is here.
Thank you, speakers, for the comprehensive talk and the wonderful demonstration of the advanced surgical techniques. So now for the next session, I would like to call upon our next speaker, Dr. Durgatosh Pandey, to speak on the hostile pelvis, what to do, and its conversion to open the answer. And I would like to call upon chairpersons to kindly come on the stage and chair the session. We are running behind the time, so it is requested for the chairpersons to limit the questions to the minimum. We can discuss during the tea time. Thank you.
Thank you so much for the invite, and thank you, Dr. Deep, for this invite to me for this lecture. So my talk is on, in context of rectal cancer, when we encounter the hostile pelvis. So what do we do when we encounter a hostile pelvis? Is conversion an answer? The short answer to this question is yes. Of course, conversion should be considered whenever we find a difficulty, or whenever we think that an adequate resection cannot be done or a safety cannot be achieved. So we will divide this talk with difficulties in rectal surgery, about difficult pelvis, the factors predicting a difficult pelvis, what are the troubleshooting things that we can do, and something about conversion as well. So we all know that rectal cancer surgery, we have to do a dissection in a limited surgical field. There is limited space in the pelvis, limited vision and access, difficult introduction of staplers and other things. And laparoscopy and robotic platforms have actually improved this by better visualization of the surgical field, and robotic by the better ergonomics, stable camera, and degrees of articulation. So the advantages of minimal access surgery, everybody has already said this: enhanced vision, which in turn leads to increased dexterity and maneuverability, which in turn leads to controlled dissection, adequate margins, and less blood loss. Now, successful minimal access surgery depends upon appropriate case selection, adequate surgical skills, which will lead a discussion to a learning curve, adequate machinery and ergonomics of surgery, and team effort. What are the factors predicting difficult surgery? There are patient-specific factors. If the BMI is very high, more than 30, a male pelvis is generally narrow, comorbidities of the patient. There are anatomical factors, deep and narrow pelvis. If we look at it objectively, the prominence of sacral promontory, the degrees of sacral curves, size of the pelvis, interspinous distance, the pelvic inlet and anteroposterior diameter of midplane, the sacrum pubic diameter, the angle between the pubic symphysis and sacral promontory was actually correlated with the quality of TME and the margin positivity rate. Then there are tumor and tissue related factors. A bulky tumor, of course, has a more difficult, more chances of difficult dissection there. the tumor site, lower rectal cancer, bulky mesorectum. The tumor may not be very bulky, but the mesorectum itself may be quite bulky. Neoadjuvant chemoradiation sometimes can lead to some tissue edema, fibrosis, etc. Locally advanced nature of the tumor, mesorectal involvement and beyond. By beyond, I mean involvement of other structures, involvement of the presacral fascias, etc. Then there are surgeon-related factors related to experience and learning curve. Now, we come to the reasons of conversion. The foremost is inappropriate case selection. When there has been a prior pelvic surgery, whether it is open or laparoscopic, if there is a less working space, a very narrow pelvis, obese male patient, big tumor in a small pelvis, timing mismatch after radiation therapy. Then the next factor is inadequate surgical skill set when the learning curve has not been achieved by the primary surgeon as well as the team. It's not just the primary surgeon who is responsible to conduct a safe, complete laparoscopic surgery. It also depends on the entire team. So this was one of the publications which said that 55 cases for right-sided colonic resection versus 62 cases for left-sided resections is essential. Now the learning curves have reduced a bit. Now people say that 20 cases should be an adequate job if you have done them carefully. These are the factors affecting the learning curve. The next factor is need for appropriate machinery. The modern laparoscopy platforms like 3D systems, use of adjuncts like ICG, identification of ureters in difficult pelvis, and the robotic platforms have also made things much more simpler and reduced the conversion rates. Now, what do we do? How to circumvent when we encounter an hostile pelvis? Now, there is a standard technique to do a surgery, which we are all aware of. When we encounter a hostile pelvis, we need to modify our techniques and change it occasionally. So early identification of vasculature, for example, early identification of ureter, if the ureters are not seen very easily, we can go above the pelvis, outside the pelvic brim, look at the ureters in the retroperitoneum, go down, and these are ways in which we can save the ureter and circumvent an hostile pelvis for that reason. Increasing the magnitude of resection. Sometimes we can divide the, let's say, the tubes in a female. Sometimes we can do a hysterectomy in addition. For these things, appropriate consent is mandatory, but these being prepared to do these things will actually help us in circumventing a hostile pelvis. Retrograde hysterectomy, as I said. This is one example of, this was actually in a gynec case, this publication, but this is one example of how to modify the surgical techniques. You do a retrograde, first divide the vagina and then lift the cervix and then dissect it off the rectum. These are things which can easily be done. Going ahead with troubleshooting, as I said, modifying the surgical techniques whenever it is required, changing the standard planes of dissection. If we are not able to go into the standard plane, change the plane, go into a vascular plane, go into the plane just near the ureters, go into the plane behind the, let's say, the nerves. Sometimes being prepared to do an extended TME, use of fan retractors and suction evacuators have also been quite helpful occasionally to troubleshoot, specifically anteriorly. When we encounter problems anterior or anterolateral, hitching the uterus to the abdominal wall, as Dr. Subramanieshwar Rao very succinctly pointed out in his video, helps. We should be prepared to resect the seminal vesicle as well. Anteriorly, this is one example of a disease invading the right seminal vesicle in which it had to be resected. Anterolateral mesorectal involvement, the right vascular approach with seminal vesicle resection can be done here. When we encounter the problems laterally, then the vascular approach helps. Early identification of the vessels, identify the iliac vessels. If required, do the lymphadenectomy there. That gives you a lot of planes. As we often see in gynecological surgery, when we do a radical hysterectomy, development of planes is always easier when we have completed a lymphadenectomy. So those gives additional planes. The ureteral identification techniques with fluorescence ureteral navigation is important with ICG, let's say. This was a long segment colorectal disease invading the gonadal vessel, ureter identification by fluorescence and gonadal transections. Again, ureteral identification. If the problem is posterior, be prepared to sacrifice the hypogastric nerves. sometimes sacral resections, but these are things which are not easily done laparoscopically, the sacral resection part. Presacral fascia involvement. Now we have been taught from the very early times that if we go behind the prerectal fascia, there is torrential hemorrhage. There is a chance of torrential hemorrhage. While that fear is genuine, but sometimes we can go behind the presacral fascia carefully and resect the presacral fascia along with the specimen. These are things which are beyond TME resections. So conversion. Avnish showed us that the rates of conversion from laparoscopic to open surgery, the incidence is 10 to 23%. The reported risk factors are, as I said, high BMI, ASA more than 2, surgeon's operative experience. These are the trials which was mentioned earlier. And MRC classic trial, they said that the reason for conversion was either the tumor fixity, which was 41%, obesity 26%, anatomical uncertainty was 21%, and inaccessibility was 20%. These are the different trials with different conversion rates. We have been getting better and better. The robotic is the least 8%. The predictors of conversion, we already mentioned: sex, the gender, BMI, tumor size and location, neoadjuvant chemoradiation, anastomotic height, histopathological features, the surgeon's experience, anatomical dimensions of the pelvis, etc. Conversion is an option, but it is not the only solution in difficult circumstances. We have already come across things in which we can circumvent a hostile pelvis. However, we should not persevere too much so that the damage is done before we convert. So an early or preemptive conversion appears to have a more favorable outcomes than a reactive conversion. When we have already made a damage and then we convert, it is then that the problems start, whether it is because of the post-operative complications or a long-term outcome. So does a surgical conversion affect outcome? The results after converted laparoscopic resections for rectal surgery are less favorable than those achieved by patients who had a complete laparoscopic surgery. The long-term oncological outcomes are also inferior in patients in whom the surgery was started as laparoscopic and then later converted. But there are shortcomings of these studies because there is a lot of heterogeneity of long-term oncological outcomes, and there have been a lot of reactive conversions than a preemptive conversions. As I said, if we assess the disease well and convert earlier, the oncological outcomes and the oncological outcomes as well as the post-operative outcomes, immediate post-operative outcomes, are not likely to be worse. But if we persevere to an extent that a damage is done, then those outcomes are likely to be worse. So is conversion bad? Conversion should not be considered as a defeat, but should rather be seen as choosing the most appropriate way of safely achieving a procedure. See, what is required in a cancer surgery is to do an adequate procedure by whatever means and do it safely. These are the two things which are paramount. If it can be done better by a laparoscopic or a minimal access approach, go ahead and do it. But if things are more difficult, there is a hostile pelvis and we are not able to do it safely or adequately, conversion is certainly an answer for those things. It is best considered as an alteration of operative plan to overcome difficulties and avoid further problems. If there is any doubt about safety or effectiveness of the laparoscopic procedures I just mentioned, it should be converted to an open approach, irrespective of possible feelings of failure in decision-making, disappointment, and discouragement on surgeon's part. And as I mentioned earlier, early and preemptive conversions appears to have a more favorable outcomes than reactive conversion. Thank you very much for your patient listening. Yeah.
Any questions from the audience? Yes.
I'm not as skillful as you, sir.
Actually, it's brilliant. You finished early. Any questions from the audience? So when you said that you go behind the rectal fascia to operate, I know I'm a medical oncologist, but does that happen often?
Not very often. But what we call about as a holy plane of Hield, where does it exist? It exists anterior to the presacral fascia and posterior to the mesorectum, posteriorly. And that is a bloodless plane. When we get into the presacral fascia, and this happens more often when we go in, and there is a point where one has to turn perpendicularly, one has to turn at an angle. So whether you're doing open surgery or laparoscopic surgery, you go like this and then turn like this. It is at that point that sometimes the tumor is stuck to the presacral fascia. And there we should not hesitate actually to take the presacral fascia, make an incision on the presacral fascia and take it with the specimen. Yes, there is a chance of bleed. The presacral veins sometimes bleed torrentially, but if we do it carefully, it can be done. And sometimes we can approach it from lateral side where the bleeding chances are less and then come to posterior side. So we have to be very flexible in our approach of surgery. If we are rigid, then if we encounter a frozen pelvis, the only answer is to convert. If we are a little flexible, then we can actually get around in 50-60% of such cases.
Thank you, Durgadosh, for such a lovely balanced view. Sometimes to go behind the presacral fascia, you have to take the nerves, hypogastric nerves,
Yes.
and then go behind them. That's a good marker for to go behind. I think hostile pelvis should not be dealt by people who are not trained in dealing with that. That's number one, irrespective of whichever technique you want to use. If you have a very good robotic surgeon like Avnish, he can probably do all cases by robotic method or laparoscopy, because it's in a hostile pelvis. I personally feel that converting to open for a person who's not trained to do that kind of job will be a nightmare again.
Yes. Hostile pelvis is not just hostile in laparoscopy, it is also hostile in open. It is just that we have a better, more control when we have opened and have things in our hand. It is just that psychological feeling that we have a greater control. But hostile pelvis is a hostile pelvis, whether you approach it in whatever way.
I would like to hear some words about if there is some torrential bleeding, how do you manage?
So most of the times we will manage it by compression. So you do a compression for a long time. Most of the times it stops. Sometimes we have to take sutures. And when we take sutures, we have to be careful to take sutures very precisely, because if we go far away, then we can actually increase the bleed. It may tear. People have mentioned about the stacks.
Absolutely.
The stackers.
They work so well. And they are the only respite when it really
in difficult
bleeds.
situations.
So we sterilize now. I would have lost a patient if my colleague, my senior colleague, who is a surgical gastroenterologist, Professor Pratap Reddy, did not tell me this. Such was the bleeding in that patient. So thumb tacks, just push it onto the sacrum. Irrespective of the age, it just goes into the cortex and instantly it stops.
The tacks will go into the bone and then it will stop the bleed.
Thumb tacks, yes.
Any experiences with hemostatic agents or packing or surgical?
Packing, as I mentioned, you can pack, but hemostatic agents.
Longer period of time, say 24 hours, 36 hours or 48 hours, and go back and take out the packs.
So I have not this hemostatic agents. I have not experience in the rectal cancer surgery, because as of now, I don't do colorectal surgeries that often. I'm mainly a hepatobiliary and a thoracic surgeon. But we have used things like flow seal in venous bleeds, and it really helps in certain situations. I don't know whether it will help in these situations where they are valveless veins. The veins have no valves and they're very thin walled. I do not know whether they will really work there.
Thank you.
Most of these surgical bleeds have to be tackled surgically.
Yes.
Medicines don't work.
True.
Honestly, they don't work.
True.
For the bleeds that would anyway stop, these things work well.
No, the thing is, you stop the bleed, you try to control it surgically, and then there is a little bit of still ooze going on. Then these things work as an adjunct, not as a primary modality. Not like the Baxter will show you the pig heart and the ventricle is punctured and then they put a flow seal and then it stops. It doesn't happen in humans. Thank you.
Thank you, sir.
So I'd like to invite Dr. Sanjeev Kumar, who I've had the pleasure to work with as well. He's a consultant surgical oncologist at Manipal Hospital.
Thank you for the kind introduction, madam. Thank you, organizers, for inviting me. So last week only I had 2 hostile pelvis to operate. So it was really a nightmare. A female in which the rectal cancer was stuck to the wall, post-hysterectomy patient, and another young male, very bad pelvis. So it's just a nightmare. So without wasting much time, I'll move on to my topic. So pushing surgical boundaries, rectal cancer with peritoneal carcinomatosis. So if we talk about a non-metastatic setting, the management of colon cancer and rectal cancer is different. But if we talk about a situation where we encounter peritoneal metastasis, the management of colorectal cancer, rectum and colon is largely same. So before moving, why are we discussing this? Because this is a big problem. Why a problem? Because one, the burden is high. So it is as 10 to 15% of the colorectal cancer cases. And the outcome is very bad because these tumors, these peritoneal mets responds very badly to systemic chemotherapy as compared to the other metastatic site like lung, liver, or lymph nodes. So peritoneum is now considered as a separate organ. That is the reason it is treated differently. So it receives 2% of the cardiac output, due to which there is poor delivery of the systemic chemotherapy into these peritoneal metastases, and that is the reason of poor response. And it reduces further with subsequent lines of chemotherapy. So what are the treatment options for these types of patients? Intravenous chemotherapy, immunotherapy, which is again very costly, or best supportive care? Or do we have some other answer? So yes, I'll be discussing about the role of HIPEC in colorectal cancers. So this topic is full of controversies. So let's see, especially after that, the recent trial, PRODIS-7. So let's see the current status of HIPEC in metastatic colorectal cancer with peritoneal metastasis. So the whole enthusiasm of cytoreductive surgery and HIPEC came from this, the trial, the RCT by Dr. Vic Vivral, where HIPEC showed, intraperitoneal chemotherapy showed a significant survival advantage of 10 months. So there were other studies as well, other prospective studies and population-based registries that showed advantage of intraperitoneal chemotherapy in colorectal cancer with peritoneal metastasis. So all suggested survival advantage. But you know, with a negative trial, all the enthusiasm goes away. So yes, I am talking about PRODIS-7. So this was a trial, multicentric trial, which was published recently, and this was a negative trial which did not show any survival advantage in HIPEC arm to treat peritoneal mets. So if we see the forest plot, none of the majority of the subgroup analysis, also the subgroups did not show any survival advantage. There was only one subgroup where the PCI was between 11 to 15, showed some advantage, but this is not enough. So before moving ahead, I want an opinion poll. How many of you believe that there is a role of HIPEC in treating colorectal cancer with peritoneal mets? And how many of you don't believe that HIPEC has no role? So the hall is almost divided, almost equal. Yeah, all the chairs also. So almost equal. But still there is majority who don't have a clue. I mean, they are in plus minus status. So there was a lot of criticism for PRODIS-7. So there was a fault with the design and protocol, the drug which was used, oxaliplatin, the patients were treated heavily, the duration of HIPEC, disease stratification was not there, and also the disease, there was problem with disease specific endpoint. So I would not go into the details of the drawbacks, but there was plenty of flaws in the study. So let's see, this is the recently published meta-analysis which analyzes different studies, which evaluates, you know, role of HIPEC in colorectal cancer. So good number size. It included 3 RCTs and 7 cohorts. If we see the diamond, it still shows that there is benefit of doing HIPEC in colorectal cancer. So there was some problem with the designing of HIPEC regimens, and the available evidences needs to be critically appraised before considering HIPEC. So let's see a new drug. Not the new drug, but this along with oxaliplatin, mitomycin was also used in HIPEC. So there are plenty of studies which compares oxaliplatin hypec versus mitomycin hypec. So if you look at various studies, so all have evaluated and compared oxaliplatin hypec and mitomycin hypec, and they have found similar outcomes, with mitomycin being a cost-effective drug, more stable and less toxicity. So that is the reason now mitomycin is being reconsidered and is a part of majority of hypec drugs. So if I talk about my mitomycin-based regimens, so it is being evaluated in so many prospective RCTs, whether it is prophylactic hypec or in curative settings. So whether hypec should be considered for treating peritoneal medicine, colorectal cancer, yes or no, that is a different issue. But one should believe that as per PRODIS 7, doing only CRS also gives a survival advantage, gives a survival of 41 months. So let's see further with these case-based scenario. So a 38-year-old young male. So he was diagnosed with rectosigmoid adenocarcinoma, mucinous histology. So on CT scan, there was disease in the left lower peritoneum pelvis, and there was a rectosigmoid mass. So this patient received 6 cycles of Folfox at some other hospital, and this patient came to me. So reassessment was done. And usually we reassess the disease using a CT scan. But majority of patients, practical scenario that they come with a PET scan. So PET scan again is a good tool. So it is used for evaluation of chemotherapeutic response, and also it is used for excluding the extraperitoneal disease. So MRI is also sometimes used to decide the operability. So reassessment was done, and it showed a stable disease. Disease was largely limited to the lower abdomen, and CEA was 10. So a staging laparoscopy was done, and the PCI calculated was 8. So this patient was taken up for cytoreductive surgery and hypec. So patient selection is a very important aspect of aspect. So a patient should be fit enough. The performance status should be good. There should be a good chemo response to chemotherapy, and also the PCI for colorectal cancer should be 17 or less than at least 20. So not only the volume of disease, but also the distribution of disease is important, because many a times a low volume disease may be unresectable because of mesenteric involvement, and sometimes high volume disease also is resectable because it is only limited to the parietal peritoneum with sparing of the viscera. So the extent of CRS, again, it's a matter of discussion, total versus involved. But for colorectal cancer, involved peritoneum excision is also accepted. But many a times in post-chemo settings, where we don't have the baseline mapping of the involved peritoneum, it is better to go ahead with total parietal peritoneectomy. So choice of chemotherapy for hypec. So oxaliplatin has taken back foot. So now mitomycin-based regimens are mainly used either as a single agent or a doublet. So various regimens are there. So technique, it can be either closed, open, or semi-open. So whatever prefers, but one can do. So for this patient, we did a total parietal peritoneectomy, and we did hypec using mitomycin C with open approach. So this patient is now alive, DFI of 31 months. So moving on to the second case, again an interesting case. Again, a young patient, 32-year-old female, unmarried. She had a mid-rectal tumor, which was 6 centimeters from the anal verge. Biopsy, it was a poorly differentiated with signet ring histology. CEA was 22. So the patient was planned for neoadjuvant treatment, and being a young patient, we planned for lap ovarian transposition and a stoma because there was features of obstruction. So on laparoscopy, there was minimal fluid and there were peritoneal deposits. PCI was 9. On frozen section, it was positive. Ovaries were normal. So we did a lap stoma, and ovarian transposition was abandoned. So patient was started on systemic chemotherapy. So after a few cycles of chemotherapy, the response was very, very good. CEA dropped to 12. There was a good clinical, radiological, and serological response. So we discussed multiple times in our tumor board and the young patient. So we pushed and we took this decision to treat aggressively with curative intent. So we did cytoreductive surgery in HIPEC for this patient. The patient was very keen for fertility preservation, but because of signet ring histology and other factors, we excised, we did a THBSO. So unfortunately, after 9 months, disease came back. So we burnt our fingers in spite of the signet ring histology we did. So this is one aspect which I would like to highlight, that patient selection is a key. So case number 3. So again, a 55-year-old patient, a female from Kanpur. So she was diagnosed and treated case of right colon. She underwent right laparoscopic colectomy, P3N2 tumor. She completed adjuvant treatment. So after 18 months, there was rise in CEA. So CT scan was done, it was normal. Colonoscopy was normal. We did a PET scan, it was normal. So after that, we did a staging laparoscopy. It showed peritoneal deposits in the right lower peritoneum, pelvic peritoneum, and there was limited volume disease with a PCI of 4. Again, question came: what should we do? Whether we should do a upfront CRS plus minus HIPEC, or we should give a neoadjuvant treatment and reassess again for CRS HIPEC. Then again, this question we don't have a very clear-cut answer. So if we look at this propensity score match, this is a very large study which did not give any survival advantage of giving neoadjuvant treatment in such setting where we encounter low volume disease with resectable disease. So we'll get further answers from this ongoing CARO 6 studies where they are giving where they are evaluating neoadjuvant treatment in such resectable cases. So what is the role of prophylactic HIPEC? So there was a paper published from in our Indian patients only, where they evaluated that there are certain high risk patients, high risk colonic cancers, T3 and N2 disease, which are very prone for recurrences, especially peritoneal. So is there any role of prophylactic HIPEC in such settings? So if we see the last 2 studies, Profilochip and Colopec, so both were negative trials, and there was no peritoneal disease-free advantage in such situations. But again, recently presented study, HIPEC-4 at ESMO. So it is a phase 3 randomized trial. It used mitomycin, and they have shown that with this prophylactic approach, there is good loco-regional control. So there is a lot of discussion, and with this mitomycin, the role of HIPEC is re-emerging. So again, a special situation. Can we consider MIS cytoreductive surgery for low volume disease, especially a situation like the case which I discussed, low volume disease? So yes, so in India only, I mean in Tata Memorial under the leadership of Dr. Saklani, they are doing a lot of laparoscopic cytoreductive surgery. So it is done. So 4th case scenario, 72-year-old female. So she presented with features of subacute intestinal obstruction. There was a rectosigmoid lesion, a omental cake, and ascites. So we did a stoma. So laparoscopically, the PCI was 15, and there was omental cake and ascites. The small bowel serosa was clean. So we did aspiration as much of ascites as much as possible, but PS improved. She was started on chemotherapy, but there was poor response. And again, ascites appeared. So what next? What should be the intent? So this is a very, very common scenario and very difficult situation to manage for the medical oncologist, because chemotherapy doesn't work and the surgeon does only ascitic fluid tapping and nothing else. So this is an unsolved challenge. The unresectable peritoneal metastasis is a situation where HIPEC does not answer. So peritoneal mets in colorectal cancer resectable, CRS and HIPEC is an option, but for unresectable, we don't have any concrete answer. So I am telling my surgeon perspective. So again, this is a technique which is PIPEC, which uses pressurized aerosol of chemotherapy inside the abdomen, which gives good control, but the response rate is not very great. It is in the range of 50 to 60%. So this is for the students. If they want to see how PIPEC is done, they can get a lot of videos. So there is whole rational evidence. So just I'm winding up. So there is another situation which is very unique to India, signet ring histology. So in India, there is an increase in patients of young colorectal cancers, and 40 to 50% of these patients have signet ring histology, and at the time of presentation, they have high volume peritoneal disease. So at Tata Memorial, again, Dr. Saklani and team, they are evaluating bidirectional chemotherapy for advanced colorectal cancer, and they're using intraperitoneal ports for administering simultaneous intraperitoneal and IV chemotherapy. They're also working on organoids. So they have successfully able to form an organoid for the signet cells, and they're working on chemosensitivity and finding new targets for this thing. So, so my take-home message that colorectal in young is a significant challenge, because 40 to 50% of these patients have signet ring histology, and they present with high volume disease, which are poorly responsive to treatment. So again, food for thought, whether prophylactic HIPEC is an answer for high risk group who are very prone for recurrences. And then molecular profiling, MSI, BRAF, HER2, PD-L1, CAR-T should be the future in finding a solution to these difficult to treat tumors. Thank you so much.
So just want to ask, how many in the audience would use adjuvant HIPEC based on your study? Would you use adjuvant?
So not till now. So we had recently 2 negative trial, Profilachip and Colopec. So we have a very so last ESMO HIPEC 4 was presented, and there they have. So I think sir will answer.
In JAMA also,
Yeah,
they
yeah, yeah.
published it already. Yeah.
So we have great 2 experts who can take this question.
Dr. Avnish, Dr. Han, please.
Oh, so I think that question is settled. We don't have evidence for prophylaxis or for adjuvant HIPEC. And I don't think anybody is doing it. In fact, I had a question, Sanjeev. Since you're doing PIPAC, probably you're doing quite a few numbers. Any downstaging up to the level of surgery for extensive peritoneal carcinoma?
Sir, I'll be honest. For colorectal cancer, there's a toxicity of oxaliplatin. I'm using oxaliplatin for PIPAC in colorectal. Not great. I have done only 5 cases, but the toxicity is too high. And I try to use the sandwich regimen, IP plus IV, PIPAC plus IV. So the response was not very great, sir.
Dr. Saklani, what is your experience with IP and IV?
I think we just joined in the early study, so like basically the port infection was slightly high. But I think we have done animal models for tumor growth, and paclitaxel is working really good. Even the irinotecan is working good. So now we are looking for prospective study for prophylaxis as well, where we can give IV follicular along with IV paclitaxel for signature, because the relapses are high. Regarding prophylactic HIPEC T4, initially when we looked at the paper, we said, okay, DFS and OS doesn't change, but I think the local control is really quite good. 2.8% for T4 cancers means where you expect the peritoneal recurrence of to be 20%, so which is pretty good. And even if you saw 70% for only T4, the peritoneal recurrence should have been 15%. So I think it is positive, but it requires a bit of tweaking, I think. Maybe biodirectional chemotherapy along with 5FU, or to get the toxicity of mitomycin down. But I think the last webinar we did with Indefso, I think a lot of people go for prophylactic HIPEC. There's no toxicity so far. I think if you want to
I have a feeling it won't work. I am not in favor of prophylactic. However, very interesting thought is about taxane as IP for high-grade colorectal, because we published a paper. Actually, it was a multi-disease paper, retrospective, but we had 2 conversions. So we use low-dose oxaliplatin, only 100 milligram flat dose oxaliplatin for PIPAC, along with adriamycin and docetaxel. And we had 2 patients who converted to operable, and both of them are still in remission. So I think there is a strong rationale probably for using IP, Pacli or docetaxel. And I think collaborative studies is the way forward. If anybody is interested, we're more than happy to protocol.
And CRS and HIPEC, is okay for T3, T4 lesions because you're going to open up and you see that if the peritoneal carcinomatosis index is less than 10, then we can go ahead with upfront CRS and HIPEC. But such scenario does not happen in rectal cancers, actually, locally advanced rectal cancers with the advent of TNT. So how do we go about it in that? Should we do a diagnostic lab and establish?
Yeah, so diagnostic lab should be done for all cancers wherever we are suspecting peritoneal metastasis. Even before opening the abdomen, you should do diagnostic laparoscopy. So by and large, largely colorectal cancer is managed by MIS only, laparoscopic or robotically only. That is the reason we pick up these lesions early with better magnifications. But yes, for low volume disease, upfront CRS plus minus HIPEC if the patient has been counseled and consent has been taken, yes, it is an option.
Let us move to the next talk.
Thank you so much.
Thank you so much. And the next talk is by Dr. K. Raja, Vascular Challenges in Advanced Rectal Malignancy.
Thank you, chairpersons, I thank Dr. Deep Goyal for the kind invitation and also giving me a challenging topic. I meant challenging because generally as a part of GI surgical training, so normally in the rectum, so this is one aspect which is not covered. And this we learn, as Dr. Subramanian mentioned, we learn from urologists and surgical oncologists who do a lot of gynae work. So it's documented in literature that primary rectal cancer do extend beyond the total mesorectal excision plane that ranges from 5 to 10%. This is from a large database, however the countrywide data might vary. And we also know in patients who underwent potentially curative surgery, approximately 10% do have isolated local recurrence, and these are the real challenges in managing. And in these two scenarios, you usually tend to encounter this vascular involvement, and that makes the surgical management challenging. So this was a Beyond TME collaborative, which was published in BJS in 2012, which means the primary rectal cancer beyond TME plane is the one that is predicted by MR that requires an extended surgical resection beyond the TME plane to achieve the R0 resection. So we know that extension beyond TME can happen in the axial plane, which could be either in the anterior aspect or the posterior aspect, which we call as the central or the axial. And then it can also be on the lateral aspects. So we all know about these compartments and the definition of the excentralization based on which compartment you are additionally excising. The vascular challenges are typically encountered when there is a lateral extent of the tumor. That is, when the tumor extends beyond the TME plane towards the lateral pelvic wall. So we should be clear about the lateral compartment. What are the structures which you encounter? The vessels, primarily the internal iliac and the external iliac vessels. The nerves, the hypogastric, which forms one of the boundaries, and the obturator nerve and the sciatic nerve, and the pelvic part of the ureter. So these are the structures which you will encounter when you go beyond the TME plane on the lateral aspect. So this is a description of the layers as you go beyond the TME. So the first, you will have the hypogastric plexus, and then the second plane is along the internal iliac vessels, and the third plane is along the external iliac. So these are the three planes. So this is the first one is the hypogastric nerves. which we normally conventionally preserve when we do in the TME plane. And that's first one you encounter, and then the internal iliac and the external iliac vessels along with the pelvic side wall and the obturator internal muscle. So this is the intraoperative picture. So we can see here, that's the ureter, the pelvic part of the ureter. And then you will have the hypogastric nerves. So that's the first plane. And then the internal iliac vessels, which forms the second. And then the external iliac, which forms the lateralmost plane. So this is just showing that anatomy. We had seen beautiful videos from Dr. Avnish Chaklani sir and Subramanian sir. So this is the last part of the pelvic node dissection, because usually it becomes, the anatomy becomes clear after the lateral node dissection. So that is the three planes, the ureter, and then the internal iliac vessels and the obturator nerve. So these are the three components, and it's usually the external iliac, which is when the tumor involves, that becomes the challenging aspect. So this is one of the case where, as you can see here, that's a tumor which is going beyond the TME plane. So that's a primary tumor with a threatened CRM and going beyond the TME plane into the lateral pelvic wall with the metastatic nodes. And so this is post neoadjuvant chemoradiotherapy with a persistent nodes. So these are the cases where you need to go beyond the TME plane. So that was nicely covered in the previous talk. So the initial dissection will be in the TME plane. As you go beyond, so that's where the tumor extends beyond the TME plane. And so when the plane is not good, that's where you go into the lateral compartment and go along the iliac vessels. So you have the iliac veins and the iliac artery. So you will encounter the vas deferens. So there's a male patient, and you will encounter vas which is divided. And that's a pelvic bone there. So that's the external iliac vein. And then you will have that was bone, and that's a musculature of the pelvic side wall, which includes obturator internus, piriformis. And then you will have the obturator nerve. So as I told, there was also a pelvic, the lateral pelvic node, which was enlarged in addition to the tumor extension. So this is the place, so that is the internal iliac vein. And you can see the tumor extending up to the internal iliac vein, which you need to control because there's no plane there. So that's an internal iliac vein, which is clipped. And that's the lateral pelvic metastatic node. And you encounter the small tributaries from the internal iliac vessels. And when you continue the dissection, so you will encounter the proximal part of the internal iliac artery. So that is a internal iliac artery, which is also going into the tumor. So that is clipped. And this is the internal iliac artery, and this is the internal iliac vein. So the proximal aspect, which will be divided. So most of the vascular resections in practice in the lateral compartment is with respect to the internal iliac vessels, and rarely it's only the external iliac. So once you clear that plane, then you can come again to the TME plane, and the tumor is resected. So this is again the anatomy. You can see the only structure now which is remaining in the second compartment is only the nerve and the ureter, and the lateral aspect, the external iliac vessels. And that is the lateral aspect of the that's the beyond TME plane, the tumor which is removed. So what we have seen is with respect to the internal iliac vessels, but if you see the literature, so this is a publication from the Sydney group, where they also mention about external iliac vessel involvement. The challenge in removing the external iliac vessel, because that's the main supply to the lower limb. So if you're going to resect, then the reconstruction has to be immediate, because otherwise you will have significant complications related to compartment syndrome, reperfusion injury, and also thrombosis of the distal vessels. So the planning of the timing of the resection is something critical. But most of the cases, instead of a complete vascular resection and anastomosis, you can even do a sleeve resection, as mentioned in this publication. But they also have mentioned few cases where the external iliac resection and reconstruction are being done, but we don't have any personal experience of external iliac vessel resection in rectal cancer. But as I mentioned, when we have to deal with this type of vessels, you should also have a good knowledge of the anatomy, especially with respect to the iliac vein tributaries. The traditional this anatomy where you'll have the internal external joining forming the common iliac vein, but you can have this type of duplication of the internal iliac veins. Occasionally, you will have the internal iliac joining to form a common vein, and there is no common iliac vein. So there is internal iliac is not joining into the external iliac. So we should be aware of this anatomical variations. And also, we need to remember about the traditional anatomy is all the branches in the pelvis, they are mainly to the internal iliac vessels. The external iliac vein does not receive significant tributaries in the pelvis. But studies have shown that external iliac veins do receive at least 2 to 3 branches on the lateral aspect, the sacroiliac, iliolumbar, and from the pelvic side wall, and also from the dorsal aspect. The importance of knowing this is if you have to do a sacrectomy, the one of the essential step is looping the external iliac vein. And if you don't remember this anatomical variations, you can have bleeding from this tributaries draining into the external iliac veins. So that's the importance, and so that you safely those vessels are controlled before the structures are looped. So we did have some discussion of about the presacral venous plexus. The one thing which we need to remember is don't blindly apply the energy, except where this kind of occasional scenario where when you can go behind the vessel, you can apply, but otherwise it's mainly the compression. Also, the presacral venous plexus, they are more on the lateral aspect, the significant vein, just at the midline. Generally, you don't get a significant vein. So when there was a talk of the hostal pelvis and going into behind the presacral fascia, so that's where you can start. So you use energy only when you can go behind the vessel. Otherwise, sometimes use of energy can increase the extent of bleeding. So to conclude, understanding the lateral compartment anatomy is key for a safe lateral compartment excision when you have tumors going beyond TME. And although I didn't cover, because in the current era, so once the extent of surgery increases, the complications is going to increase. So preoperative planning and careful patient selection is critical to have a favorable risk benefit in an individual patient. Thank you.
We all know that whenever we are getting more and more trained, surgically, whatever way, maybe our field and specialization, we can resect everything. But as sir is very senior, Dr. Saklani is already there. We are also having almost 20-year experience in surgical oncology. I think students, they are also there. We need some guidance from you people, sir. Then when to stop? As far as still we are talking about now HIPEC and rectal cancer. But as far as ovarian cancer, still work is going on. People still they are having challenges in that. And that was the primary disease for HIPEC which was started. So I think this is an organ-based conference, and there should be a strong message in the last evening that where to stop and when to stop.
I think that's a very relevant question. I think surgeons should remember, because the technical expertise, as you rightly mentioned, is going to improve because with available gadgets, robotics, better vision. So once we are going to do extended resection, choosing the right patient is the critical. And that's where with the current neoadjuvant therapy, you start, I think this type of patients, you can start with the conventional, and even you can go ahead with the TNT, because that gives us time to assess the biology of the tumor. So in a patient, you have a tumor going beyond TME, and you have given sufficient neoadjuvant therapy, and there is no progressive disease. You may not have a complete regression, but the fact that tumor is not progressing, there is no systemic disease which you have evaluated with the PET. Probably those are the group of patients who could potentially benefit from extended resection, and definitely this is not for all tumors going beyond the TME plane. So you need to be very specific. That's why I mentioned that, because As the time was limited, I didn't go into those aspects, but the careful patient selection in the era of newer gene therapy, that gives us a very good opportunity. It's not only rectal cancer, in other malignancies of the GI tract. The newer gene therapy does gives us an idea about the tumor behavior.
And Kalai, I think it's also important to understand whether it is the primary that is forcing you to do that extended resection to remove a vessel, or a lymph nodal mass which is removed, because the outcomes are completely different.
Okay.
Is it not? So
Yes.
An R0 of a primary is different. R0 of a lymphadenectomy is different.
Yes.
So what I feel the idea behind the case which he has shown is to how to approach this case. I think there might have been cases which have been abandoned or
Yes.
converted in favor of colostomy and then chemotherapy. And so the whole idea was how to approach. This. It's not like we'll be doing it in every case. The idea is just how to approach it.
No, as we subspecialize and dig deep, generally the aggression improves, and many times that is the way science progresses. So this is something that we need to understand and acknowledge, is it not? So,
Very nice
Yeah.
presentation.
Thank you.
And we should move to.
Thank you. Thank you, Dr. Raja. It gives me great pleasure to invite my dear friend, Dr. Reena Engineer, to talk on radiotherapy, give the keynote lecture on radiation techniques and evidence.
Thank you, Dr. Goyal, especially for inviting me to this August gathering of colorectal surgeons. And I'm really happy that, the work in radiation is picking up, as well as all fronts, surgeons and medical oncologists. And as far as the evidence over 20 years is concerned, we started from German trial in 2004, and now we are in 2023, and immense work has been done, especially where the neoadjuvant treatment is concerned. For almost 15 years, we practiced long course chemoradiation followed by surgery. And also there was a Dutch trial for short course. Then there was a Polish trial where we added chemo to short course. Then there was Rapido trial. We added more chemo to short course. Then there was Pradesh 23, which said that chemotherapy followed by chemoradiation is better. Then there's OPRA trial, which shows that the TNT is better for organ preservation. So all this while we have worked, first we tried to work towards improving the overall survival, which radiation did not prove it, but there was definitely better local control and better disease-free survival. And now the latest is what we are aiming towards is more and more organ preservation. So this was a German trial which proved that neoadjuvant chemoradiation is much superior where the local control is concerned, toxicity is lesser, compliance is better, sphincter preservation rate was higher, but there was no survival benefit. So this was a landmark from 2004, and it became the standard of care. For the early rectal cancers where they were mobile and early, and like in those days, MRI was not the standard of care, where we saw that giving short course RT immediately before surgery improved the local control rate from 8% to 2%. It reduced. So this again was another landmark trial which was practiced in European centers. Then from this Polish trial, again for the more locally advanced one, if we give short course chemotherapy, radiotherapy followed by 4 cycles of chemotherapy, in the initial paper of 3 years of follow-up, they showed there was a betterment in overall survival as well, not only the disease-free survival. And but then the subsequent follow-ups, there was no overall survival benefit, but giving short course with chemotherapy, 4 cycles of chemotherapy definitely improved the outcomes where disease-free survival and control was concerned. Then this was another landmark trial published in 2020, where they compared short course with chemotherapy versus a traditional long course and phase 3 randomized trial. It was a huge number of patients, more than 900 patients, and it was they were typically catered towards the T3, large T3 CRM positive T4s N2 disease. So these were all the ugly kind of tumors, which definitely benefited. So when we gave short course RT with 6 cycles of complete chemotherapy, this is TNT approach, there was a disease-related treatment failure. This distant were definitely better in the short course arm with chemotherapy, and distant metastasis was significantly lesser. But there was, in the subsequent paper, there was some amount of local recurrences were higher, but they were not clinically significant. But yes, they were. It was the only drawback of this trial, and but there was no difference in overall survival in both the arms. And in the subsequent paper, they also mentioned that radiation technique did make a difference, where they had 3D CRT versus IMRT, the local recurrence rate was higher. So US surgeons, and if you have to insist on when they are, especially when the radiation oncologists are practicing short course radiotherapy, IMRT is the way to go. Small portals with IMRT, and I'll be discussing in detail there. Again, Pradesh 23, I think Dr. Bhavna is going to discuss tomorrow. Basically, we studied the sequencing and radiotherapy when it was preceded by FOLFIRINOX was superior where the disease-free survival was concerned. So now we have both these approaches, chemotherapy of FOLFIRINOX followed by radiotherapy, and the winner arm of Rapido, which is short course RT followed by chemotherapy of CAPOX. So we have both the strategies to choose from, and the patient profile was similar. And if you see the overall, we cannot directly compare them, but yes, the outcomes also look similar. So, but the toxicity you have to keep in mind. So FOLFIRINOX can only be given to the very good GC patients who can undergo this kind of chemotherapy. So in my mind, when the patients are not, we have both the options. Short course with 6 cycles of CAPOX seem to do less toxic and equally effective. But again, it should be an MDT decision. Then the RT technique, I just want to show that when we practice 3D CRT, a lot of small bowel and sigmoid colon also receives the radiation dose, especially when we are giving a short course RT, it is 5 gray per fraction. And this can cause a lot of surgical problems, especially at the pelvic inlet, where Avnish doesn't like this, that a lot of adhesions are there, a lot of edema is there. So you must insist that when there's IMRT kind of approach and where we don't go too high in the pelvic inlet, then the outcomes can be controlled, and short course RT can give a similar result to the long course RT. And we finish in 1 week versus 5 weeks. And also we can have TNT chemotherapy while in the waiting period. So there is a benefit provided the RT radiation is controlled, and these are the bowel constraints we follow. Now, but we have heard a lot of surgeons discussing about the lateral pelvic nodes. I'm so happy that, like it is coming, because it was never discussed like few years back. Only the Asian surgeons would discuss about the lateral pelvic nodes. There was absolutely American and Europeans would not pay any attention. And we analyzed first our results, where we saw that the patients who have lateral pelvic nodes definitely their outcomes are inferior, especially who do not respond to the routine doses of radiation. So we see that overall survival, the distant metastasis rate is higher. So if they post radiation, if the nodal size reduces to 0.5 centimeter, then the recurrence rate is much lesser compared to when the persistent nodes beyond 1 centimeter. So definitely these patients do require some kind of dissection. And as a radiation oncologist, there was always in my mind that if we can give higher doses, selectively higher doses of radiation to these nodes to sterilize them further, will it make any difference? So, so this is the kind of boost we started practicing from last few years, and we also give to sometimes to the primary as well as the large mesorectal deposits. And this is the kind of designer radiation we started practicing from 2018. And this is how the boost plan looks like. So we do give 50 gray to the entire pelvis, and this is receiving almost up to 60 gray in 25 fractions in this picture. So this was one of the thesis topic for my student, and she has evaluated, because there were other factors which also playing the role. And initial few cases, the surgeons did find it very difficult when we had given a lateral pelvic boost. There was more fibrosis, there was leak, and there was a lot of bleeding. So did it affect? And we did a match pair analysis when we match with EMVI and nodal stage and the baseline size of the lateral pelvic nodes. So the outcomes, so we did it in 49 and 49 patients with boost and without boost. So definitely you can see the boost patients, they're having the outcome survival is superior in these patients. There is no randomized trial published in literature yet. And disease-free survival remains the same, but the radiation toxicity was also similar. So in the boost versus no boost, and surgical morbidity was also similar. So definitely there may be a role of giving boost to these lateral pelvic nodes and to improve the outcomes and reduce the metastasis. So what are the other dose escalation therapies? So why we have to increase the radiation doses than the normal? So of course, we want to increase the clinical complete response, increase the R0 resection rate, and improve the disease-free survival. And all these trials, so the routine long course radiation with capecitabine and followed by surgery, the trials have a report 12 to 20% of PAT-CR rate or clinical complete response rate. When we see the Rapido trial, the PAT-CR rate increases to 28% when we give TNT. And then now this OPERA trial, again, where we give long course chemoradiation followed by 6 cycles of chemotherapy, the complete response rate shoots to 38%. And organ preservation also I'll be discussing later. And Pradesh 23, it's also 28%. So clearly TNT has benefited in improving the outcomes of complete clinical response and pathological response in these trials. And this was the OPERA trial result. Mind you, the primary endpoint of this trial was not organ preservation, but then they have reported the organ preservation, they changed as a secondary endpoint. And definitely when we give chemotherapy followed by chemoradiation, it is inferior to the chemoradiation followed by chemotherapy, where organ preservation rate is concerned or TME-free survival is concerned, 53% versus 41%. So basically, after a long course chemoradiation, while we are delivering chemotherapy, there's a lot of time for the tumor to respond and go into the clinical complete response. And so typically 3 to 4 months go in this chemotherapy, and the tumor gets time to respond and show up as a complete clinical response. So now organ preservation is now becoming one of the standard of care, and it is here to say. Why I'm saying is standard of care, because now there's never going to be a trial comparing surgery versus organ or versus watch and wait, because there have been many attempts, but the patients never they withdraw their consent, or they never consent when you tell the patient that you have a complete response, but still you need to undergo APR, patients simply refuse. So there's never going to be a randomized head-on comparison, but there are, the wait and watch approach has come into NCCN guidelines, ESMO guidelines to the deserving patients. And what are the techniques to improve the outcomes or improve the response of the primary tumor. You can give a EBRT, external beam radiotherapy boost, the endorectal boost of HDR, high dose rate iridium brachytherapy, or contact X-ray brachytherapy, which is practiced in many centers in UK and other centers as well. So this was the first study which showed that high dose chemoradiotherapy and watchful waiting is possible in distal rectal cancers. So this, you can see the majority of the tumor were low lying and they were early, like T2 were 35%, and like majority of them were T2 or early T3s. And they gave 60 gray to the tumor, followed by 1 dose of brachytherapy. And look at the response rate. It was 78% complete clinical response. So this giving radiation boost to these early tumors does evolve into a complete clinical response and organ preservation. And this is another study where they gave the endorectal boost of brachytherapy of HDR iridium brachytherapy. And again, their complete clinical response rate has shot up to 86% in this study. This is how we give endorectal boost. We put in the applicator, we do a MRI or a CT scan, mark the tumor, and we give extra doses to these residual tumor. This was again a landmark trial published this year, February, OPERA trial, where they compared giving contact X-ray boost, which has a very less depth, so it doesn't damage beyond the rectal wall, and compared to the external beam radiation, and which was better for watch and wait. Again, there were tumors were early tumors, T2 and T3, and where the tumors were less than 3 centimeter, the organ preservation rate was complete clinical response rate was 97% versus 92%. So you see all those early T3 and T2 tumors, the majority of them would respond to this kind of radiation. And where external beam boost concerned, contact X-ray was superior in when there were more than 3 centimeter tumors, the 80% complete clinical response, and 97% when the tumors were less than 3 centimeter. So definitely majority of these tumors are going to have complete response. And there's another interim analysis from Canada, Montreal is published, where they compared EBRT boost to the brachytherapy boost. Again, the similar results. Complete clinical response rate is 90%. So chances of organ preservation, I would say, when they are early tumors and we don't give any boost, it is like more likely to be more than 50%. And when they are large tumors and mesorectal fascia may be threatened, so these tumors, at least 10 to 25% will have complete clinical response rate. But when we give dose escalation, the more than 75% of them are going to respond in the early tumors, and more than 45% are going to respond in the larger tumor. And of course, this has to be done with our MDT, and we don't, our radiologists are a backbone of this protocol. We don't start our MDT, and Avnish, when he joined, we made it a practice that we see all the patients at baseline. We see all the patients on follow-up together at least up to 2 years. So there is a huge learning curve to practice this kind. This was our first publication. We were actually very skeptical that in India, such a wide geographical distance to travel for follow-ups, will the patient come? It was a very successful approach, and it is mainly patients driven, because patients demand organ preservation if given a choice. And this is how we do our brachytherapy. There's a typical brachytherapy plaque and an ulcer related, which is not tumor. And this is the protocol we follow at TMH. We give them long course, and now we started short course as well. The first assessment is at 6 to 8 weeks. If it is complete response or near complete response, they go for another 6 weeks. We call them at second assessment is at 12 to 14 weeks. If it is partial or no response, they straight away go for surgery. So this is a protocol for brachytherapy results. when we gave brachytherapy for our first 100 patients, almost half of them are on wait and watch. This includes the large tumors as well. So this is a very successful protocol, and we see them 3 monthly for the first 2 years, and then 6 monthly for the another 3 years. If it is a local relapse, or we call them local regrowth, they go for surgery. So how do we choose? Now we have such bouquet of treatments available. So if it is T1, N0, M0, we go for local excision alone. But T2 now has a option, and especially low-lying T2 go in this era doing a APR or even ISR, which is not a very good functionally outcome, giving neoadjuvant chemoradiation for these T2 tumors, which will be a possibility of more than 90% responding. So this is a valid option. It should be discussed with the patient, because we have this habit of we deciding for the patient, but the patient should be a major part of a decision making. When there are bad tumors, definitely we have to give them some kind of neoadjuvant treatment, and followed by, if TNT is required, then it is a MDT decision. If they have complete response, or near complete response, they can go for this organ preservation strategy, or if they otherwise surgery. And the ugly tumors, definitely we feel that more and more TNT is required, and extended resections are required, ELAP are required, exentrations are required. So from smaller tumors going from organ preservation, we have to do less and less. But for the larger tumors, we have to do more and more. And this should be our treatment strategy in the current day. And I would thank you, and I'd like to take up some questions.
Thank you, Reena. So we've gone a bit over time. I just have two extreme questions, actually. One is, can we avoid radiotherapy given the prospect data? The PAT-CR is pretty similar. The second question is the other extreme. I remember with Venki co-consulting quite a few patients for proton therapy in rectal cancer. Now Tata Hospital also has proton therapy. So what is your take on these two?
Thank you. So for prospect trial, it was specially designed for upper and maybe middle rectal tumors. Unfortunately, they have not done for low-lying. It is a low-lying tumors where organ preservation and all these things are concerned. So till most of if there is upper rectal tumor, yes, we can give an option for patients for having a chemotherapy alone. Radiation can be avoided, or even upfront surgery for early tumors is possible. There are 3 choices available. But for low-lying tumors where they need tumor shrinkage or this thing, I think radiotherapy still remains the standard of care. And about the proton therapy, till now, there is no evidence that proton therapy is going to help these patients. We will wait for the results, but definitely right now there is no evidence of proton therapy.
Ma'am, I had one question. As you showed that we have better results when we sequence chemoradiation first, followed by chemotherapy in total neoadjuvant therapy. Do we have any subset of patients where we are going to reverse this sequence?
So yes, like Pradesh 23 design, we do start with chemotherapy where they are signature poorly differentiated. It is very bad tumor. There are lots of tumor deposits, large EMVIs, young colorectal cancer. Yes, starting chemotherapy for those patients is better. But I feel like even we discussed with Dr. Gasha Aguilar, who's the author of OPRA trial, for early tumors, I think giving full TNT may be a overkill.
And giving FOLFIRINOX after long course radiotherapy, I mean, we've seen that, the myelosuppression is a bit more. So in those tumors, maybe giving FOLFIRINOX before long course may be a better idea. Great. Thank you so much, Reena.
Thank you.
I think there are no questions from the service regarding all this.
Thank you, speakers, for delivering such a nice talk and the visual demonstrations. And thank you, chairpersons, for making the session interactive. So it's time for the final session of the day. I would like to invite Dr. Sumitra Rawat sir for the topic, how best to train in newly minimal invasive technique. A very relevant and exciting topic. And I request the chairpersons, Dr. Arjun Agarwal, Dr. Chandragoda sir, and Dr. Taha Mustafa sir, to chair the session. Please, sir.
Welcome, sir.
Thank you. Thank you very much, Dr. Deep Goel, to invite me. I think it's very difficult to say how best to train in minimal invasive technique. I think everybody has trained differently. As long as you reach the outcome, there is nothing like what is the best way to train. I think I was one of the early one in UK to get trained. So I thought I will share my journey, that how I got trained and how I am helping training for the consultant surgeons here in India. I bring warm greetings from Sir Gangaram Hospital. This is my other affiliation, is a Christie's Hospital, where I was a honorary consultant. Plus, we have collaborated with Christie's in a fellowship program, and the Royal College of Surgeons of England. I'm a laparoscopic trainer. So I will just take 2 minutes, because we are talking about rectal cancer, just to give a brief why it's a gold standard. Before 1982, the local recurrence rate was about 50%, and the survival was very poor. 5-year survival in a stage 3 would be around 50%. So there was a fight for survival. So when the TME came in, and when there was an improvement of survival, in a stage 2 and 3, 5-year survival is more than 80%. That is where all the morbidity the patient started looking at. Urinary dysfunction, sexual dysfunction, somewhere between 10 to 30%. So they were fighting for the quality, and that's where the laparoscopic approach came in, because you could see it, a very magnified view of the nerves. You could see hypogastric nerve and parasympathetic plexus clearly. But when you are doing a open surgery, you are pushing a hand in there and damaging the nerves. So we all know the benefit of laparoscopic surgery. We have the evidence, we have the guideline. When I left UK in 2012, there was a nice guideline very clearly stating that if patient wants a laparoscopic surgery, and if you can't do it, you need to give it to your colleague. That was the guideline. So that is where we come in the picture, training. How to train someone in minimal access surgery. So I have divided the component. One is a resident training. If you are working with the consultant who is doing the laparoscopic or minimal access surgery, it becomes easier. But all of them are not lucky. How many people will be there with the consultant like Deep Goel or Dr. G.V. Rao or Dr. Saklani or with us? We need to look at tier 2 cities also, where laparoscopic surgery is not done, and they are very keen. So there are the things like master classes, symposia, which Deep Goel every year organizes it. And then there is a skill center. There is a laparoscopic fellowship. And for the mature surgeon, there is a thing called preceptorship. I will go one by one. I will start with my training, resident training. I was trained in Maulana Azad, but that was an era when minimal access was not done. I moved to UK, worked in Northern General Hospital. That is the era when lap chole started, went to RVI, where I started doing lap chole, lap hernia, lap fundoplication, but I was not into the GI cancer surgery. So we started doing it. So that is where masterclass and symposia or the skill center came in play. So there were very few center, I would say 4 or 5 center who were doing advanced GI cancer. One of them was Kusheris in Dundee and another one was in Leeds. So I went and did advanced laparoscopic surgery course in Leeds, followed by, Strasbourg. I did the advanced GI surgery laparoscopic course in Strasbourg. I must say these two courses really helped me. Then I looked for a fellowship. Although I finished my training in Newcastle, but I thought I need to have 1 more year of training in advanced laparoscopic surgery. I was lucky that I was taken by Leeds, where they were doing lap esophagectomy, lap gastrectomy, lap colorectal, and this is early 2000s. So once I got trained in laparoscopic, it became easier. I became a consultant in Glasgow Royal Infirmary, but I carry on doing the training. I did the lap colorectal course at Ethicon Institute in Hamburg, where then subsequently I became a faculty as well. And I also did a cadaveric course. This is also one of the things which I think the young surgeon should look at. Once you go into the patient, best thing is do the skill course, do the cadaver course, then go into the patient for your own safety. And then what happened in UK, before you are appointed as the trainer for laparoscopic surgery, you need to do the trainer course in the way how you are going to train the surgeons. So that is when I completed it. I think it was 2008. And then I became a laparoscopic trainer of the Royal College of Surgeons of England. This is me training with Mike McMahon, and these are all the young surgeons who were keen to learn. And this is where when we started the LabCo training course. Initially, it was at 6 places, and I was lucky that I was there at 3 places, Leeds, Newcastle, and Manchester. So slowly, the training started. As you could see in this graph, I was trained early 2000, so I was in the first 5%. But how to increase the graph? I think what we need to do is, if you got trained, you need to serve the society, you need to train the junior consultants. That's the most important thing is, somebody trained you, so you need to give it back. You need to train. So this is how it started. We were initially 10, 15 of us, we started. Then in the chain reaction, 20 started training, 50 started training. You could say the graph became so high, by the time I left there, 40% of the surgeon in 2012, they were doing laparoscopic colorectal and upper GI cancer surgery. That is the time, end of 2012, I moved to Sir Gangaram Hospital and I started doing lab GI cancer work. Before me, it was done in isolation, I think 1 or 2 cases, but nothing regular. So what happened? I started, we've got 12 DNB students, and I'm proud to say that one of colleague of Deep Goel, Amir, he was trained with us. And Amir was a good guy. He was topper of NEET, very sincere, and he took everything in the stride. He stayed back with us for a year as a clinical assistant. And when he was there, I was giving him gastrectomy, right hemicolectomy, anterior resection. I would be standing there, but he was doing it. This is how you give back. So resident training. Second was masterclass symposia and skill center. Since I was faculty in Ethicon, so I started, as soon as I came here, I started doing lap colorectal course. I will take out 1 day in a month So these are all the consultants which will come all around from India. So in morning, we will have a theory class. After afternoon, they are having a simulation in the pig. So during the course of time, so we train a lot of consultant. And this was a gentleman, he was a president of Indian Association of Surgical Gastroenterology. At the age of 55, he came to learn. So age is not bar if you are doing laparoscopic surgery in the past. We had people from Sri Lanka, Nepal, Bangladesh, and till the time Ethicon on Ethicon was working, the things was good, but then it was shut down. We calculated, we trained 128 surgeons from all over India and from Southeast Asia during that period. So this is the simulation. We are doing it in a pig. So if they are doing an anterior resection in the pig, they get used to, they know what to do, they know what to dissect, they know how to use harmonic, they know how to use circular stapler, they know how to use the linear stapler. This is a picture I have posted because before this picture in 2013, I went to Patna to deliver a oration. So after finishing the oration, I asked how many people are doing lap GI cancer work. There would be about 300, 400 surgeons sitting there. Not even a single hand was raised. Not even a single hand was raised. Then there was a, this in Kerala, there 30% of the surgeons, they were doing lap GI cancer work. This was especially colorectal cancer workshop, and 30%. So you could see the north-south divide, especially in UP, Bihar, they are very late to pick up. And this is, you could see everyone is there. We had a crest conclave. Deep Goyal is there. Pradeep Jain is there. So we were there. We wanted to streamline the operative steps of anterior resection. If somebody is interested, we put a lot of hard work. Dr. Puntam Baker is there, is being published so that there is a standardization of the technique. So it's been published. If somebody wants to have a look, they can. Then I became involved in Asia Pacific endoscopic colorectal summit. Every year I used to go, and it was lovely to meet young surgeons in Asia Pacific and see how they are training. First time when I went there, I was a speaker. Second time, they put me in the governing council or the steering committee. It was lovely to have Les Boki there, Professor Sion Hum King there, Professor Watanabe there. I will tell you, even if you are a faculty, the kind of learning, you don't stop learning, you keep on learning. The kind of learning you get there, talking, discussing, seeing other people do it, that, it's amazing. Then we had it in Japan. Then this is in Shanghai. So it is something like you could see they are similar as Indians, all the young surgeons, they want to get trained. So it's always good. I must congratulate and thank Deep Goyal that every year he's doing it, which is good. This is where you can come and see how the progress is made. Then, my resident was getting trained. I was doing masterclass symposia and the skill center in Ethicon on Ethicon. The next step I thought, if we can have a GI fellowship. It was difficult. I was a surgical tutor of Royal College of Surgeons. I was involved in laparoscopic training in UK, but I wanted to collaborate with one of the institutions. Christie's is the largest cancer center in Europe. So since I was a member code of examiner, so president was, I knew him well. He was a good friend. also a mentor also. So I invited Professor Williams. He is the editor-in-chief of Bailey and Love. You would know Bailey and Love. So we invited Professor Williams because we were having a trouble setting up a fellowship program. So he came, had a look at Gangaram, and then we started India's first international fellowship program, which was like official. So they were getting F&B from National Board and MCH from UK. This is my colleague and our chairman of medical oncology. He's very actively involved in Gangaram Christie's, Dr. Shyam Agarwal. He's here, sitting here. He went with us to Christie's to see what next step is. Now the training is sorted. Now we are looking for research collaboration so that if they are doing something there in Europe, if we could do the same thing in India, done in two continents, that will carry more weight. And we did just before the corona came, we did the joint international conference. Then the last thing is preceptorship. I have gone to various hospitals, helped young surgeons, mature surgeon. This is, it was very overwhelming that I was invited from All India Institute of Medical Sciences because they bought the laparoscope, but they were not doing in their surgical oncology. So I went there, we did 4 cases there. Professor Shukla is there. And then when you are getting trained, like, you said, how to avoid pitfall and complication. You showed about 3 things, isn't it? Nerve come first, then is the internal iliac, then the external iliac. This is how you should learn. So it's important how to avoid pitfall and complication. For this, whatsoever I did in UK, I was invited to deliver a lecture there, which was a European Association of Endoscopic lecture. And then I was elected as an honorary member. It was a privilege to be second Indian after Professor Palanuveli to be honored with a honorary membership. These are the 4 pillars of surgical standard. If you are going for advanced laparoscopic surgery, you need to optimize your patient first. Anesthetist should know how much head raise or head down needs to be done, how to tilt the table, and when exactly you will do. And you need to know each and every steps and even the sub steps, so that these should be in your mind. So you need to check what you need. You need harmonic, you need ligature, you need, stapler, circular stapler. Everything should be in your mind. If you don't do it like the pilot does, before taking off the plane, they check each and everything. That is what you need to do. Otherwise, it's a catastrophe. And other thing is that you need to audit. When Neeraj Dhamija was with me, when he was doing the surgery, I was there assisting him. We did the audit. What is there any difference if the primary surgeon is doing or a trainee surgeon is doing? There was no difference at all. And who audit the surgeon? Is the pathologist who audit the surgeon. When you take out the specimen, pathologist will say, this is a poor surgery. There is a defect of more than 1 centimeter in the mesorectum. It is not more than 1 centimeter. There is irregularity. This is the optimal surgery. Whether you do open or you do laparoscopic, this is a specimen which should come out. I will conclude that, laparoscopic colorectal surgery training is challenging, but if you are trained well, it is safe. And that is what you need to do in colorectal: identification of pelvic autonomous nerves, and you need to look into enhanced recovery also. These are the 4 places I always say you look at the nerve: beginning, medial to lateral, during dissection. When you are going to the lateral pelvic wall, have a look at it. and fourth is a parasympathetic nerve plexus. These should be your sub steps. When you are doing this, you need to identify the nerve and preserve it. I'm not going to go much about enhanced recovery. I think you all know. But if you are doing a laparoscopic surgery, keeping the NG tube for 3 days, not mobilizing the patient, that is not done. So enhanced recovery has to be there. You need to learn. Enhanced recovery was started by Henry Kellett, Robin Kennedy, and Prof. Motson was in Colchester. So this is where I went there and learned about enhanced recovery. I understand regarding the junior surgeon, very few training opportunities are there. But then I have told you all the 4 things, 5 things, wherever you get your hand, you need to get in. If you are not a resident where it's been done, go and do master class and symposium, go to a skill center, wait for your time. Once you get a residency, it's fine. Otherwise, you can do a fellowship. We are in 21st centuries. We need to keep on moving. We don't know what is coming. Maybe our medical oncologist or radiotherapist may come out with a magic drug that, cancer is fully eradicated, like tuberculosis. Like in 1930s and 40s, majority of surgery was for tuberculosis of the chest. Before the magic drug PPI came, when I was getting trained, 30% of the surgery was duodenal ulcer perforation, selective vagotomy, truncal vagotomy, but it vanished. So we don't know what is coming. But the most important thing is strongest one who survives is not the most intelligent, but is the one who's most adaptable to change. Thank you very much.
Thank you, sir, for a very nice presentation. I think the take-home message for everybody is to get trained and then get back to the people. Any questions from the audience?
Thank you, sir, for the excellent presentation. We need to reinforce on the resident training again and again. It is difficult in minimal access surgery particularly, but we have been trained with the consultants sitting behind us. So with the faculty here, we want to reinforce this fact that you need to develop a heart to sit behind and train the junior residents, because the opportunities are few and less, unfortunately, lesser in the minimal access surgery. That is the take-home message. Thank you so much, sir.
Thank you. I think we as a consultant, I think we got a responsibility that at some stage we need to start giving back. We are not going to carry on doing the surgery. So in 10 years or 20 years time, when we get sick, there has to be a good trained people. If we don't train them, then who will look after us? Thank you very much. Yeah, please.
What about the DNB in GI surgeries in corporate hospitals? What is your take on hands-on training for DNB GI surgery?
See, I think like I will be honest with my training in UK also. I think very major surgery, normally you get the full 100%. Like, I was trained in upper GI at Newcastle. They were doing about 180 esophagogastric cancer in a year, largest volume in whole of Europe. But I would say during training, nobody will give you 100%. When you are getting trained, you won't get 100%. Say they will give you, but it'll be 80%, 90%. They will give you some step in one case, some other step in other case. So that is what it is. That's the reason what is happening also with the younger surgeons. They are getting very desperate to become a consultant and HOD ASAP. That is a thing which I will, say no to. Get trained first. Get trained first.
we are having DNB cases or
See, in my team also, like if somebody can't do lab chole as a DNB resident, I need to start training him in lab chole first. So that's where I'm saying that, and there is a reluctancy, residents, once they get into DNB or MCH, they think that, they will become DNB and MCH in 3 years' time, and they will start practicing. The trouble comes if you are not fully trained, go to the independent setup, start doing, and something horrible happens. That is where preceptorship, it is important. I think I would say that after you finish training, go to a high volume center, work as a fellow or a clinical assistant or a junior consultant for a year or two.
Around 3 degrees, and it took around almost 12 years of study. And at the age of passing cancer or DNPJ surgery, we were at the age of 33 or 34 and an average. And after that, we do some fellowship and the professorship, and then we start making patient, and also that making patient will take 10 years.
See, listen to me. Just a final question. Yeah. Just a question.
For a cup of coffee.
I'll talk to you. But I'm saying I became a consultant at the age of 38 in UK. I did 12 years of registrarship, including 3 years in Maulana Azad. So the length doesn't matter. You need to reach there before you take. That's what it is. Thank you very much.
Thank you, sir. Thank you, Dr. Arif, for an excellent lecture. Now I invite Professor Dr. Shyam Agrawal, sir, to come over the stage and deliver his talk. Dr. Shyam Agrawal is the chairman of the Rectal Oncology at Sargandaram Hospital.
Thank you, Dr. Chairpersons, and thanks to Deep and the organizers for giving me this opportunity. So I take the thread from where Dr. Samitra Rawat left. So he said the medical oncologists may drive away the surgeons. So actually it's happening, and I'll show you a slide which was in the newspapers last year all over. And so I think that is the background, and let's move ahead. So I think, as we know, cancer is a disease of genes and microenvironment. And colorectal cancer has made huge progress as far as molecular understanding, molecular markers, and therapy based on those outcomes in the understanding has happened. So I've divided the talk into 2 parts: metastatic colorectal cancer and early stage colorectal cancer, where how the molecular understanding of the tumor helps you take a decision as to what we need to do. So actually, this is a little busy slide, but I'll not go into this, just to show you the RAS, BRAF, MSI high, HER2. So these are 4 or 5 genes which I'm going to come in detail, but I think you need to individualize patient depending upon the metastatic disease, whether it is liver only, what is the performance status of the individual, age, etc., to decide whether a patient needs full treatment or needs milder treatment. So you have to have that goal in mind. Are we going in for a cure, even in the metastatic setting, or are we palliating the patient? So I think that's in general. But coming to the molecular understanding, so if you look at colorectal cancer, there are 2 pathways which are very important. So which are overexpressed in all colorectal cancers. One is the VEGF pathway, where you can use the bevacizumab. So that is a drug which is readily available to us. And the other pathway is the EGFR pathway. So all the patients with colorectal cancer have EGFR overexpression, and therefore if you target EGFR with the EGFR inhibitors, you're likely to achieve success. But there are caveats as far as the EGFR targeting is concerned. So we are talking about EGFR targeting, and we are talking of VEGF targeting when we come to metastatic CRC. So this is what has happened over the years, that is survival with the availability of newer chemotherapeutic agents and the targeted drugs focusing on VEGF and EGFR, and then subsequently I'll show you more, the survival has really gone up. So this is the, sort of a slide which tells you in the first line what we are going to do in a patient who has metastatic colorectal cancer. I think we have this one. Okay. So if you see, most patients, actually all patients are eligible for bevacizumab because angiogenesis is the key word for patients' tumor growth. However, as I said, EGFR is also overexpressed in all colorectal cancers, but the problem is the RAS or the BRAF. So if the RAS is mutated or the BRAF is mutated, then the efficacy of EGFR targeting is not there. So you don't need to test for EGFR. You only need to look for RAS or BRAF. So if you find them to be mutated, then the EGFR drug is not to be given. So you have two drugs, cetuximab and panitumumab, as you see here. And bevacizumab, of course, can be given to all. But the issue is in the left side, I'll just show you that cetuximab or panitumumab works better. And therefore, those are the preferred agents in patients who are RAS wild type, means they are not mutated. So then, of course, the microenvironment has really come in a big way. That is the role of immunotherapy. So you need to look for MSI high or defective MMR protein. So if MSI is high, then you can use these immune checkpoint inhibitors, which I'll come to in a minute. So EGFR story, most colon cancers are EGFR positive, so you don't need to test for that. That is taken for granted. And therefore, cetuximab and panitumumab can be used, especially for RAS wild type left-sided tumors and RAS negative tumors. But what about the right-sided tumors? So there is a conflict between US and Europe. So Europeans still believe that you can use cetuximab in right-sided tumors when you're talking about downstaging, because the response rates are quite good, up to 60-70%, whereas Americans don't believe in that. So therefore, if you have a patient or if a physician or a medical oncologist is using cetuximab in liver-limited disease for downstaging, RAS wild type, he's not wrong. So I think that's one message. So this is a little busy slide to show you the differences between, the left side and the right side. As you can see, these are various studies. I'm not going to go into the details. As I said, on the left side, if you see the top, for the FIRE3, so if you use cetuximab with FOLFIRI, 38.3 is the overall survival as compared to bevacizumab when used in first line, which is 28 months. And you can see here the response rates are coming to the tune of 70%. So, combining chemotherapy with cetuximab or bevacizumab gives you superior outcomes in terms of response rates, PFS, and overall survival. So depending upon the side of the tumor, depending upon what your intent is, one can select the targeted agent. So in order to improve the results, so currently we are combining these with FOLFOX or FOLFIRI. So now people are talking about FOLFOXIRI to be combined with cetuximab to achieve deeper and faster responses. And you see the responses going up to 72 to almost 90%. So, that is the kind of progress which is being made. However, this is not established at this point in time. The studies are ongoing. As you can see, the outcomes here when you use the 3-drug combination, which is oxali, irinotecan with 5-FU and cetuximab, the overall survival is, a shade better because the hazard ratio is 0.54 in RAS wild type and in BRAF wild type. So now we're going little details into the molecular oncology. So if you have a patient who is, failing FOLFOX with cetuximab, and then there is a gap, you can re-challenge the patient with irinotecan and cetuximab. And actually, people are doing the KRAS testing in the peripheral blood. So I'm introducing the term. So far we were looking at the testing of the tissue for KRAS, for BRAF, for HER2/neu. I'll just come to that. But now even you can do these tests in the peripheral blood, which is called liquid biopsy. So basically KRAS should not be mutated before we choose EGFR drug, which is either cetuximab or panitumumab. So now switching from the story of EGFR, then we have BRAF mutation, which is seen in about 8 to 10% of these cases. And FOLFOX doesn't do well along with cetuximab. And if you see the top line there, FOLFOXIRI plus bevacizumab is the preferred combination in the first line treatment. So I think that is one message we want to convey for BRAF patients. So what about second line? So in second line, you have the combination of vemurafenib and the panitumumab or cetuximab. So I'll just show you this trial where the MEK inhibitor and the encorafenib and cetuximab versus 3 drug versus 2 drugs was used, and they found the 2 drugs to be doing better than as compared to 3 drugs. So this is to be used in second line for BRAF mutation. So therefore there's a need to test the tissue for the presence of KRAS, BRAF or NRAS in order to decide which combination in the first line or second line can be used. So now coming to the third part, which is the immune checkpoint inhibitors, that requires MSI testing. So you need to do the MSI testing, and as you can see, we have a couple of drugs which are readily available here also. Pembrolizumab in patients with MSI high, when compared with chemotherapy, the Pembro curve is better than as compared to chemo. So in the first line, so if you have a metastatic CRC, kindly do KRAS, BRAF, NRAS, and MSI to decide which is the first line treatment. So this is better than chemotherapy. So therefore, if somebody has MSI high, I like to use Pembro, or I like to use Nivo plus ipilimumab. So all these 3 drugs are available, and these are better than as compared to chemotherapy. So now the issue, what is the issue on the MSI? So MSI unstable, which is MSI high, is seen only in 2 to 4% of patients with metastatic colorectal cancer. So you get very few patients. So there's another terminology which I'm introducing here, is a tumor mutation burden. So basically, tumor mutation burden is tested by doing the next generation sequencing of the tumor, looking at 300 to 500 genes and identifying tumor mutation burden. I'll just show you the slide. The PDL1 is not really important to select out patients for immune checkpoint inhibitors in patients with colorectal cancer. So it is basically the MSI high or the TMB which can be used to select out patients for use of Pembro or the other Nivo and Ipi combination. So it's kind of mixing up now, but then what is the first line? As I said, you have the choice of FOLFOXIRI Bev for BRAF. You have the choice for FOLFOX or FOLFIRI with bevacizumab or with cetuximab, panitumumab, or immune check. What about the second line? So for patients who have not used the EGFR therapy in the first line, then you can use the EGFR. As I told you, for BRAF, use the combination of encorafenib plus cetuximab. For patients with MSI high who have not used the immune checkpoint inhibitor in the first line, you can use that in the second line. So this is the other fifth thing which I'm introducing here, which is the HER2/neu in the second line. So therefore, you need to also test for HER2/neu amplification in patients who have metastatic colorectal cancer. Because if that is so, then you can use the readily available trastuzumab plus pertuzumab or a combination of trastuzumab and lapatinib. So these are uncommon genes, anti-RK fusion, for which entrectinib and larotrectinib can also be used. So I was just mentioning about the TMB high. So if you see here, if the patient's tumor mutation burden is more than 10 mutations per megabase, then pembrolizumab can be used. So actually, these are tumor agnostic indications. What it means is that if you have any of these abnormalities like MSI high or TMB more than 10 mutations per burden per megabase, or you have anti-RK gene fusions, so or you have the BRAF V600E, or you have RET gene. So we have drugs for that, and these can be used for any tumor. If you find this in lung cancer or breast cancer or any malignancy, so that is a tumor. These are tumor agnostic markers, irrespective of the tumor type. So whether it is an adenocarcinoma or squamous carcinoma, doesn't matter. So these are the some new drugs which are now going to become available, which are driving the treatment. So the role of HER2/neu, again, the issue is that it is only seen in 2 to 3% of patients with CRC. But if somebody is having RAS or BRAF wild type, or they are negative for the mutation, then the incidence of HER2 expression is 5% to 14%. And there's a little difference in the testing here for the pathologist. that for IHC, it should be 3+ staining in more than 50% of tumor cells. So it's not like breast cancer. It's a little different. So I think the pathologist should be aware of that. So this is not accepted by all the oncologists, that if HER2/neu or the ERB2 is amplified, the results of the EGFR drug are inferior. But then there is data which is emerging to that effect. So we don't take this into account at this point in time, but some doctors do. Okay, so a lot of trials are going on for HER2/neu. As you can see, there's an oral drug called tucatinib, which is going to be launched with us soon. 38% response rates, you can see. And this is the other drug, which is an ADC, which is an antibody drug conjugate called trastuzumab deruxtecan, where the response rates are almost 45.3%. So these drugs are coming in for patients with HER2/neu positive colorectal cancer. So I'll skip this slide. And just to sum it up before I go to the early colorectal cancer, so you have the option of using chemo plus Bev for the right-sided tumor, chemo plus EGFR or Bev for left-sided tumor. For MSI high, you have the immune checkpoint inhibitors. For the BRAF mutation, you have FOLFOXIRI plus Bev. So I think that is how the algorithm goes. And then the second line, as I've explained. So I think I'll just come to, so what do you do when you have a patient? So what tests you need to perform in patients with metastatic CRC? I told you minimum tests are KRAS, NRAS, MSI, BRAF, HER2/neu. So that is the bare minimum. But if you have the money, then you can do the next generation sequencing, where you'll get information on all these. But you get for the rare genes like NTRK, RET, and TMB, which you don't get if you do the individual tests. So I think that is what we are supposed to do. And the minimum tests are written on the top here. Okay, so just to show the number of patients. So RAS mutation is seen in 46%, PIK3C not relevant though, 8%, BRAF in 8%, and I told you HER2/neu in about 2%, and so on. So now what is happening in early colon cancer, which is very, very important, and it's going to be coming in day-to-day practice. So this is something which we're using for T3N0 colon cancer. The role of adjuvant chemotherapy is not clear because the survival benefit is about 2%. So we do the MSI to figure out whether a patient should be subjected to oral capecitabine therapy, because generally intravenous therapy is not given. So if MSI is found to be high, supposed to be a good prognosis, and therefore do not give chemotherapy. But if MSI is low, then we are giving them adjuvant capecitabine, especially for young patients. So now this is again experimental thing, but it is entering practice now. What is happening for patients with resectable cancer? Can we decide on chemotherapy? How can you do that? By the use of molecular oncology. So there's a paper from MSKCC by Tai et al. So what they did was they took the resected tumor, they did the NGS, and say, for example, found the KRAS mutation, which is seen in about 50%. They did simultaneously a liquid biopsy and quantified the KRAS mutation in the peripheral blood. And they got the VAF, which is the variant allele fraction, say 20% or 30%. You resected it. And then after resection, you do the liquid biopsy again and see whether the VAF is gone down to 0 or not. So if it has gone down to 0, that means that they do it by deep sequencing. So that would possibly mean that the patient has no cancer. And that is where and maybe you don't need the chemotherapy. So if you see here, so if you are actually from positive to negative, so see 100% patients are having a disease-free survival at 6 months. So this is early data. If you see the black and the green, curves there. So from positive to negative, the curves are almost 100%. So therefore, you possibly may not need adjuvant chemotherapy for such patients. Whereas patients who remain positive with the liquid biopsy after surgery, the disease-free survival is only 58.3 months. So this is an important, study, which we are also conducting at our center, and all the surgeons are providing us with samples, and we are doing liquid biopsies before and after surgery to see whether they were positive before or negative before, and they become negative or not. So I think this is an important study, which is a Galaxy study. So I'll just skip this slide in the interest of time. And AI is also entering into this arena. That is, they did the 67 gene study, and they figured out that, patients who have those abnormalities in 67 genes with AI on, a tribe study, they did better. But I think this is evolving at this point in time. So this is what I was referring to, Dr. Rawat. That is for locally advanced rectal cancer, MSI, and immune checkpoint inhibitors. So this is the current algorithm. I'll not go into. So what they did was that patients who had stage 2 or 3 MSI high rectal cancer, so they didn't do surgery, they didn't do chemo, they didn't do radiation, they only gave this immune checkpoint inhibitor called dostarlimab. And 14 patients, all patients had a complete clinical response requiring no surgery, no radiation, no chemo. So I think, but the problem is that the incidence of this MSI high is just around 5%, or maybe a little higher in patients with stage 2 or 3. Stage 4 is only 2%. But if you go to little, lower stage, then the incidence becomes higher. So this is evolving data. But then if somebody is not fit for surgery and is MSI high, can undergo, we don't have dostarlimab, but then we do have the other immune checkpoint inhibitors which can be used. So I think I'll come to the end of this lecture because I think the molecular oncology is there for patients with metastatic colorectal cancer for sure. And even in patients with early colorectal cancer, I think the data is emerging very, very rapidly to be incorporated in day-to-day practice. So with this, thank you very much for your attention.
Thank you, sir. I think it's a really good lecture. Each part of the colon is, I think, it's a bigger topic. To cover that in half an hour, all of the colons, definitely only you can do it.
Yeah, so I could only give a bird's eye view to surgeons, I guess. Yeah, thank you. Right. So, but anyway, I think you need to understand that we have these markers which we are doing it routinely, and some are evolving rapidly. So thank you very much.
We now have the last lecture of the day. Dr. Alicia Patricia from the New York has joined us. She in live? Can we see her?
Hi, good morning.
Hi, Patricia. How are you doing? Good morning.
Great. How are you doing?
Fine. Hope didn't wake you up.
It's actually funny. I was in the operating room until 2 o'clock in the morning with a very difficult transcendental TME case. So the topic is perfect today.
Okay. Can you see us?
Yes, I can see you.
All right. So we will give you the screen. Please go ahead with your lecture. Thank you.
Thank you. Can you see my screen? Yes. Perfect. So good morning from New York City. I'm Pat Salah. I'm a colorectal surgeon. And as many of you know, my specialty is rectal cancer, in particular, minimally invasive approaches. I am not a robotic surgeon. I have been practicing transcendental TME for 14 years, and it has really changed my practice entirely. And now the majority of my patients who come to me have very low rectal tumors within 5-6 centimeters from the anal verge. Most of them have received a chemoradiation, sometimes up to 12 to 15 months after I've had recurrent disease. So it's definitely the more complex rectal cancers. So obviously your crowd is very sophisticated. I'm sure you have spent the last 2 days talking about evolution and revolution in the management of rectal cancer. The most relevant aspects to surgery, obviously, is the event of a total neoadjuvant treatment, which now, I don't know if you're seeing the same trend in India that we're seeing in the United States and Europe, is really systematic use of TNT now for locally advanced rectal cancers, with response rates as high as 40 to 50%. So many of our patients don't even require surgery, are now being followed with watch and wait. But unfortunately, we do have a significant portion still of patients who have persistent disease or recurrent disease. And this is where the surgical approach obviously is very, very important. And we work in multidisciplinary teams. We follow the principles of the National Accreditation Program for Rectal Cancer. So very important to work as a team, obviously with our oncologist and radiation oncologist and pathologist and radiologist. So the surgical treatment of rectal cancer, what are the obstacles? How have things evolved? And the reason why it still does matter quite a bit is because we know that not every single patient is the same. There's significant variation in the complexity of patients. So you cannot treat the same patient the same way. So when you have a pelvis like this, and the tumor is about 7-8 centimeters from the anal verge, just looking at the pelvis, you don't need AI or an experienced radiologist to tell you that you probably will be okay. Whether you do this laparoscopically or robotically, you should be able to navigate through this pelvis. Things get a little bit more complex when you start to have a narrower pelvis, whether it's a male or female, definitely more complex in a male. But obviously, I'm talking here about those more complex cases when you have an obese male with a BMI more than 30, and you can see immediately, I put the scope in and I know immediately whether it's going to be a 4-hour case or an 8-hour case. So you look at this pelvis immediately and you know this is going to be an 8-hour case, especially when the tumor is 4 to 5 centimeters from the anal verge and the patient is desperate to avoid an APR. So this is a case where you know you're going to struggle, much higher rate of conversion, higher rate of positive CRM, positive distal margin, perforation, incomplete TME. So the stakes are very high. And this is where your surgical approach needs to be tailored to the anticipated difficulty of these cases. So this is where the robot has a big impact for the more complex pelvic dissection. But this is where I really strongly believe TATME is the way to salvage these cases. Even with robots, it can be very difficult to navigate through a fibrotic pelvis like this after TNT, and then to be able to achieve sphincter preservation and the perfect TME specimen. So we know the difficulties of navigating through the pelvis. We know the difficulties of getting even the robotic stapler below the tumor, especially when it's within 4 or 5 centimeters from the anal verge. The goal is to achieve this type of view, and it can be very challenging in some of the pelvises. These are the patients that I treat. 60% of my patients have BMI higher than 30. This is our practice in the US, in many places now in Europe as well. And I'm sure in India, you have no shortage of obese patients. But this is really the challenge when they have not responded to TNT. You have to find a way to get those patients taken care of properly. We know the data is reflective of the difficulties. We know all the randomized controlled trials around the world have demonstrated again that even in the hands of experts, the rate of APR remains high, 25 to 30% in the majority of the trials. High rates of CRM still 10% or above. Incomplete TME still a problem, and conversion, again, ranging from 10 to 20%, depending on who's performing the procedure. But this is probably the most important finding from the COLOR 2 trial, is that APR is driven very much by the height of the tumor. So when tumors are located within 5 centimeters of the anal verge, we know the APR rate triples or quadruples. And this is what my specialty has become, because many of the patients that I see have been told even by robotic surgeon that they need an APR because a tumor is abutting the sphincter, not automatically invading the sphincter, but abutting the sphincter. And they already calculate in their head that they cannot get below the tumor using the robotic stapler. So they are preparing the patients for permanent stoma. So even in most recent Korean trials obviously show much better data. You can see that with experience with robotic TME, the results are looking better than the ROLAR trial. You can see here that the conversion rates are dropping significantly. APR rates also are dropping. But I want to alert you to the fact that as opposed to the European and American trial where 23% of patients had a BMI of 30, in the Korean trial, none of those patients had a BMI of 30. So they're dealing with much smaller patients. So they are not tackling the very narrow, complex pelvis in high BMI patients. So you have to be very careful when you look at the data. Even looking at those videos, you know that they're not dealing with the same difficulties that we deal with in the obese male patients. So that's something to keep in mind. So why transitional TME? Transitional TME evolved from notes when we're really working very, very hard in the lab to try to develop techniques to perform transvaginal, transgastric, and eventually transrectal complex abdominal resections. We really realized that we were very lucky for transitional surgery that we had already a commercially available transitional endoscopic platform developed by Professor Bruce, and we were able to access the rectum, achieve excellent visualization of the distal part of the rectum, and go through the wall of the rectum to dissect the rectal sigmoid. And we had this proof of concept in cadavers. We worked backwards to develop this technique and flush it out further using pigs. And we worked very vigilantly then to return to the preclinical cadaver model. And eventually we're able to demonstrate that combining abdominal and transitional dissection was able to yield very high quality TME specimens. And this was the first case that we performed in 2009 in Barcelona in combination with Dr. Lacey, which was quite successful and very promising technique for rectal cancer. So notes was the inspiration behind this, but we had a lot of work to do subsequently to demonstrate the safety and to train surgeons, rectal cancer surgeons, in this approach, and a lot of work and a lot of collaborations around the world took place to try to develop a standard training pathway that involved cadaver lab training, didactic lectures, and especially proctoring, because anybody who has done transenal TME knows how difficult those cases can be, and the skills and experience of the surgeon is the most important, and these are very difficult procedure to learn to do. So this is the concept for TA-TME. Again, you have a low rectal cancer that you know you're going to have difficult. This one is not threatening the sphincter, but it's close to the sphincter. This is the best case for the learner when the tumor is above the inner rectal ring. You can place the platform of your choice. You achieve excellent visualization of your distal rectum and your tumor. You can start by placing a purse string suture. You occlude the rectum below the tumor, so you achieve your distal margin from the get-go. And then you go ahead and do your dissection through the wall of the rectum until you reach the endopelvic fascia. And then you continue with your TME dissection from the bottom, and then you eventually connect from the top. This is the most complex cases. This is the majority of the cases I do when the tumors are literally abutting the inner rectal ring, sometimes even invading the internal sphincter, but the intersphincteric space is still clear. So you can start your dissection with a Lone Star or anal retractor. You find your tumor, you go into the intersphincteric space, you perform a little bit of intersphincteric resection to get your distal and circumferential radial margin taken care of. And then you can do your purse string occlude and then start placing your platform and continue the TME dissection from the bottom. So this is more complex. As you can see, it does require experience with intersphincteric resection, which many surgeons do not know how to do. So this is a #1 prerequisite for TA-TME, is to be familiar with this technique before you start to tackle these very low rectal tumors that threaten the muscle. This is a nice perspective of why TA-TME is so useful, because everything is in line with the tumor as opposed to coming from the top down, where these angles can be very difficult to navigate. From the transenal approach, particularly the anterior dissection is much easier than when you're struggling from the top. Posterior, the angle of the sacrum can be difficult to navigate from the transenal. So I always have the abdominal surgeon actually go as far posteriorly down as they can with a robot or with a laparoscope. And then I do most of the anterior dissection from the TA-TME. So it is truly a hybrid approach where we combine techniques and technology to be able to do these cases safely. The danger point for TA-TME is to go too anterior. If you go too anterior, you can actually put the membranous urethra at risk and injure the urethra. So it's well-known danger point of APR, but also of TA-TME if you're too high up. And I'll show you some videos to show where that danger zone can get you in trouble. So this is the anatomy that the learner has to learn very quickly in a cadaver, is understanding the anatomy of from the perineal perspective. You have to be able to, when you've gone through the rectal wall, to recognize this very important landmark, the puborectalis elevator muscle, the endopelvic fascia. You have to recognize the back of the prostate or vagina. You have to really recognize the neurovascular bundle. If you're too lateral, you can enter them. I'll show you a picture of this. This is a neurovascular bundle. So we've gone through the dissection here. And if you're too lateral, you can injure this structure. So you have to be very careful not to go too lateral on the pelvic sidewall and really correct your dissection to stay more medial. If you're too deep to the endopelvic fascia, you can expose the hypogastric nerves and injure them. So you have to learn to stay just above the endopelvic fascia. You can see here we were too lateral. We're exposing the pelvic plexus. Very dangerous. You have to be very careful. The case I just did yesterday actually was an anterior tumor. And actually one nice thing is that I was able to titrate the depth of my dissection of the prostate and stay just above the non-villus fascia to ensure a negative circumferential radial margin. So again, you have to master the anatomy, really get an understanding of the anatomy from the bottom up approach. It's a very different perspective. And so it does require a long learning curve. The most important structure after this to understand is the rectal urethral muscle. This is a muscle that we routinely transect during APR, but we don't see it. We kind of, did not even really know that it existed until recently. And this muscle is very important because that's a muscle that separates the urethra, the urethral muscle, a sphincter muscle to the rectal wall. This longitudinal muscle must be divided in order to access the plane between the low rectum, mesorectum, and the back of the prostate. So I'll show you videos to show that structure. And the reason it's important is that if you don't recognize it and think it's rectal wall, if you go too high, that's when you can drop the prostate and damage the urethra. So these are the landmarks. I'll just show you quickly a video. This is sort of your best case scenario. This is a perfect case for the learner. Somebody is learning. You can see here as I'm pulling, I can see the inner rectal ring is below me. So I don't have to worry about the sphincters. I can just worry about getting full thickness from my rectal wall. which I'm doing here. You can see once you've placed your platform and you insufflate, you have very, very good visualization, especially if you use a smoke evacuator and a high flow insufflator. We're going through the muscle here of the rectum. You can see very controlled, very excellent exposure here. We're already starting to expose the bottom of the mesorectum. You can see here, the levator is coming into view. I'm literally dissecting the posterior and lateral mesorectum off the levator. You can see here, right here. And with my hand, I'm just retracting the rectum and getting into that perfect exposure. Anteriorly, again, you have to be careful. If you're low, you will find the rectal urethral muscle and dissect it. Here, I'm above the rectal urethral muscle, so I don't have to worry about it. But you can see as I'm transecting the rectal wall anteriorly, I'm going to enter very quickly the plane between the mesorectum and the back of the prostate. So you continue dissection, you keep ascending anteriorly, cephalad. You can see here, we're dropping the pelvic plexus here, we're staying more lateral, dissecting the mesorectum off the pelvic sidewall, making sure not to go too lateral to injure those nerves. And here you can see I'm using an angled hook, but there's multiple tools you can use to do this. Posteriorly, easier when you found your endopelvic fascia, you stay above it and you just dissect very elegantly your posterior mesorectum. Anteriorly, you can see here, we are approaching the perineal reflection. We have excellent visualization. You can see the beautiful anterior mesorectum here. And then the abdominal team is just coming across. This is at this point, we call it the rendezvous. We connect the anterior, above and below plane under direct vision. This is something that we like to do because you see both views from the top and the bottom, and it really helps you guide your dissection. At this point, you can switch to bipolar ultrasonic energy to facilitate the procedure. And this is what it looks like. This is the pelvis, obviously, that you want. You can decide to extract either transanally if the pelvis is not too narrow, or transabdominally. Here we did a lower midline because the specimen was so bulky and we didn't want to disrupt the mesorectum. You can see it's just pointing out there's a tumor deposit here, but big bulky specimen in a obese male. When you're done with this more easier cases, you're ready to do your more complex cases. These are routinely the cases that I do now. The lower tumors abutting the sphincter. This is a tumor that's 4.5 centimeter from the anal verge. So you do have to start doing your intersphincteric resection first, which you do with your anal retractor. And again, once you've achieved at least 2 centimeter dissection along the intersphincteric space, you can see we see the levator. So you have the open view of the levator. Now I'm finally closing my rectum below. You can see a very narrow pelvis. This is a typical obese male with a very narrow pelvis. We don't have a lot of room to navigate. I have a different type of platform here. That's a TAMAS platform. And here, I want to point out the rectal urethral muscle. You see this little pinpoint bleeding? That's the back of the prostate. I just divided the rectal urethral muscle right here. Key is not to go up here. That's the danger zone, is to go too high, heading towards the apex of the prostate. You can see here, you have to stay very close to the rectal wall, very close, divide the rectal urethral muscle and stay just in that perfect plane. You can see the very narrow pelvis of the male here, but as I'm dissecting and making room, especially with the insufflator, you can see things are going to start to open up. Finally, I just found the endopelvic fascia, the back of the beginning of the mesorectum, very beautifully identified here. And again, you have to be patient. You have to open up the planes until you can finally start to navigate more comfortably. And then you can continue dissection. You can see here, laterally, I'm going to be connecting again with my abdominal surgeon, has gone as low as he could. He's actually very well, you see, he went all the way down posteriorly. So we're just connecting the dots here under direct vision. Again, as I said, the anterior exposure is excellent with this approach, but the teams can work together to facilitate this procedure and expedite the procedure. So the other complexity, and this is where TME can be very helpful, is, as I mentioned, that a lot of our patients are getting TNT now, just like the case I did last night that kept me up until 2 o'clock in the morning. Our patients come in after they have had recurrence after TNT. So this patient, for example, had a very low tumor, failed TNT, had a recurrent disease, essentially, and unfortunately, was already 12 months after radiation therapy because he had radiation first before consolidation chemo, which is the OPERA trial protocol. But as a result, you can see the degree of fibrosis is incredible. So we see these cases now where there's tremendous pelvic fibrosis that extends all the way to the anal canal. You can see the tissues are so much more rigid. There's no flexibility. The planes are obliterated. These cases would be very difficult abdominally anyways. I mean, the pelvic is completely frozen from the fibrosis. And this is where having some assistance from the transanal side can be very helpful. You can see here the dissection is very different than what I showed you. very, very difficult planes. You see there's just no give in the tissue. Everything is fibrotic. You have to really take your time with those cases to try to stay in the right plane. It takes a lot of experience to really understand where the rectum is. But again, I just want to point this out because I see all these pretty videos of rectal cancers, but they don't show these difficult cases when you have unbelievable fibrosis from the radiation. And these cases are becoming more common because of the increased adoption of TNT. And we know, many of our patients will not respond, and you will have to deal with this. So what are the results? I just want to skip this for the sake of time. But this is, again, another example where when you have a very difficult case, you can see this is one of my colleagues who's a very experienced laparoscopic surgeon. The tumor is at 7 centimeters. It's not even that low, but the patient has a BMI of 40. And you can see here, he's struggling. He's struggling very much. At this point, he's about to, he exposes a seminal vesicle. You can see he's below the prostate. He has 6 trocars. He's trying to get below the tumor, and he can't. He's really struggling with exposure. Maybe you could get lower with a robot. I don't know if the robotic surgeons can comment. He's scoping the patient now and realizes I still have at least 5 centimeters to get below this, and he cannot expose. So he called me in to help him salvage this. This is where we call salvage TATME, where you go in to essentially assist a surgeon to get to the distal margin. So that's what I use, the exact same technique I showed you. So as he's continuing the dissection, I'm trying to come to rescue him to do the distal portion of the mesorectal dissection. You can see I don't have to dissect very much. I pretty much connect with him after about 4 or 5 centimeters. You can see here, not even 4 centimeters of dissection, I'm able to connect with him. But that will really allow him to avoid conversion, rectal perforation, an incomplete TME. So this strategy is very, very helpful to salvage a difficult TME when the surgeon is considering conversion. And this is when you want to be able to consider this approach. So other techniques and learning, because we talk about the why and the how, is again, you have to really master the skill set. You have to master the skill of placing your distal purse string. If you're going to do a staple anastomosis, you have to master the skill set, which is what we have to train surgeon to take these good quality bites. You can visualize it from the bottom. If you have a difficult time doing it from the bottom, you can see the abdominal team can assist sometimes. But the majority of the cases I do hand-sewn because the tumors are so low. We're usually within 4 centimeters, so hand-sewn anastomosis is preferable. But if you're higher, you want to do a staple anastomosis, double purse string, double staple anastomosis, which will require you again to master the skill set. So there's a lot of tools out there. This is the exciting part about TATME around the world. Wherever I go, I see the surgeons and creativity. Lots of devices. This is actually a very popular TAMIS equivalent platform in China that costs $15. It's very, very cheap. And so you see a lot of these cool devices now being developed to facilitate this procedure. I just want to focus on results of TATME. So we have now over 10 years worth of data, mostly from this very large TATME registry that has showed excellent results overall, low conversion rates. Obviously, we have been monitoring complications. We know there are complications, especially we talked about urethral injury, but the incidence appears to be about 1 to 1.5% worldwide, which is very important. We still get leaks. We still get ischemic conduits. The learning curve is long. As I mentioned, when it's been measured, we're talking about cases, 45 to 51 cases before the complication rate goes down or the operative time goes down. The most important data about TATME from this very large series shows, again, the conversion rate being less than 5%. It's the most exceptional finding of TATME is the incredibly low conversion rate. For the very first time, we consistently have a procedure here that shows consistent low conversion rates with this approach, which is very important with acceptable morbidity and mortality. Obviously, the most important outcome is oncologic outcomes, and so far so good, at least in terms of the quality of the TME and in terms of the rate of circumferential margin. The big dilemma has been about Norway data that showed a higher rate of local recurrence. That's been a concern worldwide, is to confirm that the local recurrence rate is not higher than with a laparoscopic TME. And if you look at the data coming from Norway, a lot of it had to do with the learning curve and the fact that a lot of those patients had positive margins. So it's very important to take the learning curve into account. But if you exclude the study from Norway, the local recurrence rate is acceptable in the rest of the World Series. Local recurrence rate, as I mentioned, really correlates with experience. So this is where, when the sites look at the results over time, based on the level of number of cases that they perform, you can see a significant correlation between local recurrence and number of cases performed. So the learning curve, again, needs to be overcome to have the best possible results. So in conclusion, we really strongly believe that TA-TME plays a very special role for the low rectal tumors. This is where you can really avoid APR in cases that are eligible within 5 centimeters of the anal verge, especially if you combine this with intrasphincteric resection. Functional results obviously are a problem, but these are patients who are highly motivated to undergo sphincter preservation. I just want to raise the awareness of this issue of radiation fibrosis and the hostile pelvis. But I also want to mention that the data so far shows excellent conversion rates compared to laparoscopic or even robotic TME. That we can really salvage very complex patients, as I mentioned, post-metastasis patients, re-op, redo patients, and still be able to achieve excellent results. And this is the reason we love TA-TME, is because at the end, especially after your open dissection, you can achieve really high quality specimens, really beautiful specimens with negative margins. And this is the reason that we really believe in this approach. So what's new in TA-TME is the fact that we're continuing to gather data, especially the randomized control trials have been long awaited. We finally have the first 2 randomized control trials that were published this year alone. The one from Spain was a smaller one, 55 versus 50 patients, TA-TME versus laparoscopic TME, very carefully selected, obviously. BMI was decent, 26.2. And you can see here again, first time in the randomized trial showing the lower conversion rate with transanal TME compared to laparoscopic TME. That was significant. And at 39 months, you can see actually a better results with local recurrence with TA-TME than laparoscopic TME. So this is very important, very good data. And of course, everybody's talking about this paper from China. Professor Kang just published this a few months ago. Very incredible results, over 500 patients in each arm across 16 hospitals in China. And you can see, obviously, these are early results, but very good results. The only caveat is that you can see the BMI was only 22.9. Again, not the same patients as what we take care of, but I think still pretty good proof of concept and safety of transanal TME. Conversion rate was very 0% compared to 1. Obviously, 1.1% is very unusual, but again, it has reflection of the BMI of 22.9%. But you can see excellent results in terms of the quality of the TME. Complication rates were equivalent. There were no other significant differences between the two. I don't have a lot of time, maybe 5 minutes. We just recently published or submitted for publication the results of our phase 2 trial in North America. We really were eager to confirm the safety of this approach in the US and Canada. So we assembled a team, 11 centers across the US. We enrolled 100 patients. Because of COVID, it took us 5 years as opposed to 2 years, but we're able to get this done. And I just want to show you the results. So we were focused on the quality of the TME. We also had a very strict QA and quality control mechanism to confirm the quality of our TME. We had secondary review of our specimens to confirm whether or not the specimen was complete or near complete or incomplete. So we had a central review of every single specimen photograph to confirm the quality of our TME, which was very, very important to avoid major discordance in the grading. And these are our results. You can see here, and this is very important, in the North American cohort, you can see among the 100 patients, 70% were male, 33% had a BMI higher than 30, which is really a reflection of the patients that we take care of. And you can see 67% of our patients had tumors 6 centimeters or less. So clearly this is a selection bias. Most of the patients that come with this type of tumor, male, BMI of 30 or more with a tumor that is that low, TA-TME is the way to go. That's reflected in our TA-TME centers. You can see 54% of the patients required a Hanson anastomosis, partial intrasphincteric resection in 36%, again, reflection of how low the tumors were. 100% of patients get a diverting ileostomy. We do like drains in America very much, but this is the most important data, 3% conversion rate. So this is confirmed. And the conversion was due to abdominal complication, ischemic conduit and bleeding. We had some injuries, but no urethral injuries. Our complete pathological response rate was 25%. And you can see here, most importantly, and this is validated by secondary review of the specimens, we had complete in 69 and near complete in 21, which gives us a rate of complete and near complete 90% and a rate of incomplete in 10%. Only 2 patients had positive margins. The postoperative outcomes were good. We did have a significant number of ileus, and urinary retention was pretty significant, 19% urinary retention. Fortunately, this resolved in the large majority of patients. Very important, our anastomotic complications that we tracked up to 90 days was 18%, 10% at 30 days, 18% at 90 days. But we did follow these patients through. The majority of those patients with leaks were managed very aggressively early or later, underwent redo colonial anastomosis when the leaks were severe. And as a result of that, we had a 98% rate of stomach closure by a median of 5 months, which we're very happy with. That really shows you the surgeons being very aggressive in managing their anastomotic leaks. So yes, the leak rate is high, but if you manage them aggressively, especially early, it results in stomach closure in the large majority of patients. So I will stop here and thank the audience for the opportunity to present our work on transanal TME, which we think still plays an important role in the management of low rectal cancers, especially in the era of TNT. Thank you very much.
Patricia,
Oh,
and
thank
my name is Taha. I don't think you remember 2016. I was a fellow there in, and you trained me in Boca Raton when we were training on that bovine model
Amazing.
for TAMIS.
Fantastic.
So
Nice to see you.
Yeah, and I still remember your teachings, and I started doing TATME, and we are registered with the TATME registry as well. So it's excellent to see someone at least who's doing TATME in
That's
this hall.
wonderful.
Yeah, and I just wanted to ask, where do you stop anteriorly and posteriorly from the
Yeah.
abdominal side when you are doing the resection?
Yeah, so now I routinely tell my surgeon, my abdominal surgeon, go as low as you can posteriorly. And then anteriorly, you go until it becomes very hard. I get nervous when they go below the perineal reflection, unless it looks, they have great exposure and they're doing very well. They usually stop. Like yesterday, he stopped literally at the perineal reflection, didn't even open it because it was so fibrotic and the tumor was anterior. And he did posteriorly, he went as low as he could, which was pretty good. So I think the best approach is go as low as you can posteriorly because you still have pretty good exposure, and then anteriorly you stop when it gets difficult, and that's when the transanal dissection is initiated. And I think that's important because remember, in the old days we used to say, you need to do as much as possible from the transanal side. That's not true. You really want to truly combine the abdominal and the rectal side. This is not a competition. It's essentially trying to get the job done as safely as possible without any damage to the mesorectum.
Absolutely. And do you preserve left colic or do you take IMA always at the origin in these
Yeah,
cases?
IMA every time. Every time.
Every time you take it at the origin.
Yeah, that's the first step that we do. The IMV, we also usually take it because you find those cases for the colloidal anastomosis, you really need all the length that you need. You need all of it. You need splenic flexure is almost, as you saw in the series, 94%, we take the splenic flexure down. But I know in some patients you may not have to, but the IMA, we take it every time. Do you preserve the left colic?
I had leaks, so then I started preserving in a couple of patients, and I did not have leaks. The length was good. I did do a inflation takedown on all the patients.
Yeah.
So in mostly where I do it for benign as well. So in benigns, I always preserve.
Yeah, that's actually interesting because we just did a review recently, and you're right. Taking the IMA ligation versus preservation doesn't have an impact on leaks. So I agree with you. I think we tolerate 18% leak rate because of all the other risk factors. It's like which one matters the most, who knows? But I think the concern has always been, lymph nodes and having, unsuspected IMA nodes. But you're probably right. I'm sure preserving the left colic should be just fine.
Absolutely.
Thank you, Patricia. And one question: what percentage of surgeons in the United States of America are practicing TATME?
Very
and
few.
where you see them going? You think in near future it is likely that more surgeons will adapt, because in India and this part of the world, very, very few people, I would say less than even 1%, people are adapting to this technique.
Yeah, we're seeing the exact same thing. They started with a big group of people wanting to do this to now a very, very narrow. As I showed you on the map in the US, there's really only pretty much 11 to 12 centers in the United States that are routinely doing TATME. And, I think to me, it's a reflection of the skill sets and the training and the experience, and it's not a bad thing. But you're right, I worry about training the next generation, because now our training model is, if you really want to learn TTME, you have to take 6 to 12 months and come spend time with us. So those surgeons have to do their training and come for an extra year to train with us so that they can do 1 or 2 TTMEs a month. And so it's a big commitment. So unfortunately, I agree with you. It's not going to scale. I think if we can do anything, is having several centers in our countries that specialize in those cases and refer patients to those centers. And we get criticized because we get told only the rich patient can go, right? Not the regular patients. But this is a nature of advanced cancer surgery, just like pancreatic cancer or any other type of cancers. These are the most complex ones, so they require going to complex advanced centers of training.
How would you react to a statement if I say that at this point of time, TATME in really expert hands like yours may have benefit in a very, very small percentage of patients over what we do conventionally, robotically?
I would agree, because if you look at the numbers now, if you told me which patients do you really believe TATME makes a difference, and that's what we discuss at our tumor board now, I would say it, especially with TNT now. So if you take the big pool, and we should probably work as a community to kind of put this algorithm together, it becomes, the pool of patients is going to get TNT. Only what, 40% are going to respond, 60 are not going to respond or have a recurrence. Among those 60, how many of those have a tumor that is within 6 centimeters from the anal verge with a BMI of 30? So you see that it's starting to funnel down to really a small percentage of patients. But these patients, as you know, are anywhere between 25 and 45 years old these days. Okay, so these patients are not interested. Even when you talk to them about APR, they would rather die. You know what I'm talking about. They would rather die or not get any treatment at all, any surgery, than having an APR. And there's no reason why they should get an APR if you have a center of expertise. So I agree with you. It's a small proportion of patients, but it's a very important, contribution to society. And I think we need to be able to provide that ability for patients.
I agree. Any comments from Dr. Rao? Dr. Kalyasaran, Somitro, yeah. You can come here. She can see you from here. This is Dr. Kalyasaran, very senior surgeon, heading one of the GI surgery units in teaching hospital.
Excellent talk, Professor.
Thank you so much.
Yeah. My question is, because the 2 trials which you have shown were comparing a TATME with a lab. So are there any trials comparing robotic approach with TATME?
That's exactly what I said. It's funny because when they started to put the Color 3 trial together, we were already starting to see an uptrend of rectal cancer with robotic TME, and we said you need an arm, for robotic arm because it's evolving. But this was several years ago already, so we don't have one. Unfortunately, not a randomized trial. There's a multi arm cohort study comparing open laparoscopic and robotic. But it's going to be very difficult, to really compare, because as you can see, even for us, we did not want to do a randomized trial because we were already biased for the tumors that were that low. You saw the numbers. We were biased to offer TATME. We didn't feel good about offering laparoscopic because we knew the conversion rate would be too high. So it's very difficult now if you think about doing robotic too. So we have a small study now that I'm running that was sponsored by ASCRS, where we're comparing non-randomized fashion robotic to TATME, and we picked conversion rate as the endpoint, but I'm not sure it's a very good endpoint because my robotic specialists don't convert very often. But what they do when the tumors are 6 centimeters from the anal verge, they will all tell me we go very low and then we stop and we go from the bottom and we do a little transenal dissection to connect and do so what is that? What is that? You don't have to call it transenal TME, but it's transenal assistance. And so I think that's great. If the robotic surgeons are prepared to do transenal assistance so that they can disconnect from the bottom and be able to do a hand-sewn anastomosis, that's all that we're asking for. We're just asking surgeons to be prepared and experienced to do some type of transenal dissection. And the fear is the ones who don't know how to do transenal dissection to then commit the patient to an APR. So whether you call it transenal TME, transenal rescue, or transenal assistance, we don't care. As long as you're comfortable from the bottom and you're prepared to do a little bit of the mesorectal dissection from the bottom to connect the 2 planes, I think that's what the patients need to be offered.
Thank you. Thank you very much.
My pleasure.
Thank you very much,
sorry,
for joining us.
I'm hoping next time I will be in person. That would be the
Yes,
most
we would love to have you
satisfying
here.
experience.
Most likely in October 24, I will write to you.
That would be incredible. I would love that. I might.
Thank you so much.
I was in Pune. I was in Pune for a meeting maybe 8-9 years ago. It's too long already. Thank you
Thank you
very
so
much
much for joining
your
us.
patience.
Thank you.
I really
Have a nice
appreciate it.
day. Thank you.
You too. Bye-bye.
I think with this, we conclude today's session, and we will see you tomorrow morning sharp 9 a.m. again. Thank you so much.